important. You want to, I want you to check on this patient, which is the discussion for the next session, is epithelial profiling. Epithelium in thyroid changes a lot.
Absolutely.
And because there is a huge amount of changing in the ocular surface, you're an ocular surface person. So when you have an ocular surface, the muscle can get hypertrophied. When you have ocular surface getting changes, your epithelium also changes. So what happens is sometimes the epithelium changes by 30, 40 microns. So 30, 40 microns of epithelium means that your regression is diopter or two diopters. So in thyroid, it's just not a biomechanical change, it's also changes in your way your epithelium remodels. So take home points from this case, very beautiful case is one, yes, you need a thyroid profile in it. And the second one is please do an epithelial profiling in them to do it. And the third thing, which I think Samresh will answer, is a lot of thyroid patients go through a lot of emotional turmoils. So they have a lot of internal lenticular pseudo accommodation. So that means that you need to pick it up from the eye trace. Am I right, Samresh? You are.
I think that's a great point, sir. For a patient like this, aberrometry is a must. Sometimes these patients may be accommodating, for all you know, they may be in accommodative spasm. So you need to know the job profiles. These are the patients I would try to do a cycloplegic refraction for at all points in
Yeah.
time.
So these
And
these are all done, cycloplegic refraction done, and it's, at least on the cycloplegia, it's not there the
So what
accommodative
happens,
component.
Sheetal, is, I think this is a very important case. I think we'll stick to this case is only for discussion for time now. In case we have a time, second case I'll squeeze in because it's very important what you brought in. One is your patient has thyroid related regression, so you need epithelial profiling. Thyroid related patients suffer from a lot of emotional trauma,
Right.
emotional issues. So it's not just cycloplegic, your eye muscular movements, orthoptic changes a lot. That means patient may suffer from lot of convergence insufficiency. That means they don't converge well, but they're excessively, they will be having issues in the internal aspect of it, or they suffer from something called as fusional divergence issues. There's a fusional issue plus a convergence issue, which is not usually picked up by a routine refraction or cycloplegia. A cycloplegia can't, it only
Correct.
has to be picked up by these prisms and all that stuff
Mm.
there. So, and the third thing is the epithelium, which we mentioned. All these three factors play a very important role in understanding your patient, whether this patient had a thyroid-induced biochemical change, or it was an epithelium which changed by 30, 40 microns, or it is. So next time the patient comes, just ask for it. 99% of thyroid patients suffer from emotional issues, and that itself changes the orthoptics a lot. Okay.
Rohit,
Also, does CXL prevent further regression?
See, if it is not related to the biomechanics of this, CXL is not going to do anything. In fact, may cause more harm.
Okay.
Because what you do is, if an epithelium is hypertrophied, that means that ocular surface, you are the best person than me to answer this. Ocular surface is inflamed. That means don't do anything before you look at the epithelial maps. If the epithelial map is 70 micron thickness, that means that epithelium is having a lot of changes there. So if you do a CXL, this patient will have a 200 micron dense scar because you are burning the cornea on a very inflamed eye. And that itself will be a very, very difficult thing to manage because thyroid itself causes scarring because of the way the inflammation is.
if I can
So,
go ahead. Rohit.
and then,
Rohit,
yes, sir.
sorry.
Yes,
One
sir.
question here. Then, if the thyroid is well controlled, if it was initially not well controlled and then it gets well controlled, takes say 2 months, what happens to the changes in the cornea biomechanically? Everything else changes, goes back to what it is, or it remains the way it is supposed to be?
I personally believe, sir, biomechanically, thyroid hormones has no direct link on the scleral collagen. It's, I mean, we there are some anecdotal report, but there's nothing which really changes the thyroid hormones to the biomechanics on the corneal plane. So that's something which is very, very. So my gut feeling here is Sheetal's case is one. I think it's an epithelial change which is changing, or a very, very subtle orthoptics change where the patient is having either a convergence insufficiency or a fusional issues. These two things can change your myopia by around a diopter or 2 diopters, which may mimic that it is related to your change. So both of them don't need cross-linking at all.
Also, Dr. Sheetal, you mentioned that the patient has PCOS before.
Yes.
So these patients already, if a prior cycloplegic refraction has not been done while correcting for the refractive error, maybe the the total refraction was not corrected in the first go itself.
Yeah, but actually all these problems started post-pregnancy. The Lasik was done 10 years back and the pregnancy happened 3 years back. So in between she was good for 7 years.
All right. Okay.
Anyway, brilliant case, Sheetal. I think we'll move to the epithelial maps, and I will see if I can put your.
Mao, can I just make one point? So I think wonderful case. I mean, it's a very good case for discussion. So I think definitely, I think from cycloplegic is one of the most important first thing what we need to really do, and definitely orthoptic exercises or evaluation is important. But sometimes, you know, one of the most basic things sometimes we can forget is maybe one of the possibility is the power wasn't stable at the time of surgery itself. A lot of surgeons, you know, sometimes just go ahead and they don't assess the stability. So that is also one thing what we need to keep in mind. If at all we do have the axial length pre-op, we can just, you know, compare the two and then try to look at it also. And definitely the lens densitometry is very, very important. There is a chance, you know, in these very high myopes, they can develop early stage of cataract, and that itself can be contributing to the change in refraction. So we need to keep a close eye on the lens also, which can be easily missed out in the slit lamp. And this is where the eye trace or even the pentacam, where you can look at the densitometry and even the early changes, you can just pick it up very quickly.
Great point, Naren. Even I was thinking that my gut is it could be the lens.
Yes, sir.
If you look carefully.
Definitely.
Yeah, precisely. That's the reason I think I just stopped with the first immediate management plan which I had made, and now planning to do a lot of things which has been suggested, and then see what actually works out better for this patient.
Eye trace and axial length are the three most important thing you need to look at.
The only problem with the axial length and all is we do not have her previous things. It was done 10 years back and she doesn't have it.
Lens and orthoptics. Epithelium, lens, orthoptics. If you do three, your culprit is one of them. That means that is not going to, CXL is not going to help you. In fact, it may worsen the whole issue. So I think we'll move on to the...
Rohit, I'd just like to add one point. I think the lens is cropping up again and again in all the conversations. And I'd just like to confess, two of my senior ophthalmologists in my team, I did a DLI and it was rated at 4.5. And I was amazed. And they were 6'6" and they were operating daily. They were doing 8 to 10 cataract surgeries, oblique Lasik surgeries in their daily life. And when subjected to cataract surgery, they self-confessed that their life is transformed. So we need to look at the lens quality. It is, I think, in the present days concept, just looking for a structural or an opacity or some hydrops within the lens or the posterior subcapsular capsule is passé. I think it's old. We need to look at the patient optical quality. I think it's coming up again and again in the discussion.
Fantastic. Take home point, both the talks is the lens. We have two small presentations, one on epithelium and one on the tear optics. We'll finish it in 10 minutes and then we move to the IPCL and ICL, which is again a very, very hot topic today. Dr. Krati, can you just share your screen, please?
Yes.
Are you ready? You can present, and after that we'll have the tear optics from here. It's a small presentation, and Dr. Krati Gruta is a corneal refractive surgeon with us, and she does a lot of work on optics with me. Her area of interest has been epithelium and biomechanics. That's the core area of her work. And Dr. Krati, all yours.
Good evening, everyone. So I'll be talking on epithelial maps. So the current diagnostic modalities that we use in the preoperative screening for refractive surgery and keratoconus diagnosis are the topography and the biomechanics. But the question that I have is, are they enough? The literature review has shown that epithelial mapping significantly impacts the safety and efficacy of refractive surgery and also allows for significant improvement for the therapeutic procedure. There are multitude of devices available for measuring your epithelial thickness in the market, and I shall be talking about the MS39, which is a Placido disc plus OCT-based hybrid topographer. So apart from measuring your corneal thickness, your curvature, and the power of your cornea, MS39 gives you the epithelial profile and the stromal elevation separately. So this is one of the key features of this machine. So most important application of epithelial mapping in our refractive practice is very important to rule out your form prostate keratoconus. So I shall be discussing this in form of few case presentations. So this was the first case of a 26-year-old female who came to us for a refractive surgery opinion. As you can see, her axial map shows some amount of inferior steepening. However, there was no anterior elevation. Some amount of posterior elevation was noted. Bad D was normal, and the biomechanics were also normal. So we went ahead and did an MS39 map for this patient, and we found that the area of epithelial thickness on the epithelial map of the MS39 coincided with the inferior steepening on the pentacam. And the patient also did not show any stromal or posterior elevation. Thus, a subclinical keratoconus was ruled out, and this patient was planned for a refractive surgery. Similarly, this was a second case of a 27-year-old female who also came to us for a refractive surgery opinion. On her axial map, you can note that there is inferior steepening. Her bad D is borderline. CBI and TBI, which is the biomechanics, are normal. Moving forward, we did her MS39 map, and we found that the epithelial irregularity was noted on the epithelial thickness map, which coincided with the inferior steepening on the pentacam. She did have some amount of posterior.
Just 1 minute, Kriti, if you can go back, just hold on to this. If you can go back to the previous slide, this is very important for, many of you are not regularly using the biomechanics in this group because they're all cirrus kind users. The biomechanics is always been debated as a very, very difficult tool to analyze. That's because that you think that in this case, when you grossly look at it, a 48 diopters and 45 diopter mean that this is a keratoconic eye. It should not look normal at all. But look at the biomechanics. I'll not go too deep into this. Probably I'll have time later. All in green means your biomechanics is perfectly normal. Now, people who are who hate biomechanics as a tool for refractive surgeons would agree, would debate here that this is a true case where biomechanics is useless because I can see clearly that there is a problem in the corneal topography. But when you look at the epithelial map here, next slide, you know that the problem is biomechanics was actually telling you the truth. The biomechanics is stronger. It is your epithelium which is making it look, it is wearing a cloth of a devil there. When I see this kind of epithelium, I call it cloth of a devil because it's a devil which is making it look like a devilish thing. And this patient is completely normal, even though it looks like a thing, and you keep moving. And so it is very important. Epithelial map is a very, very important clothing on the cornea. The way it fits your cornea makes everything looks normal or everything looks abnormal. So there has to be a form of a refractive surgery where epithelial map has to be part and parcel of your daily practice. Like earlier we used to say, okay, you have to have a topography as a part and parcel. Now you have to say that you have to have an epithelial map as a part and parcel. So keep moving, Krati.
This is another case of a 22-year-old female who came for refractive surgery. Now, her axial map shows some amount of inferior steepening. She does have some amount of anterior and posterior elevation. Again, her biomechanics are fairly normal. But if you look at the epithelial map, it shows an area of central thinning surrounded by an area of epithelial thickness. Now, this resonates well with the epithelial thickness profile in keratoconus as described by Dr. Reinstein et al., wherein it is donut shaped, displaying an area of stromal thinning at the cone surrounded by a rim of thickened epithelium. So, regarding this case, I would like my seniors to give their comments.
Basically, what happens in this case is you have a very, very early sign of epithelial map going towards keratoconus. This is a epithelium evolving into a keratoconus picture. So that is why your biomechanics is completely normal here. And I will show this case in much more detail in my presentation later half, because we did some very nice imaging on this. I think you can stop sharing this here, Krati, and we'll move to the tear optics, the last part of this session. And before the other presenter comes, anybody had anything, Dr. Rishi, want to add anything to this cases which he presented, where epithelium is fitting, the epithelium is dressing up the cornea is completely irregular in many places.
I think those examples are perfect to show what an important role epithelium plays in hiding or masquerading as an ectasia. And unfortunately, both these situations do exist, and we have to select our refractive patients carefully. So like you perfectly said, epithelial thickness map has to become part of our pre-refractive evaluation mandatorily. And the day we can do that, I think with the new machines like MS39, that will be great.
In fact, what I believe is when we say that, this machine, that machine, people say that, oh, I'm going to invest on machines, I'm going to lose money. In fact, all these machines have made my refractive surgery go by around 10 to 12%. iTrace helped our cataract department to grow by some percentage. Epithelial maps, in fact, I would say, has increased my practice by around 18 to 20%. All these patients, I would never touch those patients. I would call them as
absolutely.
Yes, absolutely.
And so when you are, I would like to tell everybody, when you are investing on something, you're not investing on to reject somebody. You're investing on something to do something different than other conventional ophthalmologists who would just reject.
True.
People say that, you just take up all the cases. I said, yes, because you have to really look at it. If your epithelium is kindly, nicely creating a blob-like thing inferiorly and creating an inferior, I know it's an epithelial issue. You do a trans PRK on them, you are done. You are taken care of everything.
And
You are actually giving the patient, you are earning money, and you are actually giving a patient the better side, and you are actually earning for the machine. And if you do 20, 30 cases or 40 cases, you'll probably earn, you'd pay off the machine's cost.
Rohit, just like to add one thing here. I think every time you say these things, I feel, there's such a beautiful harmony in what you say and what science and what intuition says. As a regular practice, we've started incorporating epithelial maps in my refractive surgery. And the amount of people we are taking in has gone up rather than rejection. So I think it really helps to take up the right cases. And these are the cases, if you take up a PRK or a trans PRK, they'll do exceptionally well.
Absolutely. Thank you, sir. And we'll move on to the last part of this session, the tear optics, which is again as important as looking at the epithelium, but it will take a few more years for it to come to your clinic as a routine choice. Like DLI and the Zernike part of iTrace took more than 6 or 7 years to become where we can comfortably say that this should be used in your cataract practice. So Dr. Divya, would you like to share your screen? And then I would like to request all the IPCL speakers to be ready with their presentation so that we can start it immediately. This is just a 4 minutes presentation. Dr. Divya, can you share your screen? Share your screen, please. Perfect. So Dr. Divya is a cataract refractive research fellow with me, and she's going to talk a very small topic, but it's very, very relevant on impact of tear film optics on post-refractive surgery outcome. Dr. Divya.
Yes, thank you, sir. Good afternoon, everyone. I'll be discussing the impact of tear film optics on the outcome of refractive surgery with the help of a case. We had a 26-year-old IT professional who underwent Lasik for myopia of -3 diopters. The procedure was uneventful and his vision post-operatively was 6/6. However, he came back to us 9 months later complaining of blurred vision and glare. Examination revealed a visual acuity of 6/6 and no other anterior or posterior abnormalities. So the quantity of his vision had been restored, but the quality was still not satisfactory. We subjected him to a complete dry eye workup, replete with topography and epithelial mapping. All of these were found to be within normal limits. So we dug a little deeper and analyzed his tear film using the optical quality analysis system, the OCAS. The OCAS functions on the principle of the double pass technique. Basically, a point source of light is projected onto the retina. This reflects off the retina and passes through the ocular media twice. The machine then analyzes the size and shape of this reflected spot of light. So it gives an in-depth analysis of the optical quality of the eye. The OSI is a measure of the amount of intraocular scattering. The higher the OSI, the more is the intraocular scattering, and the more is the degradation of the quality of the image. As you can see here, the right eye has an OSI of 2.2, which is more as compared to the other eye, which translates to a poorer image quality. Similarly, the images on the right eye are much larger than the ones on the left eye, which are sharp, compact, and round. This is the effect of intraocular scattering, which causes an overall loss of contrast in the retinal image. The vision breakup time VBUT assesses the tear film dynamics over a period of 20 seconds and then displays this information on 3 colored lines. In the right eye, the dots on the yellow and the red line are suggestive of an unhealthy tear film. Now, this patient was already on topical steroids, lubricants, and cyclosporine post-operatively. These, however, were unable to relieve his symptoms. What else can we offer such patients? He was already on maximal medical therapy, so we advised him treatment with advanced dry eye therapeutics in the form of thermal vector pulsation. Post-treatment with LipiFlow, we can see the vision breakup time has picked up well and was maintained well over the next few months.
1 minute, just go back. It's very important that how you take care of your tear film. This is classically used in this patient, is one of our staff employees also in the hospital. And even after 6 months, you can see that drop which was there. Now it is in the green line. That means the breakup time is bang on inside the green zone, which means that his tear film is not breaking at all. I mean, it's not creating an optical effect. So this is a very, very important slide which explains the important role of tear film in your optics of your vision. Thank you, Dr. Reshma. I think this is the last slide. I think we can summarize this. And of course, you have discussed everything in clear and everything here. In this take-home point is tear film optics is as important as your corneal optics. Even the conventional dry eye treatment don't work in them, whether you use an eye light or EI or LipiFlow or any other things which you want to call, will bring in a complete change in the dimension of your ocular surface. And please do not hesitate and do not wait for these treatments to be done. Do it quickly so that your optics is good. And this is not only just for refractive surgery, this works very well for your multifocal. The same thing could have been the multifocal patient also. Thank you, Divya. You can stop sharing.
Thank you, sir.
Dr. Himamshu, are you here? Would you like to take over the next session, please? And,
hi, good evening, everybody. And thanks, Rohit, for this wonderful opportunity.
And before I hand over, I'd like to introduce Dr. Himamshu. I think everybody knows Himamshu. I think he's one of the most intelligent people I met, very quiet, and absolutely only you will have to go and ask him. Then he will tell you the amount of knowledge he has on everything is phenomenal. And every time people listen and, is not seen too very often. He has multiple other interests in life. He's into hiking, he goes to places, and he does a lot of things. And he's a philosopher, and in many ways he's been a philosopher, very good friend to me. And it's not that we talk every day, but when you talk to him for 10 minutes, you'll understand a lot about life and beyond. And I have Dr. Kamal Kapoor for IPCL. I don't want to introduce him because he's an icon for IPCL and the work done by this group, the CARE group. Both of you should conduct this meeting, and I think the first speaker is Himamshu yourself. You're going to speak about getting the sizing right. Again, for the people who joined, the faculty who joined late, when you're 1 minute before you finish, Dr. Gairik with his loud voice is going to scare you, saying that you have only 1 minute left. So please do not get offended with it. Okay. Thank you, Himamshu, and all yours. For the next 1 hour, you please conduct this meeting.
Thank you, Rohit. It's really a pleasure, and it's so heartwarming to have such wonderful introduction of mine. And I really thank you for that. So my job, first topic is about the sizing of the phakic IOL, and here I'm talking about IPCL. The IPCL is a ciliary sulcus fitted IOL, and a lot of time we still keep on talking new lens, and well, there are more than 60,000, 70,000 lens implanted in more than 7 years, more than 1,000 users in India, more than 2,000 across the globe. And we still talk about, is it a new lens? Well, it's not new lens now. We all have used it and it works wonderfully well. Interestingly, we call it customized lens, but according to me, rather than customized lens, this is personalized lens, because for every patient, every refractive error, every excess, the lens is manufactured separately. So it's not customized lens, it's personalized lens to me. Why we talk about sizing here? But we are talking about sizing because we know in the literature, whatever best technique you use, whether it's an ICL, IPCL, there are cases where we have to explant the lens for the poor outcome, which we are talking about as a vault. Now, when we talk about vault, what we mean by vault is the gap between the back surface of IPCL and the front surface of the natural lens. And the normal vault is 250 micron to almost 750 to 800 micron. However, if the vault is high, there can be chance of endothelial damage, pigment dispersion, you can have angle closure glaucoma, and many such kind of thing. And if the vault is low, it can touch the natural lens and you can have early cataract, or a toric IPCL can have rotational instability. So that's why the vault is very important. Now, when we talk about vault, when do we decide the vault is accurate or vault is reliable? Well, it depends on the technique you use. I prefer to implant my lens under hydro implantation, where I just use DSS to implant the lens. Well, in that case, there's no viscoelastic substance in front or behind the lens. Hence, my vault can be a little more reliable earlier. If you use viscoelastic is there in front of the lens, the vault can be falsely low. But if the viscoelastic is behind the lens, the vault can be falsely high. So wait, if you use viscoelastic for 3-4 days to decide about the reliability of the vault. When we talk about the vault does not stay same also. There are papers which suggest that with the time vault reduces, and especially with the age when the lens becomes swollen, it certainly comes down significantly. To have a vault, to have an adequate outcome, there are certain parameters which we use for the sizing. One is, and two of most important of them are anterior chamber depth and horizontal wide to wide. The anterior chamber depth, what we measure, can be measured using different devices like contact devices like A-scan or UBM, or optical devices such as optical biometers or tomographers and ASOCT. Remember, if you use contact device, you may have to deduct the pachymetry from that. The cutoff value generally is 3 millimeter. Now, when we look at the anterior chamber depth, along with the anterior chamber depth, we also need to look at certain things like angle anomalies. When you look at the slit lamp, you look at the pigments, pseudo-exfoliation, inflammation, and all those things. And also look at the iris topography. When you look at the iris topography, lot of time you realize that the iris is looking flat, or it's convex, or it's concave, and that also gives you a lot of idea. Apart from this thing, one very interesting parameters which we all have started using now is called crystalline lens rise. When you draw a line between the line joining the iris, the back surface, both side, and amount of the lens which is projecting beyond that, we call crystalline surface rise. Higher the rise, lesser the vault. The wide to wide measurement which we take is usually advised to take under surgical microscope in patient in supine position using a digital caliper, which does not cost you much. However, I prefer that we should take wide to wide measurement by using more than one technique, whereas digital caliper being your gold mark, but gold standard, but there should be another technique along with that, like say any optical device like OpScan, Pentacam, IOL Master, I personally prefer Pentachem in image inversion mode, where I measure it digitally using the caliper myself. However, these things cannot be interchangeably used. Look at the example of my own eye. There's such a right eye, and there's such a variation between the different parameters. Also, when you're using optical device based on the first Purkinje image, remember, in cases like BKC and those things where you can have hyperpigmented limbus, you can have false measurement. So be aware. My preferred technique, well, I take horizontal Scheimpflug image. I do an image inversion then, and I take a digital caliper and I take the measurement. Now, this measurement, I feed it into my digital caliper, and I go on the slit lamp with the diffuser on, and I just confirm this thing. If there is any change here, I change it, and which gives me idea if it was accurate or not, and which can be a little more precise. Now, when we talk about placing, measuring the white to white, we have to remember that this is surrogate measurement. We put the lens in sulcus, but we are measuring white to white. Is there a relation between two? Well, traditionally, we are taught that horizontal sulcus to sulcus is almost 0.5 millimeter larger than white to white. However, there are enough articles which shows that there is poor correlation between white to white and sulcus to sulcus. Also, when the myopia increases, usually such kind of cases only we do phakic IOL, and there this correlation even further goes down. So why worry? Why can't we directly measure sulcus to sulcus? Well, sir, there are certain ultrasound biomicroscopes like Corneal. We can measure sulcus to sulcus there, and it can also give you, for ICL at least, a simulated vault. But remember that the repeatability of UBM itself is questionable. So can we just depend on UBM and do the surgery? Unfortunately, no. So I'm going to show you some trick, basically based on certain common understanding. I'm just going to show you some tricks. Now, before I tell you something, let's just understand this thing. A fixed size IPCL, when you put it in an eye which is larger, that means white to white is more, the vault is going to be less. And the same lens, if you put it in a smaller eye with a small white to white, the vault is going to be high. Well, there is no confusion here, right? Now, let's take an example. I'm talking about first a non-toric IPCL. On the right side, what you're seeing here, it's the range based on the calculator, what it would suggest. The rightmost part is the size available. And this is the range of white to white based on the calculator, what size it would suggest. So for your reference, I've kept it there. The white to white, let's take an example. If white to white was 11.95, the calculator will tell you to take 13.25 millimeter lens. And if it was 12.2, still the calculator will tell you 13.25. So where do you think the vault will be higher? Of course, the first one. The smaller space, you have put a larger size lens, and hence vault will be more. If you remember the previous cartoon, you know that smaller size, you put larger lens. Now what happens here, that if we have anterior chamber depth, which is less, and if your range is coming in this zone, where there are chances that you may end up in trouble. Now let's take another example of toric IPCL. Now you have a toric IPCL and you have white to white of 11.65. The calculator is going to suggest 13 millimeter.
One more minute, sir.
Yep. Yeah, sure. Okay, sorry. The calculator will suggest 13 millimeter. Even 11.93 also it will suggest the same size. Where do you think vault will be low? I'm talking about lower vault. Well, of course, the second part, a larger white to white, you put a smaller size lens, the vault will be low. The problem here is that it's a toric lens, then there can be rotational instability. So I would rather take little larger size. So if my calculator suggests 13 millimeter in this lens, I might actually take 13.25. And it's going to increase the vault, but it's going to increase the stability, rotational stability. How much vault it's going to increase? Well, when I'm increasing my white to white by 0.25 millimeters, 60% of that, the vault is going to increase. So which is 150 micron, which is not so much. But on the other hand, it's going to give me rotational stability. So unless you use these lenses and unless you become comfortable with this thing, you will keep on hearing from others that, well, it doesn't work, there are problems and all those things. Finally, if you know your subject, well, you certainly would do much better in this thing. Thank you very much.
Thank you, Himamshu. I think this is a wonderful talk. Can we ask Dr. Ramamurthy sir to give his talk?
I don't see him.
I'm there.
Yeah, he's there. Yeah, true. Sorry.
Thank you so much, Rohit, for this invitation. I'll be covering tips and tricks with IPCL, initially beginning with some simple implantation and going on to certain complex scenarios. Usually this is something we inject under normal saline or BSS, and it's because it's a hydrophilic lens, it's dispensed in a sachet containing normal saline. And this is the way you place the lens in position, and it's important that the ledges of the lens go under the flanges of the cartridge. And when you are putting it in place, you have to press it down gently. And then there's hardly any viscoelastic that I use. And the side port incisions are made at 90 degrees to each other. As far as the main incision is concerned, which is already always temporal for me, nowadays I make a good 3 millimeter size incision. And I believe the mouth of the cartridge of this should be inside the anterior chamber. And that gives me much better control as far as the injecting the lens inside is concerned. And once you have injected it, it's possible to rotate these lenses both clockwise and anti-clockwise direction. You always inject it in front of the iris and then gently tuck it inside. Sometimes if there's excessive pupillary dilatation, it's a good idea to let out a little bit of viscoelastic. A complete removal of the viscoelastic is extremely important, and time spent on this is well spent. And that's the reason the concept of hydroimplantation is gaining ground. And of course, if you have access to digital imaging devices like this, like the Callisto or the Varion, it becomes the process much more simpler. And almost 70-75% of my cases is toric implants, because leaving behind some amount of cylinder uncorrected is not quite acceptable. And in these cases, you would find that excessive filling of the viscoelastic is again to be avoided. It's a good idea to always see a little bit of strands of the visco being there. And you must remember that the lens opening the wrong way is completely to be avoided. And just in case you find that the lens is opening the wrong way, even if 7/8 of the lens is gone, it's a good idea to withdraw the lens and then subsequently reload the lens and then implant it back. It's never a good idea to rotate the lens upside, if it is implanted upside down, to rotate it inside the anterior chamber. It can be extremely deleterious to the endothelium. Here, because of the Varion display, you can see that one great advantage of the IPCL, that, as was mentioned, it's custom made, and because of which each and every lens can be implanted in the 0 and 80 degrees, and there is hardly a need to go ahead and rotate these lenses. And even in extremes of power, you are able to get these lenses. And also, depending upon the white to white, you can also get this in larger overall corneal diameter, which to my mind is a significant advantage. And today I've stopped using my diamond knives. I make a 3 millimeter knife, a clear cut incision. And I think this is a good idea to go with, because it helps me to have a better control over the implantation of these lenses. And nowadays, I do not dilate these eyes, because I think when you make the side port incisions or the main port incisions, the lens is open, and we have all had an occasion when sometimes you touch the anterior capsule. Obviously, in a cataract case, you can deal with that. But if it is an ICL and you IPCL, and you go ahead and touch the anterior capsule, the case is over. I purposely chosen a case where I had to use a certain amount of force to enter the anterior chamber. It's only after the incisions are made, I introduce xylocaine with the mediatic, which allows me good dilatation. And now I use Helon as far as the in the anterior chamber. And this allows good dilatation, especially these are usually young myopic patients. And you saw the lens being introduced. So And the need for irrigation aspiration has also been largely done away with this, because the helon tends to flow out. And you can see this small button over here, which should be in the leading left edge. And that's what you look for. That tells you that the lens is opening up the right way. And this is the lens being implanted behind the pupillary margin. And as you can see, as I hydrate the incisions itself, all the helon tends to flow out in one bolus. The fact that the bolus stops coming and then subsequently there's only clear fluid coming out, that itself tells me that there's no need for any further irrigation aspiration. There have been instances where I've completely avoided doing an IA because I'm confident that the helon has completely come out. But suffice it to say that even if you have to do it, it's quite less in quantity. And it's easier to evacuate this completely compared to a HPMC, which we used to originally use. This is the kind of vault that you would ideally look at, which is about 500 microns, the thickness of the cornea. Sometimes you might find that the lens is somewhat displaced nasally. That's because of angle kappa. That doesn't necessarily mean the lens is decentered. So it's quite acceptable. And this is usually it's said that 250 to 750 microns of the vault is not what you aim at. Sizing has been beautifully dealt with, but suffice it to say that just because you have a lower vault, that's not an indication for explantation. This is an eye which we have followed up almost for 10 years. You have a stationary opacity like this. The vault is quite low, but still we have not done anything about it. You can see a case, this is the case which I showed you earlier. There's hardly any vault, just about 100 microns. And here you can see again a very low vault, but the lens is absolutely clear. So it could be anything between 100 microns to 1,000 microns. But as far as the lens is functioning well and the patient is asymptomatic, you can watch. But just in case you have a significant cataract, you must remember that the high myopes also have a greater propensity for nuclear cataracts. But if it's an anterior subcapsular cataract, these are the cases where you can blame the lens for it. And this occurs especially when you're doing phakic intraocular lenses after the age of 40 in higher powers, like more than minus 15 diopters, where there's a low vault or a low ACD. All these are risk factors as far as development of anterior subcapsular cataract is concerned. And in case you have this problem, it's reasonably easy to deal with. You have to be conscious of the fact that you do not subject the anterior chamber to too much chamber fluctuations. And essentially, I just take out one haptic. Then using the front-loading forceps gently through a 2.8 or a 3 millimeter incision, even this hydrophilic acrylic lens folds over itself, and just by a hand-over-hand maneuver, using two forceps, you can bring the lens out. And then through the same incision, you can go ahead and you can see this being demonstrated over here. Two McPherson's forceps are used, and you can bring the lens out. And through the same incision, you complete your cataract surgery. And since this is a highly myopic eye, there's a 3-piece intraocular lens that has been implanted. In the case of high vault also, this was before the central hole came into being. You can see the iridotomy. In case the angle is not getting zipped up and if the pressure is under control, you're doing serial gonioscopy. Again, you can wait and watch these lenses. Of course, if there's a raise in intraocular pressure and the angle is closing down, you have to remove these lenses. Most often, these young individuals come up with with the rule astigmatism. Whenever it's in the range of about less than 1 diopter with the rule astigmatism, I actually shift my incision with a simple IPCL, not a toric IPCL, and then make the incision superiorly. And a 3 millimeter superior incision in my hands deals with almost a 0.5 to 0.75 diopters of astigmatism. But you must remember that this lens is not to be left behind, oriented in a vertical direction, but you have to rotate this around because the white-to-white measurement has been taken in the horizontal meridian. So you introduce the lens vertically, but rotate it horizontally. And this helps me to deal with a certain amount of with the rule astigmatism, even with the plain IPCL. Whenever you have a malorientation of the IPCL, a toric IPCL, it's important to put these lenses in place. And I just go in with the irrigation cannula. Even if you don't have a digital overlay, it's possible to just mark the amount of rotation that's necessary. It's important to remember that when you're rotating these lenses, you're not introducing any power. It's just you're redistributing the power. So it works only when the spherical equivalent of the residual refractive error is almost zero. That is a -1 with 2 diopters of astigmatism will work. But if it's just a 1.5 diopters of astigmatism that's left over, maybe it's a lens exchange that would be necessary.
So you have 1 minute remaining, sir.
Okay. Iatrogenic keratoconus, whenever it's a well-centered cone, and as in this case, and ACD is quite adequate, which is usually these cases. Significant astigmatism, the cone is stable, you can go ahead and use it. But please remember, this will work only if the patient is having good vision with spectacle correction. If he or she needed contact lenses, whether it's toric contact lenses or rose scale lenses or scleral contact lenses, it's a decentered cone, and it's the phakic lens is not going to do anything to your corneal aberrations. In these cases, best not to use these lenses. And this is just to show you a very short video of iatrogenic keratoconus case where Intax has been implanted and subsequently phakic intraocular lens is being introduced. Just to show you anecdotally a case where it lets you know that even in higher grades of IPCL refractive error, IPCL comes into play. And this was a patient with, in the right eye, she had -21.75 with 2 diopters of astigmatism. This case was almost 6 years back. At that time, we were just gaining initial experience with IPCL, but the patient decided to go for a toric ICL. So the residual error was quite significant. She was not willing to accept that. So we actually went ahead and made a custom-made lens made. And in this case, what we did was to go ahead and explant a toric ICL and reimplant a toric IPCL. This is not for me to say that ICLs do not work well. They are also excellent lenses, but obviously far more expensive. And one great advantage of the IPCL, I find that they are custom made depending upon the size of the white to white dimensions, as well as the size of the amount of refractive error, even in extremes of refractive error, as in this case, you are able to use this and get an optimal result. I just rushed through my research. Even in cases of nystagmus like this, where you can see a significant amount of movement, you don't need anesthesia. Once you get a hold on the eye, then you are able to go ahead and implant these lenses. And whenever this is combined with a significant amount of refractive error, presence of nystagmus per se is not a contraindication for using these lenses. It's just that you need a little bit of experience to go ahead and implant these lenses in these moving eyes, but it's definitely possible. And IPCL used as a piggyback. This is just anecdotal. I've just done about 2 cases. I think IOCAR itself has excellent sulcus fixation lenses now, and maybe these are off-label usage, and maybe it's better to shift over to those lenses when you have to correct extremes of refractive error. Yes, we have great experience phakic intraocular lenses. I think it's an essential part of the armamentarium, but you have to deal with these lenses extreme care. Very recently, we had a case, young lady who bilaterally implanted one eye, did extremely well. She had an episode of increased intraocular pressure, maybe because it retained viscoelastic, significant inflammation, put on mydriatics. She had, we are treating her for pre-existing keratoconus, which had stabilized. And this is what we had now, significant inflammation, dilated fixed pupil, very unhappy with the kind of photophobia she has to deal with. Once in a while, you come across these situations. You have to exercise adequate amount of care in avoiding all these cases. But most often, you are very happy with the ultimate outcome. Thank you so much for your kind attention.
Thank you, sir. Dr. Himamshi will move on to Dr. Kamal Kapoor now.
Yeah, yes. Yeah, and I would like to invite my big brother, Dr. Kamal Kapoor, for the next talk. I know Kamal for now at least 7-8 years, and apart from an excellent surgeon, an excellent human being, varied amount of interest in life. But when it comes to IPCL, nobody else can be better teacher than Kamal. So Kamal, could you be sharing your slide, please? Over to you, Kamal.
Thank you, Himanshu. I guess they're very kind words. First of all, I'd like to thank Rohit and Care Group for giving me this opportunity to share my experience with IPCL. I think a wonderful background set for me to walk on. There's a beautiful platform for me. I would say it's a complete refractive solution. So I could not think of a better logo than the Amazon logo, which says A to Z. And I agree with Himanshu more that more than customization is the personalization. I have no financial relationship with this organization. It's just good friendly terms. And right from the inception of the lens, from the day it was first designed, I've been associated with the design and the concepts and the modifications. And whatever I could have thought of, the lens has delivered. Done more than 2,000 cases till now. Longest follow-up, I think 6 years. I think I've done 34 cases. This is slightly old slide. 34 cases of piggyback lenses, 8 cases plus 4, 12 cases of presbyopic lenses. And I've also treated my hyperopic patients. Now, my experience, I've corrected till 11 diopters of pure astigmatism in corneal scars, traumatic corneal repairs. Since this is a smart lens, as said by Dr. Ramamurthy, you don't need to dial it. I've customized the lens size till 8.5 millimeter of optic diameter. I've corrected till minus 34 diopters of myopia. The largest lens I've ever used is 14.25, again, thanks to the personalization given to me by the care group. And it is available in the sizes, powers, and zones which I cannot even dream of. So I think I've had a good experience of more than 2,000 patients working in. Few points before I go to salient features is, whenever in my practice I see astigmatism of more than 2 diopters, I do measure the vertical diameter also. And as Dr. Ramamurthy said, if you have keratoconus, make sure, because in keratoconus, the anterior chamber depth could be falsely misleading. You need to measure the angles. So when I do my keratoconus patients, I've got more than 47 patients of keratoconus doing exceptionally well. And of course, these are patients who've done fantastically well with glasses. And I was looking for an angle for more than 40 to 45 degrees in them. And of course, the angle from 0 to 180. If this angle was present, I would gladly go ahead with them in anterior chamber phakic lenses. Of course, measurement of lens rise, gonioscopy, and specular macroscopy. What are the practical learning breakpoints? Always do a cycloplegic refraction, the angle-to-angle measurement, and as I said, the sulcus to sulcus, as Dr. Himanshu has mentioned. In my study, I've done a quantile biometry STS compared to a white to white. We've had a difference of 0.64 millimeters. In case you're looking for a larger size lens, make sure you've dilated the patient in your OPD before, because in case your dilatation is not more than 9.5 millimeters and you're going to be implanting a 14 millimeter IPCL, you're in for trouble. So we'll see some videos there. In case you use pilocarpine, which I don't profess using pilocarpine in these patients, in first 4 days, you will have a vault which is less than 200 microns. So don't worry. So if you have planned for a vault of 700 microns and you're seeing a 450 or a 480, don't worry, especially in case you use pilocarpine, because pilocarpine for next 3 to 4 days is going to go your lower vault. And each time you dilate this patient, the vault will go by 150 to 180. Mark my words. So don't be scared again. If you're dilating your patient to check the alignment of the lens, you will have a higher vault. So don't worry, this vault will go down. I've explanted a few lenses. None of the lenses has been explanted due to some glare or halo. Another thing is, I think this lens is one of the best lenses to be, even God forbid, you need to explant it. I've explanted ICLs also. ICLs tend to break. Sometimes they break half in the eye, and that's trouble. This lens is like a stretchable elastic. It can be pulled out. I will show some videos if I have enough time. Now, I'll just see some few situations. Look at this gentleman, minus 27 with 3 diopters. Look at, this is actually what I think they call the beer glass or the beer mug glasses. 13.75 and 14 millimeter in other eye. Now this is again 2 brothers. I used an 8.5 millimeter lens in this. We will see few situations. Now this is a lady who came to me with minus 29 with 2 diopter cylinder. Unfortunately, she developed a retinal detachment after 2 years, and we had to expand the lens and go ahead with doing a cataract surgery because the silicone oil induced some cataract in her. This is probably, I think, one of the highest reported powers in the world, minus 34 with 2.5 diopters of SIL. And the lens for this eye was 14.5, again 14.25. I would not say customization. It's a personalized lens. So this is the video for this surgery. You will see this is a 14.25 millimeter lens, which is going inside the eye. And you will realize what problems I have. Look at the size of the lens. It is inside the eye, and the lens is still probably folded nearly 1.5 and 1.5 millimeter each side. So the 3 millimeter zone till left in a beautifully dilated pupil. So I guess this is where this lens comes to my rescue. No amount of any phakic lens in the world would have helped me in this situation. And I've gone ahead and I put a 14.25 millimeter in a patient with nearly 34 diopters of astigmatism. I'll just jump the video and let the audience see how difficult it is at times to enclavate a 14.25 millimeter phakic lens. So the trick here is to enclavate first one side and then go for the other one. A beginner may get tempted to just lock in one of the three pads here and then go on the other side. No, that's a bad idea. Launch in all the three pads in one area. This will give you enough space on the other side. And only once you've done that, then just rotate the lens slightly 10 to 15 degrees to make sure that everything is unfolded and you go ahead. Now, this is another case. I will just skip the video, but the audience can actually see the size of the lens. This is an 8.5 millimeter optic diameter. This patient had a huge scotopic pupil, and there's no way any other company could manufacture a lens for me for this size. And the patient was operated by us. This is another patient operated by somebody else in Chandigarh. This lady came to me. She had a symphony lens implanted, and there was a residual open 5. And she'd gone through the internet and she realized that explantation of lens has a lot of complications. She's a principal of a very renowned university in Chandigarh. And she went through, internet, and she said, I don't want the lens to be explanted. What can you do for me? And since she was a hyperope and there was an issue with the formula, I decided to go in with a small, thin 80 microns phakic IOL. So I got a customized lens manufactured for her with 4.5 diopters, and an 80 micron lens was beautifully fitted into this eye. And this surgery went off perfect. And this patient was 6/6. Now, this is the classical case of patient operated by me, a traumatic corneal perforation with a beer bottle injury. This patient has 11 diopters of astigmatism. So I got a customized lens manufactured. You can see the corneal scar operated by me 8 years ago. And this is how the video looks like. This patient is 6/12p after surgery. Now, this patient had no choice but to go in for a cornea procedure. But I got a customized lens manufactured for him at 11 diopters of astigmatism. And this patient is doing 6/12 parts unrelated. I'm just jumping the video, but the audience can actually see there's a huge scar inducing an 11 diopters of astigmatism. So phakic lens was introduced in this patient, and the patient is doing well. This is another patient of central corneal scar with 5 diopters of astigmatism due to the central corneal scar.
So you have 1 minute, sir.
Sure. 1 minute. I'll just jump in fast. So I'll just go there. The lens goes in, and this patient also is doing exceptionally well. Now we will jump to another video. This is an interesting video. This patient was operated by me 18 years ago as a young child. He got hit in the eye, and he's reported to me with -17 diopters of myopia, completely fibrosed capsule, the lens captured within the capsular bag. Somebody's already done a yak capsulotomy in him, and he came to me for a solution at -17. So guess what do? I get a customized phakic IPCL manufactured for him. I go and do a meticulous breakdown of the posterior synechiae between the bag, and I cut the bag, I cut the synechiae, and I introduce this customized phakic lens in this patient. And this patient is fantastic. This patient, you won't believe, is 6/12 plus, and otherwise I would have need to explant this lens. Another very important case is this. This is what I call customization. A 4.5 millimeter small customized phakic lens manufactured for a non-dilating pupil, 496 micron. Again, a patient operated somewhere else for a traumatic cataract in a young age group with -13. Complete posterior synechiae. Now, what do you do in such a case? This is what you do. You have a company which manufactures lenses for you. You need to understand the science behind it. So I go in, I make my side ports. I'll just jump the video fast. I'll put in some viscoelastic, try and dilate the pupil. I'll do small sphincterotomies to give me some space. Now, I got a 4.5 millimeter calculated optic diameter size, and I don't think there's been ever documented such a case. we got a 4.5 millimeter optic diameter. Now this is the lens manufactured. Minus 13, this is what it says, a 4.5 millimeter optic diameter lens. And you will get to see the lens now. This is what it looks like. It's a small, tiny lens with only a 4.5 millimeter optic diameter. And this patient was refused from a lot of places because there was a complete fibrosis of the capsular bag, 100% capsular fibrosis. So I went in for a smaller diameter lens because I could anticipate if I could not break the synechia, at least I should cover the central 4.5 millimeter of optic zone and see how beautifully this lens goes inside the eye. And this patient is one of the most happy patients I've ever had. And I'll just jump now very fast to the phakic lenses. One of my first patients of phakic lens was my own OT technician, whom I've operated 10 years ago for a simple monofocal. And I've implanted phakic presbyopic lenses in them. The best part is I could also correct his astigmatism. I could correct his residual power and give him a presbyopic correction. And the best part is now me being in the presbyopic age, my OT technician can bend my cystitome 26 gauge needle without glasses, whereas I need to do it still under the microscope. Thank you.
Thank you. Thank you, Dr. Kamal. Dr. Himanshu.
Thank you, Kamal. And next, I would like to call upon Dr. German Bianchi. Dr. German Bianchi is from Argentina, Buenos Aires, and he is a consultant at Dr. Nano Eye Clinic, excellent researcher, an excellent surgeon, and has loads of interest and experience with phakic IOL. He will be talking to us about IPCL for myopia and presbyopia. Dr. Bianchi, please.
Hello, good morning for us and good evening for you. Good afternoon. Thanks so much for your invitation. Today I'm here for talking about the IPCL and my experience about myopia, presbyopia, and my experience about the last 3 years about IPCL. This is my history. I started in the end of the 2016 with the model V1 after V2 toric and then with the V2, and now I'm starting with my first patient with emetropic. I treat with IPCL refractive, and in the next 10 minutes I will talk about my scientific experience, sharing with you the result from my studies, evidence-based medicine. You can see here my first IPCL that I used, the model V1 on the upper part, and the picture is now from near to with more than 3 years. And in the down part, you can see my surgery that I usually do. This is the surgery that I do without viscoelastic because I feel confident with this technique. This is the quickly surgery, but it's not important if it's quickly or not, but for refractive surgery, I think is important that. And I don't have any peak after surgery because I use just either injection. And you can see in the right side many of my presentation in the last years. And this is the first PubMed publication with the IPCL, the model V2. I present this the last year in 2019. And the model V2, it was a prospective case series study with 100 consecutive IPCL. And I found that the volt was stable in the 6 months of follow-up, but also I studied the corneal central thickness and the endothelial cell density, and it was stable and without any statistical change. And now I finish another study about the diffractive phakic posterior chamber IOLs, and I present this year in the ECRS in Amsterdam some result, and I think for the end of this year it will publish in PubMed in some magazine, some journal. And I found that endothelial cell density, the corneal central thickness, was without any statistical significance. The vol was stable, and the IOP was without any peak after surgery, and it was stable. No cataract were developed in this series of 54 myopic eyes from 27 patients. What The indications and the tips: patient with myopia or astigmatism from 38 to 55-year-old without cataract, who want glasses independence, and if the patient have more than one diopter of astigmatism, I choose the toric IPCL, the diffractive toric IPCL. Well, the first thing is taking account the best corrected subjective far side. This is very important because I want to have a very good far side and near side. And this is very important to correct the far side first. And then I thinking for the next 5, 10, or 15 years for the near side. And I choose for the young patient near to the 40s, my personal formula is blend, different addition. The dominant eye, I choose the lower addition, but the most addition that this patient tolerate. And in the non-dominant eye, I choose a little bit more, 0.5 or +1, depend of the patient and depend if the patient tolerate. But if the patient doesn't tolerate this addition, I choose the same addition in both eyes. And when the patient have more than 10 diopters, I choose the same addition near to 3. This is my chart, my nomogram that I made because I need something to have to choose for my patient. And I take in account not only the age of the patient, I take in account the myopia because this patient tolerate more addition than the age, with the both option A and B, like I said before. And here we can see the coefficient of determination is near to 1. This is important, the spherical equivalent attempt versus achieved, because I need to have very good far side and near side. And is when it's near to 1, it's because we have very good vision. Here there is the binocular defocus curve of the diffractive IPCL with very good far side, near side, and also intermediate side. And this is the first lens that work together with the crystalline lens inside of the eyes and with the residual accommodation with very good results. And now we can see my history, all of my patients that I operate. But just to remark, the IOP remain was stable, no endothelial problem, no iris pigment dispersion, and no pupil alteration. And here we can see just it's easy in this easy way to replace the IPCL. I need to replace 3 IPCL in my history. This was because 2 was with less than 100 microns and 1 with 1 hypervolt, and 348 eyes, no cataract, but 1 was with cataract. And in this patient, I take out the lens and also the cataract. This just was the only cataract that I have. And this is the way that I take out, and in the same surgery, I inject another IPCL with the different size. I know that it's easy to do this surgery well. And now, another important thing for me is the UVM, like the other doctors said before, because in many of these patients, we can find some cysts in the sulcus, and this change our size of the lens. Sometimes this lens could be with a hypervolt because of that. I know that when the cysts are less than 0.5 millimeters, is not no problem to do this surgery. And I have two eyes that need to rotate the lens. One was for trauma and another was for this kind of cyst. And another study that I do is the lens rise in 42 eyes with 1 year and 2 years. And I realized that the change of this photopic and scotopic pupil, or the lens rise, was near to 100 microns, near 97 for the first years and 95 in the second year. And this was that I think that when the volt is less than 100, we need to change the lens. The tutorial is a good
Bueno, acá estamos con Luis, que se operó con IPCLs difractiva para ojos hemétropes. El ojo derecho hace una semana y el ojo izquierdo hace 48 horas. Luis, ¿cómo estás? ¿Cómo te sentís?
Muy bien. Read the subtitle that I asked for this patient.
¿Cómo estás con las
How
luces
he
en la
feel.
noche? ¿Te molestan las luces, las halos? ¿Ves algo de eso? ¿Las luces de los autos de frente te molestan?
No, eso 100% no tengo ningún problema.
¿Sabes?
Sí, eso veo perfecto.
He improved 2 lines. He, before surgery, had 25/20, and after surgery, he can read more than 20/20. He's very happy with that. And also, he can read figure 1.
Bóvedas y entre miles de columnas penden hermosas plantas.
This patient has 50-year-old, and I choose for the dominant eye 2 of addition, and for the non-dominant eye, I choose 3. This is another extreme patient, minus 31, with 2 of astigmatism. And this is you can see in the right side, how is after surgery is minus 0.25. It's very secure, this lens. And also we can see the volt is very good, and the periphery volt is also good, like you can see with the UVM.
So you have 1 minute remaining. Yeah.
I'm finished now. Thanks so much.
Thank you, Dr. Bianchi. That was wonderful. And if we see your experience with phakic, I'm sure everybody would be encouraged that these lenses, especially the presbyopic lenses, are there to stay here, and they will work quite well. One very interesting part which he showed was about the change in the vault in different lighting condition. And I think that brings out a very important message that if the vault is low, if because of the photopic condition, if the iris pushes down the lens by almost 100 micron, then no way we can put a lens with any vault less than 100 micron in the eye, and we have to replace it. So though we call 90 to 100 micron vault as still acceptable, but looking at these things, we have to learn that we cannot leave such kind of low vault in anybody's eyes. Thank you, Dr. Bianchi. And next, I would like to invite Dr. Schwind-IPCL Pavel from Gemini Clinic, Czech Republic. Dr. Pavel has been doing multiple surgeries and with various interests, and he has many firsts in his name in his country, and in Czech Republic. His experience of anterior segment surgery is unmatched. Dr. Pavel is going to share with us his first-year result of toric IPCL. Over to you, Dr. Pavel.
Hello, Himanshu. Hello, everyone. Thank you very much for the invitation. Thank you to Rohit, and to Care Group. It's my pleasure and honor talking here about my 1-year results of toric IPCL. So what are the indications, the basic indications for toric IPCL implantation at our clinics? Number one, I would like to emphasize that our first choice for refractive surgery is laser refractive surgery on the cornea. But whenever we cannot correct the error by laser, then we think about phakic lens, and in our hands, that means IPCL. And for toric IPCL, we consider patients with astigmatism over 2 diopters. With the patients with less astigmatism, we tend to treat with conventional IPCL, and I perform the incision on the steep meridian, enlarge the incision a little bit. That enables me to control and compensate astigmatism up to 2 diopters. Our safety limit, considering anterior chamber depth, is 2.6. I know officially most of my colleagues with posterior chamber phakic lenses have a limit 2.8, but we have proven that 2.6 millimeters is safe enough long-term with IPCL in our hands. Regarding the endothelial cell density, it's 2,000 cells per square millimeter, and we for the lenses which are not customized, we consider patients with pupils below 7 millimeters. Of course, that should be eyes with no signs of cataracts and no significant intraocular pathology. Here you see the IPCL, which was already introduced, and among all the features listed here, which are my favorite, are that we have toric versions with unlimited toric component. Presbyopic version is very appealing to me, and I happen to be the first in the world to implant a presbyopic phakic lens. And what is also clinically very relevant is that these IPCL implants are injectable through 1.8 to 2.2 millimeters throughout the entire wide range of optical power, and that also sets this implant apart from the competition. Just to mention that we have also the design with central opening, and this central opening is a little bit different to the other lens on the market. It's a bit smaller, and it has cylindrical walls, which should limit the light scatter and light loss, which is also clinically very relevant. So what do we do with our patients? And let's look at the demography of our patients at this study, which I'm going to present the data. So in this cohort of patients, we have implanted IPCL to myopic patients with astigmatism, and we have data from 23 eyes of 12 patients, mean age 29 plus minus 5. We had 5 females and 7 males at this group, and we have 1 month and 1 year complete follow-up data for all eyes mentioned here. Before the surgery, we do the basic workup: refraction, distance-corrected visual acuity, basic eye assessment on anterior and posterior segments. We rely with our sizing on white-to-white derived from Pentacam. And then you can use online calculator or send the data to a distributor or manufacturer, and they calculate the IPCL and ship it to you. So the process is pretty much straightforward here in Europe, and I believe in most of the world where you have your distributors, you can get the lenses through this process. Of course, sizing is critical to all posterior chamber phakic lenses, and even more for toric lenses, but I don't really have experience with high risk of rotation of this lens. Is very stable in terms of rotation, and alignment of course is crucial to be able to compensate for the toric component. So here we have a short video how we handle our patients. We use the IOLMaster 700 and Callisto systems, and you measure the patients, you derive the data, and then you transfer the data to operating room. Of course, you can also use a simple picture of the eye and project the correct axis, which is 0 axis over the eye, and have this picture at the disposal of at operating room, and that also works fine. But the navigation systems give you an extra comfort, so we use our Callisto system together with this IOLMaster 700 to process the data. So here we are at our operating room, and we are just double checking the correct axis placement, and surgeon can confirm that at the handle of the microscope and process through the software to start the implantation. You see the box and the implant and single-use injector provided by the manufacturer. This is a hydrophilic acrylic implant with the biocompatibility proven on thousands and millions of cataract implants. We see the toric markings on the optic, and we place this lens into the cartridge, and I like to bend it up, which is a little bit different towards most of the other surgeons. Then I close carefully the cartridge, and I like to advance the lens in the cartridge by spatula, and then click the cartridge with the lens into disposable injector, and we are ready to start to inject the lens into already pre-filled eye with OVD. And the lens unfolds slowly in anterior chamber, and then we will place the lens into the posterior chamber and in a correct axis. So here you see the axis, and we are manipulating the leading haptics behind the iris, and then while placing the IPCL more or less into the desired axis. We are manipulating the trailing optics also behind this a little bit suboptimal pupil, but it goes just straight forward. The lens is on axis behind the iris, so we can aspirate the viscoelastic. I personally did some implantations at the beginning, just the hydro implantations without the use of OVD, but in my hands, we have seen an increased rate of iatrogenic early cataracts. So now we use really OVD at each case. So then we bring the pupil down, which will cause the toric markings on the optic to disappear. We manipulate the lens behind the pupil, which gets down. You see the central opening is not really in the center, which is often the case, but I think that's just a straightforward case which was demonstrating on the video. So what about the results? This is a pretty high myopic group, pre-op in mean minus 9.29, and you see that the result, refractive result, is pretty predictable, and we are almost on zero, and at 1 year at mean minus 0.33, which is nice result. But what about the cylinder, the astigmatism? At mean pre-op 2.25, 1 month 2.43, and at 1 year 2.28. So it's about a quarter of residual astigmatism 1 year after the surgery. And I think this really demonstrates the efficacy of toric IPCL implantation for astigmatism correction, and I really like that result. What about safety and efficacy regarding the vision? Uncorrected distance visual acuity in logMAR, we went pretty close to zero, which means high quality vision, and you see in decimal that we are at 0.9, which is great. And in logMAR, corrected distance vision acuity 0.04 at 1 year, so we are almost at 0.9 in mean in decimal. So again, for this high myopic group, that means high quality both uncorrected and corrected distance visual acuities. Endothelial cell counts didn't really go down significantly. We just decreased from mean 2,687 cells per square millimeter pre-op to 2,547 cells per square millimeter at 1 year. So that's fine. Intraocular pressure, nothing really important here. Mean 14.4 and mean 13.8 1 year. So what about complications? We did see temporary pressure spikes in 2 eyes, which counts for 8% at this group. So that's the price we pay for dealing with OVD. But again, in my hands, it seems to be safer to insert the IPCL in the eye with which was already pre-filled with OVD. Residual refractive error requiring laser, we had 2 eyes, again 8%, which was pretty straightforward because it was a small error. We needed to rotate phakic lens to improve the toric compensation in 1 eye. And improper sizing, we did not have any eye which would receive too small or too big lens, which is, of course, a big drawback of posterior chamber phakic IOLs, because cataract is something which we all fear of. So in conclusion, toric phakic IOL is a very safe and effective solution for myopia combined with astigmatism, and it provides fast distance visual rehabilitation with results very stable in both refractive and visual acuity functions, and our 1 year experience is all positive. We do have much longer experience than 1 year, but we statistically proceed the data from this group, so I can share only 1 year data at this moment. Of course, we need longer follow-up on more eyes, and as the toric IPCL we use at our clinics as a daily routine, we gather more and more data, and we will share the data, and the data is being processed for publication right now. And I was happy to be able to share my experience. This is our clinic in Zlín, Central Europe, after the busy surgical day, and I took this video with my own small drone. Thank you very much for your attention. Happy to answer any questions. Have a good day there.
Thank you, Dr. Stodolka. That was wonderful, and especially you ended up with a wonderful overview of your clinic with your personal drone. Very interesting part you showed about your lower limit of NT chamber depth, which you consider as 2.6. And I would like to ask other speakers what would be their lower limit, and how do they decide if they want to deviate from their lower limit. Dr. Bianchi, how about you? What is the lower cutoff value for you in terms of anterior chamber depth?
Sorry, I don't understand.
The anterior chamber depth lower limit, what would you take as your cutoff?
Yes. For me, it's 2.8, but when you start with this lens, maybe you need to take a little bit more, 3.0. But well, I think it's the correct size, the anterior chamber when you start. But 2.8 is perfect for me. But of course, you need to take an account. If you have some keratoconus, you need to know the angle of the anterior chamber. It's very important. And also for the patient with hyperopia, and it's not only important the anterior chamber, it's important also the angle of this anterior chamber, no?
Yeah, thank you. Dr. Ramurthy, if you have a, Kamal, I'll come to you next. So Dr. Ramurthy, if you have done UBM on a case, and a lot of time we come across such kind of scenario where UBM shows a different measurement and white to white shows different measurement. What would you go by, and how do you solve such kind of mysteries?
I think we go with white to white. UBM is just an added modality. I would cross-check it with a topolizer or with a OpScan and go with that. As far as UBM measurements are concerned, quite often it's a little difficult to identify which are the points, and it's a little confusing. And most of these lens sizing has also been done based upon white to white measurements. And I'd strictly stick to at least a 2.8 millimeter anterior chamber depth, because less than that, I burned my fingers, and just doing an eye gyrotomy also doesn't help in these situations.
Sure. Thank you. Kamal, how about you? What is your lower cutoff? And what is your preferred method of measuring white to white?
Himanshu, I think we've discussed that before. I agree with Dr. Stodolka. We've had an opportunity of doing a lot of sessions together at the ESCRS. Even I go till 2.6, but my very important thing for me is the angle. Number one, and if I'm going below 2.8, I always do a PI. I think that's one thing I would differ. I do go to 2.6, but I don't usually say that at conferences or symposiums, because it sends out a bad message or a wrong message to a beginner surgeon. But I think once you're adept at it and you understand how the thing works, you can get away with a 2.6. My cutoff would be for a 2.6, I need to have an angle of 40 plus angulation. And I would always do a small PI at 12 o'clock. If I'm going below 2.8, I would do that. Now, answering your second question, white to white, with me still the gold standard is my Cirrus / my autorefractive keratometer, but I only cross-check with my vernier digital calipers. That doesn't form as my gold standard, but it forms as my confirmatory tool. Because I realized that I gave this exercise to a lot of people in my team. I told them to do a caliper measurement, and every time I had a different measure. But only if I give them a baseline that, okay, you have anything between 11.1 and 11.4, I would get nearer to the accurate. So over time, I've evolved a system where I use the caliper to confirm, but that's not my primary measurement. That just gives me an oddball, round ball figure. So I do that.
Okay, so there was one question which was similar by Dr. Reshma, that can we use TOMI optical biometer? Dr. Reshma, any device whichever suits in your hand, you need to remember that they cannot be interchangeably used. So you need to know how reliable and how repeatable your device has an agreement with your digital caliper. And if as all the speakers said, that we prefer that we use multiple devices to confirm that, and your final confirmation has to be with your digital caliper. One more question was there, Dr. Ramurthy, can you? Please,
just
sir.
one comment, because any optical biometer, whether it's Topcon or whether it's IOL Master, they all measure from sclera to sclera, while what we want is limbus to limbus. So invariably they give about 0.3 to 0.4 millimeters higher. So this is something that you need to factor in. So in these cases, I would go with some topographic device and digital calipers. And as Kamal very eloquently said, I use the digital calipers because sometimes a small hemorrhagic spot or a blood vessel or a pigment at the limbus can be confused by the topographer to be part of the limbus. And when these two coincide, that gives you the confidence that they are online.
Dr. Himanshu, I just wanted to make one point. For the lower ACD value, I think more than PI or angle closure, the important thing not going very low is the future endothelial decompensation. So I think looking at the specula before doing in something like 2.6 is very important.
Sure, I totally agree that everybody must do specular in most of such eyes. But at the same time, we also have to remember that whatever we look at is the central anterior chamber depth. And the way iris configuration, iris topography is also very different. And on top of that, it's not about one value. It's about the combination of your white to white and lens. What I was showing in that in the same size lens, you have a different white to white and you have different vaults. So yes, of course, the very valid point there.
I'd just like to add one point. I think, Himanshu, since you did start this topic, now this is a Pandora's box. It would also depend on your pupil size. If you have a large pupil, then going in for a 2.6 ACD would be trickier, because with a larger pupil, you are bound to have more than expected ACD vault. And I've played around with large pupil sizes, so I know how it plays around. So if you're playing within 6.75 millimeter of your scotopic pupil size plant lens, it works fine. Anything more than 6.75, I burnt my hands and I'm needed to expand the lens.
Last question. Last question, Dr. Bianchi, I'm going to ask you only because we don't have much time. So somebody has asked that what is your preferred method of removing viscoelastic from the eye? Do you use bimanual? Do you use coaxial? And do you go under the lens also?
I don't use viscoelastic because I started with this technique years ago and with another lens and also with a pseudophakic lens. And I feel very confident with this technique. And I don't have a peak of the peak after surgery because we don't have this viscoelastic inside of the anterior chamber, and the vault is exactly after surgery. And well, I don't have any inflammation, and I feel confident with this technique. It's just that. And another thing I want to say about the vault, it's important to do the UVM, because many times we found cysts in the sulcus, many times. Yes. And this is one of the most important things when you have a big vault or a small vault, and everything changed. And also the IPCL could be rotated in another side when you have cyst. It's not a wrong calculation for the white to white. It's just you have a cyst, and if you don't do a UVM, you can have this kind of problem. But well, my technique is without viscoelastic, and I like that.
If I can,
thank you, everybody.
So just a last step.
Yes, Naren,
talking about implanting the lens. I mean, I personally actually implant the lens under irrigation. But see, a lot of people are not very comfortable in terms of manipulating the lens under irrigation. One simple modification is where you can implant the lens under irrigation, and then you can use a visco cohesive on top of it. Okay, so that way you're rest assured your cohesive is not going below the lens. So once you have done that, then you can tuck your lens and then do all your this, and immediately you can remove your cohesive. The thing about cohesive is definitely if anything is left behind, you are in a lot of trouble, because you're going to have a lot of reaction, a lot of raised IOP. and other issues. That is why this is a slight modification where you always put the viscocohesive on top of the lens. So this way, you're rest assured all your cohesive comes out in one snap. So it's a very simple.
Yes,
thank you, Naren. And I think I just want to clarify one thing. I seriously don't want to convey that hydro insertion is the best technique or that's the only way. It's a personal choice. Many of us use hydro insertion. Many of us also use visco insertion. And so please do not take a message that hydro insertion is the only way. With this thing, I think we'll conclude the session and I'll hand over the reins to Dr. Rohit again. And thank you everybody for being here. Thanks.
Thank you, Himanshu, for conducting it so well. And thank you all the speakers. Wonderful discussion. And I think we have answered all the questions which was put in different forums. We are also watching questions coming in YouTube also. There are a lot of people watching on YouTube, many questions being asked. I think your talks covered most of it. We would like to start the third session, the very important session on Schwind platform. We have very important, two important guests, both good friends. Dr. Shadiabad from Lebanon, and he's pioneered in customized lasers. And also we have Thomas Minago and a lot of people using Schwind platform. He's one of the brain behind the way it is programmed. And he's one of the people working on the R&D and application part of it. This session will be moderated by Dr. Kumar Doctor and Dr. Gairik. Both of them will start the session. Dr. Shadiabad, would you like to speak first? I know you have some family engagements, or you would like to speak after Thomas.
So that would be good. Thank you, Professor Shadia. If I could speak first, that would be great. Thank you so much.
Is it okay, Thomas?
Absolutely okay. Go ahead,
Thank
please.
You,
because he did do a lot of arrangements in his family friend to be here. So we are just 20-25 minutes little delayed, but Dr. Sherry, I think it's all yours. Please take the screen.
All right. So again, thank you so much for this invitation, Dr. Sherry, and this meeting is wonderful, really, and I'm really glad to be part of it. So planning a customized laser ablation on the Schwind MRS. There are many issues with custom treatments. The first one being the possibility of overcorrection. 2, biomechanical insult. 3, remodeling. And 4, development of haze. Now, of course, there are many strategies what we could use to circumvent these problems. The first one being outsourcing. Outsourcing preoperative higher order aberration and outsourcing postoperative lower order aberration. That will be using corneal rings in terms of keratoconus, or femto-AK if it's a post-graft eye. Of course, using spectacles, post-op phakic IOLs, like has been mentioned now in the session, or allowing for a possible retreatment using an excimer. As well, by the way, as debulking initially with a PTK if the aberrations were so high that the topographer wouldn't be very accurate in determining the exact aberration. Now again, garbage in, garbage out. And that's why if we could not detect very good Myers and good measurements, it's better to stop and consider what's the problem. If it's a very irregular cornea, probably better to go ahead with PTK. If it's a problem with measurements, probably decide to have a much better Placido shape. Maybe use different devices depending on what you have. And finally, look at repeatability. If you have 3 or 4 or 5 measurements, is the repeatability, is it good in all the measurements? And otherwise remove the measurement which is the one that's standing out, and stick with the measurements that look pretty much alike. And that's very important. And of course, the reasons for overcorrection are many, but most importantly, they are refraction input, the laser adjustment, And finally, biomechanics, because the cornea is not a piece of plastic like Cynthia Robert would say. Again, when we refract, it's important to keep in mind that sphere is equal to defocus plus spherical aberration and others. So we might be incorporating spherical aberration in our refraction. Again, cylinder equals to astigmatism plus coma plus secondary astigmatism and so on and so forth. So we need to make sure that we need to keep in mind that we might be incorporating part of these higher order aberration in our refraction no matter what we do. Finally, the laser adjustments. Well, in ideal wavefront is a wavefront without higher order aberration. But this is an example of a spherical aberration. And as you see, spherical aberration has an lower order aberrations. So this is myopia in spherical aberration. And if the laser treats the myopia, we're going to end up with no higher order aberration. But guess what? We're going to end up with the equivalent in diopter in lower order aberration. So the laser does a second adjustment and basically corrects the lower order aberrations as well. So what this brings about the refractive neutrality that the laser, at least the Schwind-IPCL works with. So there is an equivalent diopter of treatment of higher order aberration and lower order aberration at the same time to keep the treatment refractive neutral. Because of that, we need to make sure that we won't be trigger happy when we treat these aberrations. So basically, as you can see here, the laser has much easier task in treating lower order aberration than higher order aberration. This is well known for all lasers. So hence, we might end up with overcorrection if the laser tries to treat both, because the treatment of lower order aberration is going to be much easier. And that's why this brings the issue of trying to avoid being trigger happy. The more we correct new aberrations, the more unnecessary aberrations, the more there is a possibility of ending up with an inaccurate refractive results, typically overcorrection. In addition, the more aberration we treat, the more possibility of developing corneal haze. Remember, these are very irregular corneas, whether they are post-graft eyes, whether this is a keratoconic patient, or a very irregular cornea we're dealing with in the first place. And finally, corneal integrity. We want to spare some tissues first for biomechanical remodeling and to avoid developing any ectasia. But more importantly, again, we want to be able to revisit the cornea later if the cornea gets much more regular in order to treat. So again, the mantra here, the less, the better. Well, how to go ahead and plan a custom treatment? Well, first, again, we start with refraction. And in order to put those higher order aberration at bay from our refraction, I would recommend refracting with the lights on. So this will decrease the possibility with lower order, higher order aberration factoring it in, as we know, because they are square root in terms of pupil size. Two, don't be trigger happy again. So if the patient is satisfied with a certain amount of astigmatism, let's say 2 diopters, and from 2 to 3 is kind of not quite sure if we're getting better visual acuity, then stop at the lowest possible refraction. Two, I would compare the ablation depth. So look at the custom, look at the aspheric, and compare the ablation depth in both. So on the left-hand side is a corneal wavefront guided, on the right-hand side is an aberration-free, both the same exact treatment plan. And if you look at the treatment, of course, there's a difference between the two, difference in depth and difference in volume, and that's what we should keep in mind. And ideally, and of course, this changes per patient and per case treated, but ideally, we wouldn't try to put more than 1 diopter difference between the two, and ideally 0.75. And that would be equivalent to 10 microns if it's an optical zone of 6. Again, 155 to 190 in terms nanoliters in terms of volume, 12 microns for 6.5, and 17 micron and 14 microns for 7 millimeter of optical zone, which is roughly commensurate to 300, 350. These are broad things that I would put in mind. And again, this would change from patient to patient. There are some patients who I really don't care about their final refraction because I really want to treat their higher order aberration, but typically it's always a compromise between these two. So this is a kind of rule of thumb to follow roughly. Going to the platform, if you look at the left-hand side, first I want to try to tweak the refraction. So again, there are possibilities to tweak the refraction with a minimized depth or minimized volume and to set certain constraints to the tolerance where I want to shift from the refraction I have input. The second possibility here is actually treating the pyramid. And again, the Amaris and the Schwind is one of the few lasers, if not the only laser, that would really allow us to tweak these aberrations, as you see here, and tweak the pyramid to again shave more from the ablation, both in depth and in volume. For instance, this example of a plano -2 at 50, a keratoconic patient. And as you see here, the SMK is 2.81 at minus, if you want, at 49, pretty close to our refraction. If I look and decompose the higher order aberration based on 6 millimeter and 4, and here 4 millimeter would be commensurate with my refraction. And as you see here, I have a coma of 0.82, but the astigmatism, the regular astigmatism, the lower order component is 1.86 minus 1.86 at 41, and that's pretty much commensurate with my refraction. So I would really know that I didn't really over-treat it, and it didn't incorporate a lot of higher order aberration in my, or a lot of coma in my cylinder, the one that I actually measured. And then going back, and if I input exactly what I measured, you can tell that the ablation is 37 microns centrally with the 793 volume. Let's say I want to just incorporate plano here, and if I incorporate purely plano, actually I get more, 46 micron, a little bit less on the volume, but 46 micron. So again, the concept of trying to put zero refraction is as true, because again, the laser is going to try to be refractive neutral. If I force the laser into a certain refraction, emmetropia here is going to go ahead and put more treatments and ablate more, and I'm going to end up with a more unpredictable refraction. Instead, what I would, yes.
So sorry to interrupt. 1 minute. Can you tell us what constraints are? There are a lot of new users to Schwind. You can just tell us what are these constraints. I'm sure Thomas may talk about, but it will be nice because you have your own way of explaining this.
Right. So actually here right now, what I'm doing is actually, in this case, I'm giving an example that, okay, I'm gonna go ahead and remove all constraints. So I'm gonna first go with the radical way, or I'm gonna remove all constraints and see. So this is what I usually would do, and I think Schwind would recommend the same thing first. Initially, the constraint is the following. If I have a sphere and I want the laser not to deviate more than 1 diopter away from my refraction, I would select the sphere and I'll put a constraint of 1 diopter. Again, the cylinder will be the same thing. The axis, if I want the axis to be treated not more than 15 degrees, then my refractive axis, then I would put click axis and I'll put 15 in here, depending on how really accurate I am, and depending on how I don't want to deviate from the patient's refraction. In here, first, if I try to remove all constraints, so I'm telling the laser, just do whatever you want and give me the lowest treatment in terms of tissue ablation. So I want the treatment with the least tissue ablation, and I want to check what refraction the laser would end up putting. And in this case, interestingly, I end up with a refraction which is close to my refraction, plano minus 1.51 at 62. So it's half of a diopter away from my astigmatism, and it's about 12 degrees away from my axis. And for me, that's good. I don't have to go ahead and give all the different possibilities because the others are just trial and error. This actually would spare me a lot of time because I'm basically shaving a little bit of my predictable refraction to have much less tissue. And guess what? Much less tissue was first might be more predictable because my refraction, I'm never sure that is actually the true refraction. I'm never sure if 2 diopters would be incorporating some of the coma as well. And 2, I will leave more room to revisit the cornea, but now on a more regular cornea where the refraction is more accurate, and then treat that refraction based on maybe purely lower order aberration, and that would be more accurate. So that's, again, the mantra is like the less the better. So again, if I put all the constraints out, this is the refraction I get. And guess what? Again, for the treatment, this is going to give me the least treatment possible, 27 micron, and the volume is cut by more than half, 422 micron. And actually, that's the one I'm going to give. Imagine it's just a small change with half diopter, and in 12 degree, this will increase my treatment almost by double. So again, once I take care of that, I move to the pyramid and I let the laser, again, recalculate and try to shape a little bit more, selecting the aberration I want. And I can really force things. I might want to keep coma or remove coma, but in general, if you let first the laser, go ahead and select for you, look at the final results. And that's actually, look, ablation depth centrally is 11 micron, and periphery is 25 microns. And bear in mind, this is a cone. So the cone is not always what you see as the thinnest ablation, because the thinnest ablation is in the middle. So the cone heel is actually away, and it's actually 18 micron. Finally, I would compare with the topography. So this is the ablation and that's the topography, and actually they're pretty much commensurate. And that's very important before going ahead. One thing I like in the Schwind platform is that it allows for seamless evaluation of topography and ocular wavefronts. And that's amazing with the parameters right now. So if you have on the left-hand side, you have the corneal wavefront, on the right-hand side, you have the ocular wavefront. If you take a look here, the ablation is 39 microns centrally, not on the cone, and 950 in volume, but look at the ocular wavefront, and now with really minimal aliasing with the parameters, such a high resolution, and more importantly, high dynamic range, I can really image these keratoconic eyes, and I can see that even though it's still 39 microns centrally and definitely less in volume, the ocular wavefront, but look at the cone, and it's much, much less. On the same scale, which is here 41, here is about maybe 40 microns of treatment, and while on the ocular wavefront, it's definitely much less. It's about in the 30, low 30s, and that's the advantage of having both and comparing. And as they are pretty much, they look alike, the two ablation look alike. In this specific patient, I went ahead with ocular wavefront. And that goes with what Bruce Allen showed a couple of years ago in JCRS. Basically, he showed that when evaluating keratoconic patients with both ocular and corneal wavefront, there were 44% less treatment both on the cone in the standard and the maximum ablation with ocular wavefront than corneal wavefront. And that usually can be attributed to the posterior curvature, which harbors a negative meniscus, so subtracts from the anterior, especially for coma. As you see here, you have the anterior curvature and the posterior curvature, which they do subtract from each other, and it's about 30 to 40% sometimes, and that's important. So if you have a really good device that can have a high dynamic range, you can trust the ocular wavefront with one condition, that you have a good optical zone. If you don't have good optical zone, I would move definitely to corneal wavefront guided. I have large optical zone, then I have this possibility. A very quick case to put that into an example. This is a patient with an MS-39 treatment with the epithelial map, and you see the anterior curvature and posterior curvature. This patient has had a cross-linking and developed some haze. So I really didn't want to treat much. I want to just improve his coma because he was just complaining of some shadows. And if you look here, the coma is 0.86 as 100, the anterior coma, but the posterior higher order aberration, and bear in mind, this is MS-39 with OCT, so the haze would not be good in any Scheinflug device, but this is an OCT, so it would be much more accurate evaluating the posterior coma than in Scheinflug. And it's here is 0.41 at 285, exactly the opposite. And guess what? The total higher order aberration is 0.43. So it's cut by half. Now, if I want to go ahead with an anterior corneal wavefront guided or any topography guided, I'm going to leave the posterior higher order aberration unmatched. I'm going to end up with the same final result, 0.43, but different direction at 285. And that wouldn't help the patient at all. So here I looked at the higher order aberration thanks to the parameters, and I saw that the total higher order aberration in coma is almost the same, 0.46 and 92, which means I can go ahead with ocular wavefront. And luckily the patient had large pupil, so I could go ahead and treat that. And of course, so I went with ocular wavefront guided, and this is the post-operative results. As you see here, this is the pre-op, and this is the post-op anterior curvature. And yes, I can see some coma in there, but on the anterior surface. But if, again, you look at the MS-39, you see that even though we have 0.39 at 103, the total coma is 0.03, so it's 0, because thanks again to the posterior higher order aberration, the posterior coma, which was negating the anterior. And actually, in this case, we really nailed it, luckily. So again, ocular wavefront guided should be part of the armamentarium. But again, in the future, total corneal wavefront guiding, incorporating anterior and posterior, thanks to higher development of OCT right now, might be the very near future. So in conclusion, I would like to just put again the really ground rules for custom ablation, at least on the MRS. Always look at the measurements, repeatability and quality. Check your input refraction and try to tweak it to incorporate less and less of the higher order aberration. Think of outsourcing, debulking, both lower order and higher order aberration whenever possible. Again, the less the better, because we can always revisit later on a better shaped cornea. And finally, think always corneal and ocular wavefront guided, not just corneal wavefront guided. Thank you.
Brilliant, brilliant, Sharia, as usual, brilliant. And
thank you.
Very, very nice presentation. Before we have a discussion with your talk, I know you need to leave. I would push one.
I can stay for 10 minutes if you want.
I would like to push one case which was after Thomas's talk, but I would like to bring that case, a small case, which we are trying to do, because there is a lot of confusion around treating abrasions. Everybody says that treat the abrasion. Abrasions, I believe, are like commensals. You cannot kill all the commensals, whether in the eye or the gut. If you kill the gut microbiome, you'll end up in bad diseases. So abrasions needs to be controlled, not treated. So I think we have a way which we are doing. I mean, this is on a research mode. I think Thomas can also comment on this. We have not started using Pyramis yet. Hopefully we should be using. So question I would like to ask you is, so in your practice, you look at both the Pyramis, which is the ocular wavefront, and the corneal wavefront, and choose the one which has least amount of ablation. Am I right on this? Or you use predominantly ocular wavefront in your practice? Let's rule out keratoconus. I'm talking about, let's assume you're doing a trans PRK. Which one would you put your bet on?
Actually, I would always look at both, and it all depends on the initial source and how much I trust the machine I'm having, and again on the optical zone as well. If I do have a good optical zone, large optical zone, and the ablation look very similar, actually you could go with both, and I would go with the one that gives me less tissue ablation. A lot of time, however, in very irregular corneas, post-graft, or even the Pyramis doesn't give me a great result. And actually, you know what? I go to the Scout. I mean, this is, I would say, this is my go-to machine for very irregular corneas, because it has such a small cone that goes all the way up. So I think I individualize and I look at everything and I decide what's the best for that specific patient. And as you said, the aberration can be controlled and not removed. And I actually noticed that, and this was a case that you presented with Pooja, I think one time in the Crossing Congress, and I looked at all my keratoconic patients and I performed MS39 and Pyramis, and I found out that 5% of my keratoconic patients have deeper than the posterior curvature internal aberration of more than 1 diopter at 5.5 millimeter optical zone. And that was a lot. And it was started for one case you were presenting. And that kept me thinking that sometimes the aberration in perfect harmony internally, maybe due to the angle alpha and kappa that the keratoconic have. But again, as you said, it's not just about to treat all the aberration possible, but get to the perfect harmony for that specific patient.
So let's have a small case and then we can discuss, then we'll move to Thomas's talk. Okay. And Sneha, would you like to start the presentation?
Yes, sir. Good evening, everyone. Today I'll be discussing about the role of visual adaptive optics in customization of laser ablation treatment. Whenever we think of performing a topo-guided laser ablation for regularization of cornea and keratoconus, the most important question that arises is whether we should treat all the aberrations or should we customize the treatment of aberrations. Which one should we choose? There are some microorganisms present on the ocular surface that are commensals. In the same way, there are certain aberrations that help in improving the quality of vision post-operatively. The visual adaptive optics resembles a phoropter that helps us to customize and know the aberrations that decrease the visual quality and those that improve the quality of vision. Visual adaptive optics is an aberrometer that works on the Hartmann-Shack principle. It measures the aberrations and then assesses the change in the quality of vision, preserving one of the aberrations and neutralizing the others. The procedure is as follows. First, we acquire good quality scans. Minimum 3 scans are necessary. Then we evaluate the uncorrected visual acuity and the best corrected visual acuity. It also gives us the refraction along with the best corrected visual acuity. The next step is to customize the aberrations. We can customize the third order, that is the coma trefoil, the spherical, and the higher order aberrations one by one. One by one, we can check the change in the quality of vision after inducing these aberrations, whether it is improving or it is deteriorating.
Basically, it is like how you would do a phoropter. This is a research tool which helps to change the aberration instead of your glasses. So all that is the basic one-line simplification. Please let her finish now.
Here we induce the third order aberration, that is coma and trefoil, one by one. If there is a drop in visual acuity after inducing these aberrations, we should treat these aberrations while doing the laser ablation. And if there is improvement after inducing, we should preserve these aberrations and should not treat them. The Schwind-IPCL 1050RS gives us the privilege to customize these aberrations during the treatment by switching the aberration off on if we want to treat it and off if we wish to preserve it. The same concept applies here when we induce the spherical aberration and when we induce the other higher order aberrations. Thus, if the quality of vision is improving post-operatively by inducing the spherical aberration and deteriorating after inducing the third order and the other higher order aberrations on the visual adaptive optics that has been performed pre-operatively, we will apply it on the Schwind by switching off the spherical aberration that is not treating it and switching on the third order aberrations and the other higher order aberrations that is treating it. Thus, the advantage is it improves the quality of vision post-surgery and it also helps in minimization of depth ablation, that is, preserving the corneal tissue. Our team at NN is currently working on this project where we perform visual adaptive optics, customize the treatment of these aberrations accordingly. In this patient, there was improvement in the quality of vision after inducing spherical aberration on visual adaptive optics performed pre-operatively. We did not treat the spherical aberration. The outcome showed improvement in 2 lines post-operatively as well as there was improvement in the quality of vision. Whereas in the other eye, we had not customized the treatment and thus treated the spherical aberration and there was loss of 1 line of best corrected visual acuity post-operatively. We have the same case which will be discussed.
I think that we can end it here.
So yeah, Sneha, you can stop sharing screen.
Yes.
So basically, what we are trying to say is one of the greatest things Thomas and Schwind has done with this machine is phenomenal capacity to think and do what you want. I don't think there's any machine on earth which can do it. And thanks Thomas and your team. And I think on behalf of all the users, and Sherry's smiling because he's a very thinking surgeon and he's used this to the maximum. So whenever you get a new thought and you can share and start thinking and start going back, you don't need to ask anybody. The machine is open for you to use. I have no idea how they did it, but that's why it's such futuristic thought process involved in it. So basically, the concept of correcting every patient the same way is going to be a very, very kindergartenish way of dealing with aberrations. We have to choose, pick, and treat. A lot of people have said, don't treat spherical aberrations in keratoconus because that's not the culprit. You don't see, a lot of this has been discussed, but this is a proof. In fact, there is one patient I had when we tried treating his coma on the adaptive optics. If you negate the coma, he became worse. That means coma was very important for him. Even though you want to say that coma should be cleaned. So this is a classic reason why some patient, after you put a contact lenses, actually drop their vision.
Dr. Ramurthy.
So there are times when, I've had patients when you put a contact lens in and we expect everybody to improve. All out of 100, 98 will improve. One will come and say, my contact lens is not, I don't see as clear as it should be. That is because your eye has adapted to that coma. It's become a commensal. It's become a healthy microbiome. So it is very important at this point of time. It may be difficult to choose, but it's very important. This study, what Sneha is trying to show, tells us that every single patient is different and how you utilize your knowledge to treat it or not to treat it is going to be different. So I would request Thomas to give a comment on this, then Dr. Shetty before he leaves.
I agree. Each patient is different and that brings a vast of variety for possibilities. And what we do somehow in our application department, we have standardized it as much as possible, which works for maybe 80%, but not for all. So what we always check is we check for the aberrations coming on the different diagnostic devices, ocular or corneal wavefront. And if there are some significant or almost significant, this votes towards customized. But there are other factors like the visual acuity. If there's less than 20/20 or less than 6/6, then this also votes towards customized ablation. And also if the patient has some complaints, of course. And then if we agree to do a customized treatment, it goes further, which device is reliable. If both are having the same data, you can rely on both machines because the data is reliable enough. The density of spots and measurements is good for both machines, corneal and ocular. So in principle, it would be usable for both machines. Whereas the corneal wavefront has advantages because you are not restricted by the pupil, by the pupillar opening. It measures the whole corneal surface, whereas the aberrometer has advantages through method to measure through the entire eye, including all the aberrations. So it's a really complex tissue topic. And even if we decide for one of these measurements, it goes further. Which of the higher order aberrations needs to be customized, which should be involved, others can be excluded. If there are some significance, it is most likely that they are bothersome, but not always. As you mentioned, Roy, in some cases, internal aberrations compensate for each other. And if you eliminate corneal aberrations, which are compensated internally, then that brings the patient into trouble. So it's complex, and we offer some tools looking on this. But we have no tools about the visual acuity, so it was a good idea to show this behavior and to bring in the higher order aberrations which contribute to an increase of the visual acuity. However, what we also do, we look on the ablation depth which are involved by these aberrations, and that offers a chance to bring or to correct the ones, the higher order ones, which are influencing the high amount of tissue, which remove a high amount of tissue, because most likely they are also influencing the visual acuity. So that makes it rather complex. I agree. And Shadi, maybe you have to add something for that.
No, Thomas, actually what you said is so right, but I think what we're seeing here is actually some kind of a missing link. The amazing thing in the philosophy of Schwind, which went really against the current of all what the laser manufacturers were doing, is that they brought back the wavefront into the core of topography guided and core of customization, at the point where at one point we had this hype about wavefront, like wavefront, the supervision, and suddenly we kind of, as Professor Shetty was saying, kind of we shy away because we felt it wasn't leading us much to a promised supervision. But then what Schwind did is actually going back, even customized treatment, broke it down into higher order aberration and gave us the possibility to kind of customize the very wavefront we want to treat. And now with what we're seeing with this presentation, hopefully using adaptive optic, putting this missing link between what the patient feels and what the patient sees and our customization. I think it gives us even a bigger power. And of course, this is not the main issue. And as Thomas, you said, there are many things in the equation. There is the ablation depth. There are many things factored in, but this is a very important tool. Sometimes I'm faced between, okay, shall I treat, if I can shape the ablation either way, but which is more important to the patient? And sometimes this is gonna be great into kind of shifting the physician one way or the other. That's, I think, it's an amazing tool, hopefully, when it's out.
Thank you. Thank you, Teddy.
Thank you. Thank you so much.
Being here, in spite of having your family engagement. Thanks a lot.
Thanks. So actually, it's an amazing meeting. I wish I could continue. I've learned so much in this 1 hour plus, which I'm here with amazing speakers. Thanks a lot. I would really appreciate it. Thanks a lot.
Thank you. Now we have the next speaker, Thomas. I did introduce Thomas at the beginning. He's a man to go for anything to do with the problems you face during learning phase of Schwind. I learned a lot from him, a great teacher. Last 2 or 3 months, I've been looking at all his presentation. And that's why I thought I'll change your topic because many of them must have seen those topics. So, Thomas, all yours.
Okay, thank you very much. I'm going to share my screen. So first of all, thank you, Professor Rohit Shetty, for this invitation and setting up this meeting. And thank you also, Vipin, for setting up this meeting and both of your teams, because I know it is a lot of work and a lot of preparation needs to be adjusted behind. So thank you for giving me also the chance to talk about our devices and about the Amaris in particular. I'm going ahead to talk about spot, fluency, laser tracker, and more. So the underlying technology which makes it possible to get these nice results as Shadi and others have shown to us. So let's look next. Okay, let's look on the spot and fluence. And there's always a discussion about the optimum of the laser beam characteristics. And there are controversial opinions about that and the impact of the laser beam, the characteristics of Gaussian or super Gaussian, truncate or not, and spot geometry, spot overlap, and the lattice of geometry and ablation smoothness. So there's a publication from Alba Mosquera talking about the characteristics of laser beams. And out from this publication, we have here some interesting information. Let's look on these graphs here. So if you have a flat top device, or if you have a Gaussian device or a super Gaussian, the difference is flat, and Gaussian is only flat in the central area, then steepening in the periphery. And the super Gaussian is similar what we have with the Amaris. It is more like a peak in the central area, but not a real peak. It is a mixture, a steeper Gaussian. And we have here a graphic which shows the radiant exposure, so the fluence millijoule per centimeter square in the horizontal, and the ablation volume in the vertical. And the flat top is this violet line. This is a Gaussian line, and the super Gaussian, what we have similar in the Amaris, is the blue line. So why is this important? If we would have a flat top, a small change in the fluency in the millijoule per centimeter square will have a tremendous effect in the ablation volume. Even if we are in that level here, if the energy changes a little bit, it will move or change the ablation volume. Ideally, in this graph, we would wish to have a small, a horizontal line. That means even if the fluence, the radiant exposure changes, our ablation volume stays solid. However, this is now not absolutely achieved, but with the super Gaussian profile, which we have in Amaris, we are also here in almost in a flat top area, or in a flat area, not a flat top, flat area, and also with the higher fluency. So that was one of the multiple reasons which votes for a super Gaussian beam profile. But there are more. Like if we look on the roughness for the ablation, again, flat top Gaussian or super Gaussian. If we look on the flat top and on the overlap of the spots, you see even a small overlapping already increases some roughness in ablation. Whereas if we go for a super Gaussian or for a Gaussian, we start with a small overlap, we start with a very low roughness. And interestingly, here in that area of more than 400 microns, more than 500 microns, all of them ramping up. So this gives another hint and gave us another hint how to optimize and shape our beam profile. But there's some more behind, because when we look on the effect of a pinhole on a super Gaussian profile, if the pinhole is open, we have the super Gaussian like this profile. If the pinhole is closed for 30%, so the opening is 70%, it will look like that. And if the pinhole is closed for 50%, like that. And that also has an effect. And we can see if the pinhole is open, we have the least amount of roughness in ablation. So this votes for as large as possible open pinhole. However, we need to be above a certain threshold to avoid thermal heating of the cornea because of the pulses which do not contribute to the ablation process and just only generating heat in the corneal tissue. So that's why we still have a pinhole, and we are close to this red line and close to the pinhole of 100%. What is written in the user manual? An optical system guides the laser beam through the tower and laser arm onto the treatment plane and performs a 6.3 or 6/3 millimeter rectangle beam size in a small round spot of 0.54 millimeter full width half maximum as a super energy distribution with a super Gaussian profile. With a low fluence, as you know, we work with two fluence level, high and low. One is 250 millijoule per centimeter square and the other is 500 millijoule. So this is what is written in the manual. This is the information which is behind. And you have seen with the graphs before what is important and what all this information put us forward to these parameters, to this small spot, to this kind of energy, and for that profile. Because at the end, also the dose of the energy is playing a major role. If the energy decreases, you need to increase the number of pulses to get the same ablation volume. That means the dose overall increases. If the energy increases, the number of pulses decreases because you need less pulses, but one has more energy than others. But the temperature increases. And there are some publications talking about this concept of dual fluence and of this efficiency. And that leads us to a proper spot placing and thermal control, which is needed to take action, especially if we go for high fluency and high repetition rate. So that brought us consequently in the development phase to smart pulse technology, which is a pulse technology to especially enhance the short-term outcomes. And I think you have heard about this wow effect. Yeah. And there is a principal change when this algorithm came, which made it away from a flat, plain ablation profile and pulse positioning list. It included the cornea as a three-dimensional aspect. And the effect is traditionally, we have, if this is your ablation profile and you see the underlying grid, traditionally it was that one spot to the next spot, you have an equidistant spot, which is true if you go to a plane, to a surface. And also in the periphery, you have the same distance. But as the cornea is curved and as a laser shoots and fires on the curved surface, we have an effect which is described in the fullerene. And following this edge to that edge, we always have the same distance. And also in the periphery from here to here, it's the same distance like from here to here, or from here to there, or from there to here. So of course, we go on a surface which is curved. And when we implemented this, it brought a tremendous effect on our surface outcomes, especially in the early days. First of all, it reduced the roughness by 1/3. So this is a measurement from our labs, which we see here, over the different diameters. This is without this smart pulse technology, and this is with this smart pulse technology. So we have seen that the standard deviation, the roughness, was reduced significantly. And there are some publications showing that this effect also is very beneficial. If we look here, blue is trans-PRK with smart pulse technology, orange is trans-PRK only, so no smart pulse technology. And we see the change, or we see the Snellen lines at day 1, or at the 1 week, or even after 1 month. So we can see that especially in the surface treatments, and especially in the first months, there's a tremendous effect coming out from this smoothness. And in the long terms, about 3 months and 6 months, it diminishes, but still it's in favor about the possibilities. This was a study from Aslanidis and Kimenonis talking about this and comparing this on real patients. He also compared the pain score, which was blue again with smart pulse technology and orange without. And we see there was less pain in the trans-PRK with the smart pulse technology, and also significantly less haze. So that has been very step forward, which was 2016 in our development. But as we also ramp up with the repetition rate to 1050 Hertz, we need an intelligent thermal effect control to take care about this. And I have a nice video which explains this. I jump from oops, sorry. Okay. So it talks about the approach of the intelligent thermal effect control. And I wish I couldn't stop it. Okay, and jump from it. So what we see here, the laser is firing, making a heat, a deponation, ablating tissue, and then this tissue is ablated, a little bit heat is deponated in the cornea and spreading around. And it's placed in a very clever way so that the energy fades away, as we've seen here, over time. And the next pulses can be set in a certain area to be in a proper, nice arrangement. So at the beginning of this, one spot made ablation, deponated some energy, increased some heat, but over the time, it is diminishing away. And while one pulse is diminishing, a next pulse can be placed. So as this pulse is at the beginning spreading around. So we see this here. This was a measurement with a camera which was able to grab a snapshot of a thermal load every second in time. And we see the ocular surface treatment temperature at the beginning was around 29 degrees. And the hotspot here was 32 degrees. So the temperature was really very low. Also here, this was with the Amaris and the camera, which was able to grab 350 images per second. So this image is really live on a real patient. And we see it is increasing by 4, 5 maximum degrees of Celsius, whereas most of the pulses had been in the blue area, so by 1 degree. So I don't want to dive further, but that has shown that it is very important to take care about this intelligent thermal effect control. And this spot, this fluence, this laser, and these parts and pieces are essentially important for the tracking. And you probably know that the Amaris has a laser repetition rate up to 1050 Hertz. The spot size is 0.54. The spot shape is super Gaussian. The spots overlapping in an optimized pattern. And this means for high precision in reflective correction, it is necessary to position the laser spots every 1 millisecond in a position preciseness of less than 5, or more, better, precise than 5 micrometers. And since the patient eye is not fixating, any eye movement disturbs this preciseness. And there's a study here from Aslanidis and Arba talking about this situation. And when we go further, we look on the eye tracker. We have a camera which observes the eye movements 1050 times a second, which gives the latency time or a reaction time of less than 1 millisecond. Then we have the image processing, and we show this in a live video. We have a main control unit which we input this offset coming from the measurement from the camera, including or adding pulse coordinates, and then we adjust for the scanner. The scanner needs to be positioned and the laser needs to fire, which also takes some microseconds. So this is a workflow in principle which is used from the hardware side for the eye tracker. So the spot positioning error depends on several parameters: eye tracker acquisition rate, eye tracker latency time, scanner positioning time, laser firing rate, laser trigger delay. And this can be calculated and expressed in maximum value and typical values. But besides of that, we also have the velocity of the eye movements, which is a combination of different velocities. We have saccadic movements with a speed of less than 170 millimeters per second. We have optokinetic movements. We have Vergence movements. We have miniature movements. And all of them can be expressed and sum up so that the maximum value of eye speed movements is 181 millimeters per second, whereas the typical value is much below of 85 millimeters per second. So this shows the importance of having a fast eye tracker, a fast processing eye tracker. Because here in this graph, we have the latency time and we have the pulse positioning error. If your latency time is within the 15 microns, you have a vast tracking error or pulse positioning error. The Amaris is working here in a low area, giving a very low pulse positioning error. But it sums up, as I want to make you aware of this, because we have also the eye tracker acquisition rate. If we go for a low eye tracker with 100 Hertz, we end up here having a high pulse positioning error again. With
You
the
have 1 more
Amaris
minute.
1050 Hertz, we are here in this area having a low positioning error. And that also further expands to the scanner latency time And we can imagine having a quick latency time with the scanner that's in favor for the pulse positioning errors. So we have dependencies. The spot positioning error depends on acquisition rate of the tracker, latency time of the tracker, scanner positioning time, laser firing rate, laser trigger delay. And there's no single parameter that alone minimizes the positioning error. It all comes together. And there must be find a combination, an optimal combination to minimize the error. You know about that we have the different dimensions, not only lateral movements, also the eye rolls and rotates. And then came up the idea with the latency free to compensate eye movements that occur in the period of the acquisition of the eye tracker image for triggering the subsequent laser pulses. And how it works is that the eye tracker performs a motion analysis on the basis of the previous positions during the treatment. And then it calculates for all 6 dimensions, for all directions of the eye, where the corneal target position will be in the moment of the next 2 consecutive pulses. And then the scanner moves to this position before the next pulse is triggered. And then the laser system knows exactly when and where the future laser pulse needs to be triggered. And this effect is called latency-free ablation, which is a perfect combination of speed, preciseness during the laser treatment. And what is more to say, there are plenty of presentations talking about this fluence, calibration, thermal load, and eye tracker. And I want to make you aware about the possibility to go on our homepage. If you click on our homepage, you find the info center and you find the subdirectory publication and outcomes. And you end up here where we have a database of 251 publications, all related to our products. And you can further select your products and select your topics. For example, if you select the Amaris product family and you are interested in the eye tracker topics, you will find 31 publications talking about the eye tracker, about eye tracking results, talking about the physics behind and some things you have seen in my presentation. So I would like to encourage you at the end of my presentation to have a look on this homepage, on this on these publications and have a deeper look to that. So thank you very much for your kind attention, and I'm glad to be here. Thank you all.
Thank you, sir. I'm sure Thomas will be there for the live demonstration. We have, after the PRK session, we're going to have around 7 or 8 cases, which will be live from the software itself. That means everything will be live, and you can help us. How do you plan it? So it will be live as though you're operating on your machine. Dr. Kumar, sir, would you like to introduce Dr. K.K. Mehta, sir? And
first of all, Thomas, nice seeing you. That was an excellent presentation. I just have one question, was that when you introduce the 7-dimension, so I have the 6-dimensional, how much difference is in your results with the 7-dimension? Does it make a significant difference, or it does not make a significant visual impact?
It makes a significant impact for the patients who you would typically say these are outliners, because it filters out the outliners where you have some surprising movements for any reasons. And of course, for patients with nystagmus, it also is a great advantage, a great help for that. So if you have no outliners, if they fixate rock stable, then there would be no need for that. But as you from time to time find patients looking around and you want to make sure that even these patients get the optimum benefit out of this treatment, then in this particular treatment and these particular patients, it is very helpful.
Thanks, Thomas. Now invite Dr. K.K. Mehta, who is actually the doyen of ophthalmology. For people who don't know, he was the first person to get the SIRIS into the country way back in 2004 or 2003. And I was the second person after K.K. Mehta. I got the SIRIS into the country, who's an authority on refractive procedures, of course, cataract and refractive. So he will tell us about his experience on the platform of Amaris. So he was first having the SIRIS, and then he shifted to the Amaris. Sir, K.K. Mehta, please.
Thank you. Thank you very much, Kumar, for giving me this opportunity. Let me shift over my screen and share my screen. My talk today is going to be restricted not so much on the practical side as with the fact that I started utilizing this laser, and we found that we could manage to literally shift onto this system. So basically, I'm going to talk to you about how I got the laser and how I used it. It's basically a non-medical talk. And when I asked Dr. Rohit, I said, why give me this talk? He says, because you bought the first laser, so you have to now talk about it. Having said that, let me proceed a little further. My story commenced actually in 1998 when I opened a new center and I wanted to have the latest equipment. And I decided I must have an examer laser. So in the initial days, the Schwind system was with Wipro, which was the IT giant. I approached many companies, including the Bosch and Lohm, and in those days also the Summit. But it was Wipro which entered the Lasik laser sphere, which stole the contract. I was invited to see at Wipro's headquarters at Shahjahanpur. And Wipro was very huge. It's very depressing when you go there. The place is almost as big as Sachivalai, which is literally a huge building. Those days, they were the king of computer and printer technology, and the setup was very impressive. But the person who I met was Azim Premji, who now, all of you know, is one of the top men or honchos, as one would go in the infra technology field. And he said, when he sat me in front of him, and he said, I was going to buy the Schwind-IPCL laser. And I agreed to everything he asked and agreed to everything I asked for. The deal finalized in 20 minutes over lunch. I frankly didn't have a chance to say no to anything. I thought, I would still have a time to decide whether I wanted to go for this or I wanted to go for the other alternates, which was the Technolas as well as the other units. But in 4 days' time, the laser was delivered to my home, long before my checks were cashed. So in came the first SRS laser. Now the interesting point is I live next to a bus station. And we were advised at that time, this was the first laser coming in, so Wipro advised us to have a special base which would be without vibration to fit the laser. So we literally had to go almost 4 feet deep, lay in a platform, a cement platform, then build on it, lay a second platform, and then use a layer of soil which would enable absorption, the vibrations before it went. I think probably mine is just about the only laser center which utilizes this total vibration-free technology. And of course, I also got in the first Carriazo pendula. Interestingly enough, when I first went to buy the laser, I thought of not having the Carriazo because no one had ever used it before. It was untried and literally there was no talk about it at all. But when I went to the stall and they put it onto a pig's eye and then pulled on the laser and say, see, even if I pull on the eye and the machine, it doesn't disconnect. You go and try it in every other place. So I went back to all the other places and tried it. The eyeball would easily come off. And I thought to myself, oh boy, this is a safe procedure, which is one of the reasons I picked up the Carriazo. Other thing I liked very much about it was the fact that it moved by itself smoothly without having to move horizontally. It was pendular vertical, which made sense to me. Having said that, we got in the laser, and that's my son with me when we started it. So then after that, since I was the first pendula coming in, Schwind was a little worried about it. And I hadn't been using a laser before that. Prior to that, I had only used the Bosch and Lohm Technolas laser, which was quite different. And so they told me that you have to hop into their place for an evaluation. So we went to Kleinosthin, which is about 360 kilometers from Munich, and but only 3.5 hours by car on the Autobahn. And that's their center there, which is at Kleinosthin. Those who haven't been there really should visit the center. And of course, I was invited in October, November, which was a time where it snowed like no one's business, which didn't make life very interesting because I don't like the cold very much. This was their headquarters. And the interesting thing was the little rock garden sculpture, which is Rolf Schwind's pride and joy. And I was particularly interested to ask him as to where did he get it from. And he said he particularly had got it from a place more than 500 kilometers away and had it specially installed. We were a little time with Thomas Wendler, and then subsequently we worked on the laser. Those were the original laser, as you noticed on the side, had the beam splitter and the camera running from the side, and it was a beautiful place. And this was with Rolf, very good host, gives excellent wine, I can tell you that much. Either way, 14 months after buying my new laser, Wipro decided and decreed that, oh, we are not interested in medical applications anymore. Almost broke my heart. I mean, you now have a new laser which is going to have no mother and no father to look after it. And at that time, fortunately, Care Group was coming up. And Vipin and I were in one of the international meetings, and I caught Vipin and told him, see, this is a great place. You have to join Schwind, and you'll be able to look after it. And I must say, he took up the gauntlet. And with Lal Dave and Vipin, over the last 25 years, they have really looked after it. And I must say, looked after it well. In the middle, as you notice, is Vipin. Of course, he's looking a lot older now. This is one of the older photographs. And this is Lal Dave, really a marvelous man. And with him, I really have nothing to worry as far as the Schwind was concerned. Then came the advent of the Amaris laser. The Schwind SLS was an outstanding success, as was the pendular microkeratome. In those days, you kept hearing stories about the other keratomes, how they stopped halfway, how the flap would go through, how they would get holes in the flap. And I would look at my laser and say, oh, God, I'm great. I haven't had any of this. Practice boom, life was good. Then came the new Amaris laser, promising more goodies and, most important of all, a better ablation profile. By now, I decided to get the first Amaris provided Rolf would come and inaugurate the laser, which he agreed to. This was the first Amaris which walked in, and this was our laser center inaugurated by Rolf and inaugurated by by Shri Krishna, who was the governor of Maharashtra, who 6 months later left. So I promptly called the next governor, who was Shri Jamil. I said, you come and inaugurate it again. And he's a technologically minded man. He was originally the governor in Bengal. And he kept over and spent quite some time with us, understanding all the details about the laser. And interestingly enough, we were upgraded as the Schwind Center for Excellence and Research. And with Frank Tenen, the chief technician, who became a good friend with us also, we used to have spend a lot of time. Then newer upgrades took place, and Smart Surf being one of them. Results were always excellent, which proved that the original choice of Schwind was correct. Smart Surf really made a great deal of difference. I mean, Thomas spoke to you about how it works, but the final result at the end of the story is the patient. He turns around, gets up and says, I'm saying great. That is the end of it all. He is the final arbiter, as one would say, of any technology. Our next laser, we were planning on getting in the beginning in January of this year. However, it went on what I call as a COVID hold. And I hope maybe in another 2, 3, 4 months from now, we should be getting our next play toy with us. And I look forward to spending more time with it. It really, the Schwind laser is an excellent technology. It's been a marvelous voyage for us. And we look forward to our next laser and what it will bring for us. Thank you so much for giving me this opportunity of sharing some of my old thoughts with you.
Very, very nice talk, sir. I think very inspiring also. And I think it's same thing applies to Thomas and his team. Nostalgic in many parts. And the way you have, the reason I wanted to talk is we've all heard about all your talks. Everybody here knows you. But we wanted the whole journey which you built around this machine and how you, how you learn from one machine to the other and how you've been loyal to this whole technology. That just shows that how good it is and how good it's worked for you. Dr. Kumar, sir, anything to add on to this? You are also one of the pioneers of this technology in the country.
No, I mean, I'm absolutely with Kiki, and I had, in fact, contacted him before I got the machine because he got it before. And I had got it through Lal Dave that moment. Unbelievable. I mean, he helped me through and through as he understands technology very, very, very well. I had a Mel 70 before that. So that was a Zeiss platform. Again, a Gaussian beam. Somehow I've always, like Thomas may not know, but I've always been a Gaussian beam guy. So I never had the flat top or the truncated flat top. None of these beams never came to me. So after the Mel 70, I shifted to the Schwind side and the Osiris and then the Amaris. And I've always believed in this. Luckily, I picked up the pendular. So I have also been for Keki Mehta sir that I had been to Cariazo, who's the inventor of the pendular microkeratome. And I was with him in Brazil for 2 days. So that was another great thing. And he's a very nice gentleman. Last time, if you remember, Rohit, he was in one of the conferences, and that's how I met Cesar Cariazo, and that was very useful. at that moment. So I mean, thank you, sir. Excellent talk. Your whole journey was very, very, very impressive, and it's always a guide for all of us.
Thank you, sir. Let's move on to the next session. Dr. Kumar, doctor, I want you to be also involved in the next session as a moderator.
Yeah.
And we are going to have Dr. Sharon, who is going to join, and along with you, and Dr. Sheetal. Three of you going to moderate this session. This is on SmartSurf. I mean, this is one of the very, very important sessions of the Schwind platform. Is about using it for the perfection of trans-PRK. So we have an interesting line of people who are going to share their experience. I think we'll start off with Dr. Naren is going to do the PRK perfect protocol for
Thank you, Dr. Rohit. So first and foremost, I thank even Care Group for arranging this wonderful webinar. Now, the first question which comes into our head whenever we think about haze is there actually a protocol in handling these kind of haze patients? So, as we all know, even with the perfect PRK and cross-linking, there is always a chance of haze. And once that forms, it really goes south. Now, definitely post-PRK haze is one of the complications which every PRK surgeon really is worried about. And that is one of the reasons why we thought, can we actually find out risk factors pre-operatively itself to see who's at a higher risk of haze, and also create a scoring system, and also try to tabulate a prophylactic management of these cases so that we prevent these post-PRK haze. So to do this, we did a study where we had two arms. One is the retrospective and prospective. The retrospective arm, basically, we looked at 238 PRK patients. We identified the risk factors and we tabulated the score. What we did is looked closely at the clinical assessment and also documented the densitometry. With the help of the densitometry, we document the and what we found is almost 9% of patients, of the total patients we had post-PRK haze. Of this 9 patients, 13 patients had low vitamin D, and 7 patients had high OSDI, and 3 patients had ocular surface inflammation. This was the guiding force. So what our hospital or NN did is we discovered novel markers or novel factors which helped preoperative itself to identify which is the factors which is actually causing the inflammation and causing haze. And this we published in our science paper also. And basically we identified these novel factors, and this was the main factor which created the altered wound healing and the cause for corneal haze. So let's look at how our cornea actually heals. First, there is activation of keratocytes. Then there is myofibroblasts and fibroblasts, and there is apoptosis. But if it is in abnormal conditions, when there is activated keratocytes, there is excessive myofibroblasts and fibroblasts, and this leads to aberrant collagen and haze formation. So in the second arm, which was a prospective arm, we looked at 450 eyes. We made them to go, we applied the risk scoring system, and then we divided the eyes into 3 groups, that is mild, moderate, and severe. And we applied the PRK protocol. Now, what is this, the scoring system? So we included the OSDI. As you all know, whenever there is abnormal OSDI, there is it's a very highly closely associated with the low vitamin D, and there is nociception and there is inflammation. Now, when we look at contact lens intolerance, usually is associated with unhealthy ocular surface, and there is gland dropout, and T-buds are very closely associated with meibomian gland dysfunction. We also included working environment. Why is this? As you all know, there is a very good correlation between ultraviolet radiation level and the incidence of late onset corneal haze post-PRK. And once we have done this, now we grade it into 3 things. That is, less than 5 is low risk, 5 to 10 is moderate, and more than 10 is high. So how do we use this or use the scoring system in this protocol? Now, this is the protocol which we have devised. So as you can see, first, obviously, you need to do the scoring, take good history, examination, and once you've done that, if the pre-op scoring is less than 5, you can just take them for surgery. But if the scoring system is more than 5, then make sure you put steroids, put the patient on steroids for 4 weeks in tapering doses, and lubricants for 4 weeks, and also on immunomodulators for 4 weeks, and tablet doxycycline 100 mg BD for 15 days and OD for 15 days, and take up the patient after 1 month. Now, intraoperatively, what we normally use is Ocuvel soaked BCL and also 0.02% MMC for 30 seconds. Now, in terms of visits, postoperative day 1, 1 week, 1 month, 3 months, 6 months, 1 year, this is a normal visits, and always, other than the routine things, always make sure you look at vision, NCT, SLE, and densitometry was looked at closely. Now, early postoperative patients who had less than 5 score were put on fluoromethyline for about 8 weeks, and the patient was put on lubricants for about 6 months, and if the patient had a vitamin D deficiency, it was treated. But people who had more than 5 score, it was first the patient was put on prednisolone for about 2 weeks in tapering dose, and fluoromethalone eye drops for 8 weeks, lubricant for 6 months, immunomodulator eyes for 6 months, tablet doxycycline 100 mg OD for 15 days, and again treat the vitamin D. Now, if there is an incidence of late postoperative haze, basically put the patient on prednisolone eye drops for 2 weeks, fluoromethodone, lubricants, all are the majority are the same. Also add on tacrolimus eye ointment for 6 months, and tablet doxycycline 100 mg BD for 15 days and OD for 15 days. Treat vitamin D deficiency. Also add vitamin C for about 3 months, and make sure the patient wears UV protective glasses for 8 to 12 months whenever he goes outdoors. Now, so when you look at the results, now when we look at coming back to our retrospective arm, we had 9% of the patients had haze, but in the prospective arm, when we used the protocol, we had about 2% of haze, which is a very significant change in the amount of haze. So basically what we're trying to say is whenever you do pay attention to the details, definitely the big picture will take care of itself. So what our study basically adds is the factor driving the haze was unknown till now, but the preoperative, but we have identified certain preoperative risk factors which help us to predict who are the patients at higher risk of haze formation. And also we devised a scoring system to help you guide through the protocol, which help you to prevent post-PRK haze. Now, the future, definitely, if you want the protocol to be 100%, just history, examination, and imaging won't be enough. You really need to add biomarkers into your clinics. But how do we do this? Now, or not just how do and where do we use it in diagnosing in our clinics? So we can always use it in post-refractive cataract surgery complications like haze, dry eyes, ectasia, and also in disease, looking at disease progression status like keratoconus and many other diseases. But for today, let's look only at predicting the haze. So we have, like I mentioned earlier, we have identified very novel biomarkers in predicting these haze. So basically what you can do is just from the tear film, if you incorporated it into a cartridge for a multiplex assay and use laser detecting based devices for reading. This is our initial data, which as you can see, it can easily pick up at least the important or most significant factors or the novel factors which can help you in detecting which patients are at higher risk of haze formation. And this is what we are creating in our lab. Basically, we are creating a molecular diagnostic and monitoring kit. And with the help of this microfluidic based chip, just in your OPD with just collecting with the shimmers, the tear film, you can put it into a buffer and add it into this chip. And this will be a very low cost device. Any doctor can have it in their clinic, and they wouldn't need for a big lab to invest in a big lab just to look at biomarkers. So hopefully the future is bright, and we hope for the best. Thank you for your time.
Thank you, Thank you, Dr. Naren. And I'd like to call upon Dr. Chinmay Sahu to present his case now. And at the end of the session, we can have some discussion on this.
I'd like to thank Dr. Rohit and the IOCare team for giving me this opportunity to speak today. The topic that I have chosen, or I have decided to approach upon, is how can surface ablation give us good results in astigmatism? So the first question that arises, how are the results of trans-PRK in astigmatism? There are multiple studies which have looked into this, and the study by Z et al., which used vectorial astigmatism to analyze where the average cylinder was around -1.11, and using Alpine's method, showed that at 6 months, 100% patients had an uncorrected distant visual acuity of 20/20. 93.6% patients were within 0.5 diopters of the intended correction. So the first take home is that trans-PRK is a viable and effective option for astigmatism. One small point, you can use the astigmatic software, which is easily available on lasikmd.com for your analyzing astigmatism corrections. The second question, how does it compare to LASIK and SMILE? The study by Zhang et al., which was a prospective study looking at roughly 80 eyes, and where the average cylinder was around 1.1 in each group, showed that the trans-PRK group had at 1 month, the uncorrected distant visual acuity was as good as the femtosecond LASIK group. And at 1 year, surprising, the refractive predictability was better in the trans-PRK group compared to the femto-LASIK group. In fact, in the femto-LASIK group, 6 eyes were found outside 1 diopters. So multiple studies have again looked into it. It suffices to say that trans-PRK compares well with LASIK for astigmatism. What about SMILE? In the study by June et al., which was a retrospective study where astigmatism more than 2.5 diopter was included, they used the 3-point technique for SMILE and they compared it with trans-PRK custom ablation, and they found that the results were equally good in both the groups. In fact, they said that there was a need for some adjustment in high astigmatism using SMILE because of the lack of a pupil tracking system and possible distortion for the docking of eyes. The Schwind system seemed to do better because of the static and dynamic cyclotorsion, which was controlled during surgery. The high order aberration seemed to, in post trans-PRK, there was a slightly increase in the spherical aberration, whereas in SMILE, there was a slight increase in coma aberration. So the take-home three is that trans-PRK compares well with SMILE. Obviously, SmartSurf is an excellent option. We have looked into that multi-center trial, which looked at the two conventional trans-PRK versus SmartSurf, where astigmatism up to 3.5 diopter was included, used epithelialization speed, corneal syndrome, and various visual parameters, and showed that there were significant differences between the SmartPRK in terms of the spherical correction and the spherical aberration. Also, the pain factor was much lesser in the SmartPRK or the SmartSurf group. So the take-home 4 is SmartSurf seems to be a better option. Now that we've established that surface ablation can work well, how about using an optimized wave, aberration-free or a wavefront optimized versus a wavefront guided treatment? A study by June et al. Which was a retrospective study, and it looked at astigmatism more than 1.75 diopter, showed, and where the average amount of cylinder was around 2.4, showed that the visual outcomes were comparable using in both the groups. The higher order aberration was better corrected in the corneal wavefront guided group because of the coma decrease. So the take-home 5 is that in most patients, an aberration-free profile can work very well. What do we do really in our own practices? We have this decision-making tree from the Schwind, which says that if the ocular wavefront and corneal wavefront is less than 0.25 diopters, you can directly go for aberration-free. Between 0.25 to 0.5, if the patient doesn't have any night vision complaints, vision is 20/20, still go for an aberration-free. Other than that, you need to look at the ocular wavefront, corneal wavefront differences. And if it's more than 0.35, maybe look at lens exchange or ocular wavefront treatment. Otherwise, you go for a corneal wavefront treatment. Now, how much does total ocular wavefront matter? Now, through previous talks by Samresh and various speakers, we've realized that The eye trace works very well in our practice, but a lot of us do not have it. This study by Artel et al. Showed that the total ocular hyoid aberrations were lower than the corneal aberrations in most of the younger patients, and that internal optical surfaces seem to be compensating for the corneal aberrations. So as rightly showed in previous talks, that if you go and treat the corneal higher order aberrations and miss out on the internal aberrations, you can actually create problems for the patients. So take home 5, if you do not have an aberrometer with you, how do you really go about it? There are certain indirect clues, like if your corneal order, higher order astigmatism, aberration is more than 0.5 and the patient doesn't have any symptoms, keep in mind that the lens could be compensating for it. On the other hand, if the higher order aberration symptoms are present, but the corneal topography seems to be regular, again, you have to be looking out for the lens as a possible culprit. Other clues are difference between manifest refraction and corneal cylinder, and difference between the axis of manifest and higher order refraction. Question 6, what is ocular residual astigmatism? Does it matter, and how can I incorporate it in my...
So you have 1 minute left.
Yeah, ocular residual astigmatism basically implies astigmatism other than the anterior corneal surface. A study by Alpine showed that more than one, you need to look out for it. Basically, there's a calculator called the Aura calculator, which is available on assort.com. You enter the corneal values and the refraction, and you can see that the ORA value out here is 1.37. If it's more than 1, you go for try to change the correction using 60% refractive, 40% corneal, and you see the intended treatment corrects. For a lot of people like us, this is a nice tool where we can try to get better outcomes in our correction of astigmatism. So this was the take home 6. How do I improve my wavefront guided treatment? This is out of the scope of this talk, but you can use vectorial mean refraction calculation, compare the ablation profiles, calculate the tolerance factor, and use the nomogram to fine tune your ablation and corneal wavefront guided treatments. So question 8, does epithelial map really matter? We all know that epithelial mapping is giving us a lot more information nowadays. On the Schwind platform, it's a refraction neutral profile. But if we do not, take home 8 is if you don't have an epithelial mapping and SmartSurf, please enter the central epithelial thickness as per the epithelial map. If you have epithelial mapping but do not have SmartSurf, adjust the target refraction. There is, if you are, say for example, the central epithelial thickness is 60 micron. So you would land up with an undercorrection, so overcorrect. If you do not have both, then manually calculate the central epithelial thickness on your ASOCT and adjust the target refraction. The centration of ablation profile matters. We all know the importance of pupil offset. The Schwind has an asymmetric offset, which actually takes care of most of the problems. But one quick take home is, if the if you're using aberration-free profile and the pupil offset is more than 0.2 millimeters, do not forget to enter the amount when you're doing the correction. Lastly, there are certain important intraoperative and post-operative cares to be taken preoperatively. Just ensure that the accommodation is taken care of. During topography, ensure that you have a SCC compatible image, especially important if astigmatism is more than 1 diopter. And preoperatively, do not overdo the paracane or underdo it. Please ensure proper alignment of the Myers. The room humidity plays a great role in over-under corrections. And longer the ablation time compared to intended time, more will be the irregular correction. So my take home is trans-PRK is effective in astigmatism. Look out for lenticular astigmatism. In most patients, aberration-free works well. Understanding of the ocular residual astigmatism can improve the accuracy, and proper pre-op planning and intra-op care can prevent refractive surprises. Thank you.
Very nice talk, Dr. Sahu. We will move on to the next speaker, and then at the end, if you have any questions, we'll go for the discussion. We'll have Dr. Amjad load his presentation. Can you stop sharing the screen? Yes. Dr. Amjad is here. He just texted me. I think he was there.
Yes, sir. Yes, sir. I am just.
Oh, yeah. Please share the. Dr. Kumar, any points you want to add for these two speakers before Dr. Amjad takes over?
I think Sahu covered it quite well. I mean, that's so true. Only thing I was wondering that if you have a high astigmatism of say 4 diopters, then how would smart pulse compare to a corneal wavefront guided work? I think you need much more tissue for corneal wavefront guided. So if you do a aspheric treatment on smart pulse for a -4, anybody, I mean, Rohit, your experience compared to a corneal wavefront guided treatment, because it was a thought in the olden times that if your astigmatism is 0.75 and more, it's better to do a corneal wavefront guided treatment than anything else that gives better results. But what's your thought on this?
If I start off, see, if in today's practice, if I'm doing a smart surf on a higher astigmatism, I would seriously look at the status of epithelium and how epithelium is irregular. Because if the epithelium irregularity, at least in 60% of my cases, amounts to close to a 0.5, 0.75 diopters from the epithelium itself. So that has to be really compensated for. If you're treating a -3 or something, that means 0.75. And irregular epithelium means that the topography, what you're taking, your customization has to take care of that. So for me, that is something very important because the talk about higher order, lower order, the values were all decided before people started using epithelial mapping as a routine clinical use.
So,
yes, Dr. Sahu?
So just one question. So for people like us who may not have the epithelial mapping, what I've worked out using the central epithelial thickness and using the ASOCT, is that a viable option or it wouldn't work out as, I mean, can that be a surrogate for actual epithelial maps?
I personally feel that if your volume of trans PRK is higher, then investing on a epithelial mapper is going to bring you more cases than actually financially it's going to be more viable than otherwise. People get really concerned about investing now, but I always feel that you start adding more cases which otherwise would never have been part of your refractive practice.
Rohit, I'd just like to comment.
Yes, sir.
I think it's a good idea to have epithelial mapping in any situation as per se, because I've realized that even when I'm doing my femto Lasik, it really helps me to have the epithelial map. Because sometimes I've actually, a lot of times I do an 80 or 85 micron femto flap. But sometimes, Rohit, I'm amazed to see a 68 or a 70 micron epithelium in the center. And that can be tricky if I'm planning an 80 micron flap.
Yeah.
So nevertheless, having an epithelial map is very, very essential if we are doing a refractive practice. And of course, to map a lot of other aberrations when we are doing a trans PRK. So I think it's what Rohit says is excellent. It's a good idea to have an epithelial mapping system in our OCTs, and it will pay for itself. It's just a matter of time.
And Dr. Sahu, what I would like to say is, in case you don't have it, you want to look at it later, but getting it done from somewhere else also makes a lot of sense because you'll have a clear picture. Because what happens is, ASOCT we have tried in the past when epithelial mapping was not there. It's quite it's not as simple and easy as you see a beautiful map of 9 millimeters from Avanti or one of these practice where you can just work on it.
And the reason I had the question was because in the system you can only enter the central and probably the peripheral thickness, but technically speaking, it's a 3-dimensional map that you're looking at. Would the ablation profile really get customized to that? Whether the Schwind would?
I think we can ask Thomas about it. Thomas, if you're here, the question is, if you are putting the epithelial map as 50 in the center and 60 in the periphery, would the laser customize based on what you have fed on the pachymetry? Will it make a difference? Thomas, if you're here, if he's not here, then he will we'll get back to him when he's coming for the next session.
Just a small comment also. The problem with the OCT, because majority of them take a sectoral imaging, and between the sectors, it tries to average the value and gives you the whole picture. So whenever it averages, we lose a lot of data. So, but here there's no averaging. Actually, it takes the overall 360 image and gives a 3D view of the whole picture. So that way, you don't lose data. It'll be much, much better actually.
And any
because
also, if I
Sharon.
As Dr. Sahu was saying, by using the OCT, if you are trying to put the caliper and then measuring the epithelial thickness,
Correct.
what happens is there's a lot of variability, as Dr. Kapoor was saying.
Yeah.
The observer variability, for a lack of better word, would be quite a bit, because even a small variation of where you place that caliper would change. And in a normal cornea itself, there's a lot of variability of the epithelial thickness from the center to periphery, and it's a lot has been published on that. And that's where the beauty of this technology comes in, because it takes into account that variability in a normal. And the advantage of having the epithelial map is that it is to pick up the abnormals, where we are assuming a normal change across the different parts of the cornea. So of course, as Sir was saying, Dr. Rohit Shetty was saying, maybe having it from outside would definitely add value rather than doing.
I think the point here is,
Sir,
there's nothing wrong in way you're doing it. Only thing is that if you have a big cylinder there and you want to be very bang on, then that is worth getting it done. Even if you don't have it, I'm sure somebody else will have it, and it can be done.
And using the Oraca, the assort.com calculator.
That's a nice way of looking at it. We have not done it. I think we can probably, at the end of the session, we can ask you about how you're doing it, so that people who are interested can try on this. It's a nice one.
As a feedback from Schwind side, what of course you can enter the central pachymetry of the epithelium and the peripheral, which you have measured. But as you only can feed in one value for the periphery, and if you have an OCT measuring the epithelial thickness, you have the epithelial thickness on multiple positions. So our official recommendation is you take the central value from your epithelial measurement, you feed it into the ORCAM software, and let the software automatically calculate the peripheral value for the epithelium. So only rely at the moment on the central epithelial thickness. Because there are other factors, like for example, the OCT system or the epithelium measurement systems measures typically perpendicular to the cornea, whereas the excimer laser goes under a certain angle when he ablates the epithelium. And then the distance traveling through the epithelium is longer than if you measure perpendicular. And this needs to be considered. And that's why we say in the central area, it works absolutely fine. Go and use this and let the software, the ORCAM, calculate the peripheral value.
Also, Thomas, I believe the epithelial removal is a refractive neutral on the Schwind platform, right? So would it really make so much of a difference as it's being pointed out?
I agree, but maybe in particular cases when the epithelium is different to what you expect, then it might have an influence. And especially if you have a difference in the superior or inferior area, then which one would you use?
True.
Let's move on to the next session, next cases by Dr. Amjad. He's going to discuss some case-based approach on smart surf planning. Dr. Amjad.
Good evening, everyone. At the outset, I would like to thank Dr. Rohit Shetty for having given me this opportunity to speak on this platform. And it is indeed a great honor to be speaking in front of all my three mentors as far as refractive surgery is concerned. I've learned a lot from Dr. Rohit Shetty, Dr. Kumar, doctor, who has taught me refractive surgery right from my case one, and Dr. Mehta, K.K. Mehta, sir. This is the reason why I have the Amiris platform. So as discussed with Dr. Rohit, I would like to put up a few cases for discussion on the platform. So let's start with case-based approach on smart surf planning. So as we all know of all ablation techniques, that is lenticule removal or Lasik or a smart surf or the surface ablation, smart surf appears to be the best viable option because it leaves your posterior stroma quite virgin. And then there comes up this criteria where to use what and in which situation. So this is one particular case This is a 24-year-old male. Right eye pachymetry is 514 microns, left eye 525 microns. You can see the subjective refraction. Right eye is 2.5 diopter spherical minus with a -2 cylinder at 10. And left eye a -3 diopter spherical with a -1.5 diopter cylinder at 170 degrees. These are the pachymetry maps. Everything looks, this is a refractive map where the point to be noted is the Kmax. In the right eye, it's 49.9 diopters. This is the Bellin display. Doesn't show any anterior elevation, doesn't show any post back surface elevation, but the final D value appears to be in yellow. This is the pentacam image of the left eye of the same patient where the Kmax is 51.2 diopters. This is the Bellin display. Again, no elevation either on the front or the back, but the final D value is in yellow. This was the inter-eye corneal symmetry ratio, which we get on the pentacam. I'm sure most of us are well versed with this. So I would like to put it to our moderators, to Dr. Rohit Shetty and everyone around. What would be the approach? What would be the choice of treatment in such a case?
Could you go back to the 4 maps again? And this is how much was the power? -3, is it?
-3 spherical and 1.5 diopter cylinder.
See, grossly, it's on the corneal plane. You're looking at close to around 2 diopters of cylinder, right?
Yes, sir. Yes, sir. Subjective refraction.
So when you have so much of a cylinder, your posterior and all your best fit spheres elevations are very confusing.
Yes, sir.
At this point of time, see, only thing is that the thinnest point has shifted down a bit. It's a 528 microns on your pentacam. But otherwise, I'm not really, elevation, I'm not really, you can't comment on this kind of a cornea. And most important thing which you have mentioned, which you have to see here is, you are looking at a corneal white to white, which is 10.3 millimeter. So the best fit spheres of any kind has not been designed for 10.3. So your complete cornea is actually a normal cornea, but your bad Ds and everything is because the fit of your best fits is completely different in this case. Look at that, it's a 10.3 if I'm right. Just below your red where you have circled it, if you can put your cursor, just above the next to that, no, to the right side, below that, 10.3. So it's a very small corneal white to white. Anybody else has to say anything on this particular scan? According to me, it seems good for me, but like I said, if you even a Lasik would do well, but if you feel that, yeah.
Rohit, I mean, here, as you said, it's a small cornea. So 100% I wouldn't prefer a microkeraton.
Yes.
So I have a Zimmer femto, so which actually applanates the cornea, makes it flat, and then makes the flap where you can actually control the flap diameter. So it's not a candidate for a blade LASIK. Otherwise, because I don't know how they have this max front of 51, when here you have 45, 46 on this diagram. So how did it reach that figure?
It's there at the top, 51.2.
In the top, right. Okay.
Yeah.
So, but still, I don't mind doing a femto LASIK, not a blade or a surface.
Yeah.
Dr. Rohit?
Dr. Kumar?
Dr. Rohit, could this high max be because of the small cornea?
I think that you see, this is
The false, yeah.
False, abnormally small cornea. That's what when he was making a presentation, I was looking at the maps. I didn't look at that's why I asked him to go back. It's a small cornea, so all your parameters of indices you have to throw out of the box. None of your indices works here. But according to me, apart from having a small cornea, this looks healthy to me.
It would be good to see the raw image actually of this map.
Dr. Rohit and Dr. Kumar sir, how are your experiences using surface ablation? Because sir is talking about femtosecond LASIK, but would surface ablation
Yeah,
also
yeah,
work well here?
it's a -3 cornea, and you don't have to worry about it. And I'm a big fan of surface, so surface would work. I mean, see, one of the challenges of these kind of corneas is, see, normally you don't have a 10.3 white to white cornea. That means that there has to be some pathological genetic changes in him to have a smaller things.
Cornea.
In these cases, even though it's perfectly normal, you don't know what happens when you make a cut, how the eye heals. So it's always better to go on a surface. So for that reason, even though it's a normal eye, I agree with Dr. Kumar sir that it could do, but it's a surface would be the safest option. Can we move on, Dr. Ramjit? I mean,
Yes,
that's the most important take-home point here is please look at the white to white in any form of topography before you comment on your curvature maps or elevation of bad D, because bad D and all of them are completely false in this. So anything less than 11 millimeters, you're absolutely have to forget about your indices.
Also, isn't the bad D, the normative data is actually the Caucasian and not Indian?
It's close to, they have used close to 11.8 to 12 millimeters. So you are actually 2 millimeters less here. So
Yes.
you cannot fit the same criteria onto a 10.3 or 10.5. Anything less than around 11, I would be, that's why first thing I check when I saw indices before I move to the indices part of it is to check what is the corneal white to white, the corneal dimension. That's a big take home. Very nice case. Let's move to the second one.
So this is again a 26-year-old female, right eye 476 micron, left eye 480 micron, the central thinnest point on pentacam. The refraction, not very significant, -3.5 diopter spherical and 1 diopter cylinder on the right eye. Left eye 2.25 diopter spherical and 2 cylinders in the left eye. Topography map. This is the pentacam image. The thinnest point is 476 micron, slightly high IHD. The elevation map looks normal. Only thing is the final D value in yellow. And this was the left eye. Again, the thinnest point, 480 microns. This was the Bellin display. Again, sir, what would be your choice of treatment?
See, I'm very legally 480 is a cutoff. There is a legal some document during the time when we had the issue with the ectasia many years back when AIMS had that issue. So there was a legal document of 480. So it does not mean that we can't do it for less than 480 if the cornea is healthy when you are treating a -2 or 2.5, some range like that. But we have to understand that if it ends up in an issue, legally we are not protected here. That is something which is, so legally it's a different ball game. But this cornea looks healthy other than just being a thinner cornea. And, if the patient is very demanding and understands this, you can do a PRK, trans PRK, but absolutely no Lasik or smile or any other procedure. Dr. Rishi, would you like to say anything on this? Or Dr.
I agree with you.
So would corneal biomechanic, examining it and then doing it make more sense?
No, it doesn't matter because biomechanics is not going to help you with this because it's, even if it's strong or less, doesn't matter because it's your volume of tissue you're taking. Dr. Kumar, would you differ on this?
Actually, I know that 480 is a cutoff, but we have done at 470 also. But as you said, legally it won't stand. And anyway, on the surface, so not going in, so the biomechanics is out.
So only thing
Also, sir, when we look at these borderline thicknesses, do you cross-check it on other platforms like the anterior segment OCT or some other?
OCT base is a very important one.
That's exactly what I.
Because sometimes you get variable measurements, and then you're again confused as to what you're supposed to do next.
Yeah, OCT base is very important.
Yeah, because that's exactly Dr. Amjad.
Yes, sir.
I was just thinking that, a lot of times I've had pentacam would give something and cirrus would be just maybe 8 or 12 microns higher.
So it's a mix and match.
So what we have noticed at our center is pentacam gives us 10 microns higher than the ASOCT on OptoView. So anyway, we are already looking at slightly higher readings. So maybe ASOCT in this cases will be.
ASOCT is the gold standard because it is not dependent on your motion artifacts. It's not dependent on many of the factors. What happens with your shine flow or a slit scanning. So what ASOCT says, you have to follow it. But like I said, this case can be done. Just keep in mind that inner corneas have, I mean, only thing is that legally, otherwise this is a healthy cornea. The thinner corneas are not unhealthy. We have had patients with 430 corneas and no keratoconus and very healthy, and they're not going to develop anything. So it's just like the height. Some people are born as dwarfs, and they're not that they are unhealthy by any way. They also lead their life normally, and their lifespan is also as normal as you and me.
Dr. Rohit, can I also butt in and ask one more question? Like when I see a borderline cornea, I somehow feel safer when I'm doing a male patient compared to a female, especially if she's not married. Would that be again a valid thought?
A healthy cornea, male or female, doesn't really matter because the only time the male and female matters is if you are treating a female keratoconic eye where you're worried about progression or estrogen. The estrogen during pregnancy has a different effect on the corneal collagen. Otherwise, if you're treating a healthy male or female patient, you should not be worried. In fact, the only thing which I'm worried would be the amount of outdoor, whether this male or female would, after you do a PRK on this patient, because haze factor. But thinner corneas very rarely have haze. Thinner cornea, sometimes when you have a thin cornea, I don't even do a mitomycin on it. The reason being thinner corneas, the amount of keratocytes and the way they change into myofibroblasts, all those them are much lesser. If you really look at your haze pattern, if you go back and see, it will always be on a thicker corneas. Thinner corneas didn't do. But not that I'm advocating not to use mitomycin, but in a case like yours, -2 or 2.5 diopters, and you just can do a simple procedure and be done with it.
So what are your normal mitomycin C protocols? The same as minimum 20 seconds and maximum a minute?
No, I would use 10 seconds for every diopter. Is that correct?
Yes.
And if the patient has an outdoor activities, probably use it little more. If the patient is an outdoor active, say for example, we get some marine engineers. So marine, those people go on ship. Merchant Navy. We get a lot of merchant navies. We get a lot of people who are to join for police who will be outdoors. If your outdoor activities is more than at least 3 to 4 hours a day in the peak sunlight, then your mitomycin and your vitamin C has to be given differently, because these are the people who develop haze because of UV light. So asking history before you do any of these PRK procedures is very important, because that itself will tell you how do you titrate it. So somebody's work is completely indoors. That's what Dr. Naren said, that if you are completely indoors, vitamin C's and all those things don't really work for you. I mean, you don't need it, not that it works or not, because there is no UV light exposure. And I do sometimes ask for people, for example, if you're treating a patient from Goa or treating a patient from Bangalore, the haze potential is completely different, because we are above sea level or somebody's at sea level. And we have had patients when they come to us with late onset haze. The first question I ask them is, did you change your location from where you were before? Many times I've had this patients telling, yes, I was in Bangalore, then I moved to Infosys or Wipro in Mangalore. So you are at a certain high level, sea level, and then suddenly go to the sea level where the UV light is different. And a lot of people suddenly become different these are all important things for a PRK when we sometimes don't ask. When you do a PRK, a lot of people suddenly change their lifestyle. Suddenly become, okay, they do a surgery and suddenly start running marathon or cycling in the morning. So all this sudden change in the pattern exposes themselves because they got a surgery done. All this sudden exposure in the thing exposes themselves to more UV light, which changes, these are all the causes of late onset haze. Late onset haze is just driven by how your keratocytes, when they're healing, suddenly become myofibroblasts and then suddenly start becoming rogue cells, which creates haze. So these questions which I mentioned are very important when you ask them, and this can, so sometimes I use mitomycin for even if I'm treating a -1 or a 0.75, because I know that this patient is more outdoors.
Dr. Rohit, and one of the speakers, Dr. Hafezi, I think, has shared his experience in the talks of not using mitomycin C at all for haze. Would it be population dependent, like in Indian population, it would not?
See, any of these talks has to be taken in that direction, that in fact, when he starts and when he talks about these talks, he says this has to be looked at it from the which geographical location you come from.
So in our population, you would still recommend using mitomycin C, absolutely.
Mediterranean temperate climates are completely different compared to where you come from, and you just cannot compare that. So I feel that we have to use it based on the number of hours he spends outside.
Sir, what would be your protocol for mitomycin C in such cases, those who want to join merchant navy or those who want to take up?
I would give maybe around 5 to 6 seconds more.
More per diopter, sir.
Yeah, if I'm just, let's say he has 3 diopters and I'm giving, normally I would give 10 seconds. I'd keep at 45 or 50 seconds or 60 seconds. So see, when you mitomycin is in a very simple way, it's in a very nice way. It has been used as a thumb rule, like 10 seconds per diopters, but it is completely forgotten what the person does outside. That's why you have to put a lot. It has to be written in your case file where and what is happening, which place he comes from. As somebody coming from Goa you would use mitomycin. I would use mitomycin even if it's a -1 diopter, because he goes to something which is full of UV rays, and his profession is on the road. I mean, he's you need a different mitomycin, please. On what type of occupational he's in and how much time he spends. Can you move on to your next case quickly?
So this is a patient he had old subepithelial infiltrates which led to scarring. This was a topo map showing the scarring. This was the pentacam images. The pentacam images were quite clear, except one isolated area of posterior floor in both the eyes. So what would be the treatment options, sir? Lasik or surface ablation?
Sheetal, would you like to comment on this? Sheetal or Sharon? Let's ask them first and then I'll comment on this.
Can you go back to that format, Dr. Hamza?
It's basically pentacam is showing irregularity because of the scar. So
how long after the original?
It has been around 42 months to be precise, because 42. We were only treating the patient since then.
Okay, and he had no flare-ups of the infection?
Initially, we treated the patient for 9 months and then he was okay, left to scarring, and then he was lost for follow-up, and suddenly with his age, finding difficulty for presbyopia, wanted to get it corrected. It was a very keen patient too.
So basically the question is, do you want to cut it, or you want to do a smart surf, or you want to cut the cornea?
Yes, sir.
Frankly, I would, yeah, go ahead, Sharon. I'll talk about that.
No problem. So if it would depend on where your opacities are located. If the opacities are a lot in the visual axis, then probably doing a PRK would remove the opacities as well. But if they're not that many in the visual axis per se, then it wouldn't matter. The posterior elevation may not be a true depiction if that, it may be the opacities which are causing some erroneous pick of that posterior elevation. But my bigger concern would be that, make sure that it's totally quiet. Patient has not been on steroids for at least 6 months or, more if possible, been on some sort of tacrolimus or cyclosporin. Otherwise, you can have very bad recurrences post doing a refractive surgery. There can be a flare up. So
basically,
that would be
absolutely.
Yeah, what I feel is actually the subepithelial opacities or scars should not give a posterior elevation problem. Something like I would expect a posterior elevation problem, something like in an endothelial dystrophy or things like that, you know. So I don't know whether this posterior elevation is because of this subepithelial opacities. But having said that, if
just
you,
one thing here, I will like
I
to.
think it's an artifact.
An artifact, yeah.
It could be,
exactly.
yeah.
It's not a real elevation.
Yeah, Sheetal, what
Probably.
I've seen this in epithelial, when you have a very irregular epithelium on the cornea, because there is some optical light scattering event, something happens there, your posterior elevation is never right in the
elevation
form of topography.
Reliable,
So you
yeah.
have to ignore it. Dr. Rishi, what would you do on this? Map or Zap? Zap
Can I
is
just see the previous map?
But in general, what
I mean, any irregular cornea, I'm going to do a surface ablation. I mean, and if you see the central area, that is showing quite a bit of asymmetry. If you go to the right one, next, yeah, you can see it's the left eye, isn't it? Which had the, so there is a significant amount of 43 and 46 in the central area. So I would certainly go for a surface ablation.
Wouldn't it be a better idea, Dr. Rohit, to go for PTK first and kind of take care of this?
You can do a topography guided ablation.
Let the
the depth is very, very superficial. You don't.
Yeah.
So let the, after PTK, let the refraction settle down again and then do PRK or whatever.
One shot you can do it, because you know it's a very small
very small opacities.
Not small opacity, and they're not usually not in the central area also. So I think you can do a PR, but you know these cases can recur also. So that's something which you keep in mind. So mitomycin and keeping them on tacrolimus and post-operative would make a lot of sense. And these patients do well with omega-3 fatty acids, because omega-3 fatty acid has a component of resolvins in it. So resolvins are the ones which cause scarring. So I would use omega-3 not as a dry eye anti-inflammatory. I'll use it more for the resolvent part of it.
So with
Rohit, what about cyclosporin?
To which
Yeah, 6
surgery
to
you
8
would,
months. Yes.
Cyclosporin also.
So would the age of the patient matter according to which surgery you would choose at all?
No, not really. Like I said, for me, what really matters, if it's an older patient, I would do a Lasik, because 40, 50, because then, you know, cornea would have been biomechanically thicker. And one thing is important is that biomechanical corneas, the age will take care of it. But when you do PRK, the most important question which commonly missed is you're asking them what you do and how much time you spend outdoors. I'm repeating it again, but it is very important. We never bother. We assume everybody is a computer engineer who comes to you for Lasik. I mean, that's what in Bangalore we think, and Hyderabad also.
Yeah.
And there are other professions in life, like people who are construction engineers, marine engineers, and all that stuff. So they are the ones who come to you suddenly with a scar, which you can't explain.
So we come across all struggling TV actors.
They are also important. You know, they are exposed to different kind of lights. And that's why they use those UV lights to see their wavelengths and all that. I mean, I'm sure that it must be having some effect. You should probably study about how the lights can affect all this.
Right.
Thank you, Dr. Amjad. We'll move on to Dr. Rishi Swarup now, and he's going to give his talk.
Thank you, Dr. Rohit. At the outset, I'd like to thank Narayan Nitrale. I've consistently been part of all your webinars, and I think you'll have to unshare. Dr. Amjad, please stop share. Yeah. So I'd like to thank Dr. Rohit for inviting me. This is a fabulous webinar, and I've learned a lot. And it's amazing that you managed to get such a wonderful attendance again. Just goes to show what high quality content there is. So the topic which has been given to me is trans PRK, is it better than the rest? Transepithelial surface ablation. So I had done this exercise once before for a talk of transepithelial PRK I had to do. So I decided I'll pull out my data for the last 2 years. And I was again happy to note that surface ablation still constitutes a very large chunk of my corneal refractive procedures. There is a small pie for SMILE there, and probably that may not be very representative because we've just got the Visumax machine just before lockdown. So I suspect that pie might be a little larger if I present this talk next year. So I think a lot has been said already, and I will not bore you with repetitions, but basically it's very important to understand that the main advantage with transepithelial ablation is that you're not removing the epithelium manually, but you're actually removing it with a laser. And we know that when the laser strikes the epithelium, it appears bluish, and when it strikes the stroma, it appears red, as you will see when the ablation moves from epithelium to stroma. So that's one of the ways to know when you have started moving on towards the stroma after the epithelium is over. In conventional PRK, you're just removing it, but because you're removing it with alcohol or some other agent, you usually end up removing a much larger area of epithelium than what you actually need to remove if you're going to have an ablation zone which is smaller. So your epithelial defect will end up being larger. Even if you're doing a two-step transepithelial PRK in which you're doing a PTK first to remove the epithelium and then doing the stromal ablation, which many of the older machines were doing, you would have that disadvantage that you'll end up with a much larger epithelial defect. Plus, you'll have a gap between your PTK and your PRK, during which time you'll allow for desiccation of the stroma. So the transepithelial PRK, the main advantage is as soon as the epithelial ablation is over, the stromal ablation takes over. So it happens in one smooth movement. You save time, and your epithelial defect is exactly the size of your ablation zone. So smart surface already been covered. Basically, it's the new technology which allows for a faster visual recovery. In fact, immediately after surgery, the patient sees quite well, which is typically not what you would expect with the surface ablation. Although after 2-3 days, the vision will drop a little bit and then again recover. And it's important to tell your patient that, otherwise they'll get very panicky. They also have lesser pain and lesser haze. So why should one be doing transepithelial PRK? It's a shorter procedure time. The epithelial defect is smaller, I told you. And because of this, it also heals faster. So the patient traditional problems of PRK are lesser with transepithelial PRK. It is effective, and several studies have shown that it works as well as any other corneal laser procedure, even for higher ablations. It avoids the need for scraping or the use of alcohol, so lesser complications. And epithelium is really the best masking agent. So if you have irregularities in the stroma, a few bumps here and there, epithelium is filling that up. When you remove it manually and then do the ablation bed will also be as irregular as it was when the epithelium was removed. So it's good to use that masking agent and get a smoother bed at the end. And of course, we all know the problems of flap procedures or cap procedures, and that advantage of surface over these is certainly there. And recent studies have shown that even large ablations, if you use the right agents, you can get pretty good results with surface ablation as well. This was a study showing that transepithelial PRK actually by third day itself, the epithelial area predominantly heals, which is very similar to Lasik. So compared to traditional PRK, which would probably take a day or two more. So we talked about this two-step versus one-step, and main advantage is the desiccation is lesser because it's shorter, epithelial defect is smaller, and also the hyperopic shift is lesser because if you're doing a one-step PTK ablation, your ablation of the epithelium is just plano. It is peripherally and centrally the same. But I think Mr. Thomas also referred to this earlier. In the periphery, you will end up, because the light is traveling in an oblique fashion, you will end up with a hyperopic shift because of this if you just do a PTK ablation. And that's why the Schwind has a custom profile in which the peripheral ablation is little more compared to the central ablation. And we talked about epithelial thickness maps. So it's very good that now in the newer softwares of Schwind, you can actually alter the amount of epithelium that has to be ablated. And accordingly, the peripheral ablation also can get altered. So thereby basically, because of this differing profile of the epithelial ablation, there's no refractive effect of this epithelial ablation, which is a big advantage over the other machines where you do a manual PTK followed by ablation. Also, the tissue wastage occurs whenever you are doing it for a thinner cornea. For example, if you were if your epithelium is thinner, you will end up ablating more stroma. So if you have the epithelial thickness map, you can actually customize that and avoid wasting tissue. So you won't really have a refractive effect, but you'll end up unnecessarily sacrificing a lot of stroma. It's also useful in the optic zone planning, and basically your epithelial defect size will be exactly the same as your optic zone size. And if your epithelium is thicker and your machine has not incorporated that, you will sometimes, if you're doing a myopic ablation, your optic zone may actually shrink. And this was a very nice paper by Dr. Shady Awad and group, which showed like a theoretical analysis of the refractive and the ablation zone, optic zone effect. So what he showed was if your epithelium is thicker than what is being entered in the machine, you'll end up with a smaller optic zone, even though your refractive effect may be the same. And of course, if it's thinner, you will just end up ablating more tissue and wasting tissue. Another thing that they studied was if your variation of the epithelium from the center to the periphery is different from what the machine is accounting for, you can end up with a refractive shift which can be up to 0.66 diopters. So trans-PRK is pretty simple. You don't really have to do much, but one thing one has to keep in mind is that your surface should either not be too wet or too dry when you're starting. If it's too wet, you'll end up with an undercorrection. And if it's too dry, you can end up with an overcorrection. It should just be just right. And the way I do it is I wet a Merocell sponge completely, and then I squeeze out the complete fluid and just do a gentle stroking of the surface before I just start the ablation. Another important point to remember is if you are going to be ablating a small refractive error, say about less than 1.75 diopters, better to go for a slightly larger optic zone. Otherwise, you can end up with a undercorrection. Topography guided ablations are useful in irregular corneas. And again, here a transepithelial ablation is very useful because your epithelium is filling up all the irregularities. And so you can get a much smoother bed. And it acts like a perfect masking agent. And smart pulse technology has taken that to the next level. So this is just a video to show that the epithelium shows up as blue. And the moment you move towards the stroma, it becomes red. So that's one of the ways to know when you have crossed over to the stroma. And of course, it's important to apply mitomycin C. It's important to apply it over the entire ablated area. Sometimes some people just place the sponge in the center. And because the cornea is curved, the sponge will not cover the size. So it's good to move around your sponge rather than just place it. This, I think, is going to be covered in the next talk, so I'm not really going to elaborate more. Trans-PRK has outperformed the traditional PRK in almost everything: dryness severity, soreness severity, sharpness of severe pain, and also stickiness of eyelids. Interesting thing which is noted in this particular study was the number of people who used to come back with stabbing pain 1 week after the epithelium has healed was almost 10% in the PRK group compared to the trans-PRK group, which is only 1%. So I think pain scores overall, and also the surprise pain after the epithelium heals, sometimes you have these recurrent erosions. Those are much lesser in the transepithelial PRK. And I suspect that is because you're really not doing anything with a blade. You know, the edges are where you can have a problem and you can have recurrent erosions. And because here everything is done with the laser, your edges are perfectly adhered. And I think that's why you don't have these recurrent erosions afterwards. In addition to your traditional refractive errors, I think it really helps in corneas where something has already been done, like a Lasik or a PRK or a graft, or if you have irregularities from scars, or if it's an ectatic cornea where you're combining the cross-linking. I think these are specific indications where trans-PRK has a beautiful role. Just a few cases to show how beautifully it has performed in irregular corneas post-graft, and here post-RK, you can see the difference map and a nice smooth post-laser ablation profile. So trans-PRK is no blade. It's actually the true bladeless and touchless procedure. It's even more blade-free than the traditional femto Lasik and smile, because you're really not touching the cornea with any metallic instruments. So the least risk of having an infection, if you ask me, is in a trans-PRK surface procedure. So is it better? Yes, it is better. Thank you.
Perfect. I think I completely agree with you. Being a big fan of trans-PRK, with all this pain, new managements hardly see any pain. So what percentage of your practice is trans-PRK now, that you also have?
Almost 60% right now, but I think the smile is picking up quite a bit.
Thank you. I think we'll move on to Dr. Ritika. I think she's going to have a quick overview of the pain management. Dr. Ritika is a refractive surgeon and based out in Mumbai. And she worked with me on this very important paper, which kind of changed a lot of practice into how do you control or reduce pain. Dr. Ritika.
Thank you, Dr. Rohit, sir. So at the onset, I'd like to thank Dr. Rohit for giving me this wonderful topic, which is pretty close to my heart. So the main problem with any surgery is we need to combat every part of that surgery. And PRK being a very old surgery, we thought it would have good results and it would continue to go forth. But a lot of surgeons have stopped using PRK, and that's probably because of the post-operative haze, which Dr. Narain already spoke about, and the post-operative pain that goes along with the surgery.
Ritika, you need to make your slide bigger. You're not clicked on your slides. You're not seeing your slides.
You're not seeing the slides?
No. You have to, which is your presentation. So what you have to do is, I think you have
to stop sharing and I'll share again.
Yeah, you have to.
Yeah, stop sharing, open it in the PPT and then start sharing again.
Yeah. Otherwise, it will not come.
Yeah, Can you see my screen now?
Yeah.
Yes, it's visible, yes.
Yeah. No, it's on the presenter. Yeah.
Yeah?
Yeah, perfect.
Okay, great. So I'll be concentrating on the post-operative pain. And this post-operative pain scares the doctor probably more than it even scares the patient, because after doing a perfect surgery, no one really wants to see the patient the next day in immense pain. And we've done a lot to tackle this pain. What we initially tried was to use topical NSAIDs, but unfortunately, when you use topical NSAIDs, it just washes out of the eye really quickly and the patient is still left miserable. So we were wondering if we could actually use it in a depot form. And what we used was a bandage contact lens soaked with 0.45% ketorolac. We chose this because it was effective in reducing pain. It was preservative free, which was really important, and it had less side effects. So what we did was first we cleaned the BCL package with 99.9% alcohol, and then we waited for 5 minutes for that to dry. Then we injected 0.2 ml of Acuvale inside the bandage contact lens package and left it as it is for around 20 minutes, during which time we completed the PRK surgery and then took this lens out of the package and placed it on top of the patient's eyes. Now, what we noticed on the first post-operative day after doing this was that the patients who did not receive this Acuvale soaked BCL, their pain was around 8 on the Wong-Baker's pain scale. But the patients who did receive this Acuvale soaked BCL, their pain was only around 2. And this change in pain was significant. And the patients were also feeling much better with it. Now, I know as corneal surgeons, most people would be worried about the healing. But what we saw was there was absolutely no difference in healing in the patients who received the Acuvale soaked BCL or who didn't. So that was a big relief. So now we knew that this worked, but we wanted to know exactly how long it was working. So we did an experiment in which this Acuvale soaked BCL was placed in an Eppendorf tube and taken to the laboratory at 4 degrees, where high performance liquid chromatography was performed. And we saw the Acuvale concentration at various time points. And this was depicted in the form of a chromatogram. And so what we exactly saw was that there was a single peak drug detected, which meant, yes, Acuvale was present in solution. But also what we saw that it kept increasing over the first hour that we tested and then stayed stationary over the 6 hours tested. So this constant increase over the first hour was great because that's when the patients actually need it, when the anesthesia wears off and they've just had the surgery and they are really in a lot of pain. So this is tiding over that pain for sure. So we were really happy with these results. A small but significant step that we did was to clean the BCL surface. Now, it's a small step, but it's important because when we did an experiment to see for the sterility of the surface, we noticed that when we did not clean the surface, growth was seen. And avoiding this step can actually result in a lot of post-operative complications, which can totally be avoided by just doing a small step of cleaning the surface. So delivering the topical NSAIDs through the soft contact lens by adsorption is a novel technique which allows for longer duration of analgesia. Now, I know we have spoken about this before, but we recently published it, and why it's again come into being is because AccuVeil was unfortunately not available recently and people were not able to get a hold of it. So now I believe Entode has taken it and it's is making it, and it'll be available next month, and even Microvision is working on its own composition for it. So I think it will be available soon and people will be able to do this. Having said this, is this the only way that the pain in PRK is managed? Unfortunately, the answer to that is no, because even in the studies we did, we saw that there was approximately a 7% failure rate, and we were wondering why was this the case. And we had always done the preoperative confocal images where we went back to these patients who actually had pain despite getting an AccuVeil soaked BCL. And what we saw was that these patients had multiple dendritic cells at their nerve endings. And the tears also showed increase in cytokine levels. So all this pointed to inflammation, just like in Hayes. In pain also it pointed to inflammation. So multiple dendritic nerve endings with raised inflammation, high OSDI scores, coupled with low vitamin D and the personality of the patient all resulted in pain. So it's really important, if you already know this is there, to treat this before and then do the AccuVeil soaked BCL after the surgery so that you're not left with any surprise pain post-surgery. So preoperative inflammation, both clinical and molecular, can be a reason for increased pain for the non-responder. So we need to keep this in mind, treat everything, and then go ahead with your BCL soaked in AccuVeil to get the best results. Thank you so much.
Thanks, Ritika. I think this was a very important paper. One question which, before everybody asks, I would like to ask you is, AccuVeil is not available everywhere, and it's always difficult to get it. So one thing on behalf of Ritika I'd like to answer is, because of this last close to a year, we have worked with at least few companies to push them into bring this kind of exactly the same molecules of AccuVeil for all our practice, and kind of successful in this because both I know that Entode and Microvision are going to launch the same preservative-free molecules into the market by next month. And in fact, Entode also has a name to it. So they are already registered, and Microvision also is not too far behind. So I think for all people who want to use this, I think this is a fantastic thing. And my post-ops are all handled by Dr. Sharon, Gyrek, and all of them as fellows and now consultants. And hardly patient comes back to you exactly. If I see 6 patients walking into post-op tomorrow morning, it's very difficult to know which one of them had a Lasik and which one did not, which one had a spine. So patients, so if that is the thing we try to reach, it means that we have conquered pain, and the rest is, like Rishi sir said, that we don't have to worry about anything because there's no manual removal of anything. So there's no chance of infection or anything if the patients are keeping themselves clean. Thank you, Ritika, and thanks. A wonderful talk, and really happy to work with you on this particular thing, which became a very, very nice way of making people take PRK much more seriously than what they did. I'd like to call upon Dr. Arun, a good friend from Ajmer, and is going to talk about a very important topic about the post-PRK corneal haze and his way of addressing this problem. This is something which people keep asking about. Dr. Arun?
Yes. Good evening, everybody. Am I audible?
Perfect, sir. Perfect.
That's wonderful. Dr. Rohit, we tried using Acular LS instead of AccuVeil, and it didn't work the way AccuVeil used to work. I think we are again looking forward for this molecule which you're coming up with, or the Endor people are coming up with?
It should come. It should come early. If I asked them, they said this is going to be pre-Diwali launch. I don't know when Diwali is, but somewhere in November I know. So I think it should come before that.
Looking forward for that. It was a great breather. Okay, coming to the topic, post PRK corneal haze. Basically, stromal haze after PRK can appear either in the early period or it can appear in the late period. Both of them are subepithelial haze, and the early one appears after several weeks, and it remains for 2 to 4 months, and it responds to the steroids. If you increase the dose of steroid, you give the steroids for some time, this haze disappears. But sometimes the haze may appear late after PRK surgery, maybe after months or maybe after years, and usually it does not respond to steroids. So first, this is the grading of the corneal haze. It's available on a lot of places. Let's come to the top. Okay, so once you're doing a PRK, basically you're removing the epithelium, you're removing the Bowman's layer, and you are removing a part of the stroma, the variable amount of stroma, depending on the refractive error you are correcting. So basically there's an epithelial injury, there's a stromal injury. So once a stromal injury occurs, there's a precise remodeling of the stroma in the most of the cases, leading to a clear transparent cornea with no vascularization. But sometimes there can be improper healing, in which there will be a reduced transparency of the cornea and a compromised vision. Not only the stromal injury, but the epithelial injury also leads to stromal haze. So what happens once there's an epithelial injury? The inflammatory cells, they infiltrate. There's a apoptosis of the keratocytes, and there's a proliferation and migration of the epithelium from the site of the injury to the center, or sometimes the limbal, or from the proliferation of epithelial cells from the limbal stem cells. Now this apoptosis, just let me pick up a. So the apoptosis, it leads to keratocyte proliferation and migration. How it does is, so once there's a keratocyte death, the stromal cells get activated and there's an immune cell infiltration. Now these immune cells, they release cytokines in the form of transformation growth factor beta, which incites myofibroblast formation. Now these myofibroblasts, they're basically opaque. They form disorganized collagen and do not have a regular arrangement in the cornea. But over the period of time, these myofibroblasts, they disappear, and so does the haze disappears. And once the myofibroblasts disappear, the keratocytes move in. And these keratocytes, they absorb the disorganized collagen and glycosamine glycans. But sometimes these myofibroblasts, they do not disappear. There are too many of myofibroblasts, leading to the corneal haze. So what are the risk factors for the corneal haze? So it has been theorized that the more stromal ablation you do, there are more chances of stromal haze because there will be more inflammation. Again, small ablation zone is a precursor for corneal haze. Irregular surface. Now, if your surface is not regularly ablated, the chances of corneal haze is more. So here comes the role of smart surf. In the smart surf, the corneal surface is absolutely smooth, so there are less release of cytokines, the TGF beta, and less of myofibroblasts formed. Role of UV exposure has already been discussed. I'll not go into this. We have discussed this already. And then abnormalities affecting the epithelial basement membrane regeneration also causes corneal haze. Now what happens is these epithelial cells, they send these cytokines into the stroma, the TGF beta, into the stroma for myofibroblast formation. Now if the epithelium basement membrane forms, the cytokines don't cross, and if there's a defect in the basement membrane, more and more TGF beta will cross and will lead to more formation of myofibroblasts. And of course, we have seen that it is less with mitomycin C, which inhibits the keratocytes. The treatment of haze is basically, people have tried various things. People have tried corticosteroids over a very long period of time, and there has been some resolution in the corneal haze. People have used mitomycin C directly over the haze after denuding the epithelium. And what we have tried after consultation with Dr. Rohit is transepithelial PTK with mitomycin C. So why do we need to do a transepithelial PTK? Because we need a smoother surface. If the surface is irregular, if it is not smooth, there'll be again more proliferation of the myofibroblast. So what we need is a smooth surface. So it's better to do a transepithelial PTK. So here's a 20-year-old male who had fiber 60 vision before the surgery, and his best corrected vision was 6/6 with minus 3.75, and we decided to go in for a transepithelial PRK with mitomycin C. The tomos were absolutely okay. This is pre-op OCT. It was fine. Post-op was uneventful. Steroids were used for 1.5 months post-operatively, and they were tapered over 3 weeks. And last follow-up was 3 months after the surgery, wherein the vision was 6/6 in both the eyes. This was sometime in January. The patient came for follow-up. Then the lockdown occurred and everything, and the patient came back sometime in end of May with this picture, with corneal haze in both the eyes. Now, this boy was preparing for entry into some armed forces, and he used to go for running in the morning time. And that was like once the sun was rising, it was a cool time, but still he was doing his running and everything during the morning time. He was doing his exercise. He was training himself for armed forces. And this is the picture when he came to us 7 months after the surgery. His visual acuity was 6/60, and we started with steroids, but nothing happened over 3 months period. So then this was the post-op tomography after 7 months, when the patient came with corneal haze. And if you look at the OCT, you will find infiltrates or the thick opacities in the subepithelial region, which are very clearly available. And we measured this with the scale in the OCT, and it was measuring.
Sir, please, you have 1 minute remaining, so please wrap up.
I'm almost done. So this was 60 microns. So we did a transepithelial PTK. PTK depth was kept at 70 microns. Mitomycin C was applied 0.02% for 1 minute, and the BCL was applied. After the surgery, there was no haze, and his uncorrected visual acuity increased to 6/9. And this is what we saw post-operatively, 1 month post-operatively. The patient has been under a follow-up for 2 months, almost 2 months now, but it is too early to say whether the opacities will reappear or will not reappear. But what I'm planning is to keep this patient on steroids for a very long period of time. So in conclusion, the corneal haze is more oftenly seen with the treatment with high myopias. However, with the use of mitomycin C, the haze is less, and there are less chances of haze after trans-PRK, because there are less keratocyte deaths after trans-PRK or after apoptosis. Initially, try and treating with them with steroids. If no improvement, then perform transepithelial PTK, and followed by refractive correction if needed after 6 months. If there's any residual refractive error and if the thickness is good, you can go in for a refractive correction after 6 months. Thank you very much.
Dr. Rishi, or any?
I have a comment. I have had a few patients of haze, and my experience has been all the haze that you treat with the laser, it always comes back. So I feel there are some people who are just prone to develop haze, and they will, if you give them laser, they will develop haze again. So eventually, what I've started doing for these kind of haze is just give them long steroids, sometimes 6 months or more, and you'll be surprised how it actually goes away after some time. And if it doesn't, then you manually debride it rather than remove it with a laser. That's my experience, my limited cases that I've had haze in. Doing a laser again for the haze, actually temporarily you'll feel good, but it tends to come back.
Good point. And
well, the one question I have, Rohit, that so much of steroids everybody gives, and refuse said that 60% of your work is surface. You not encountered any steroid responder ever? And if you do, if you stop the steroid, what happens to the treatment and the regression, or anything happens or nothing happens?
So you do get steroid responders, and unlike Lasik, they are not easy to pick up if you're not monitoring the IOP. So it's very, one of the things that you get is a very subtle kind of a epithelial haze, and their vision drops a little bit just by one line or something, and they just are not happy with the vision. And if once you've seen it, you can always identify it. But in such cases, it's not necessary that you have to give long-term steroids. You can you shift them to tacrolimus. You can give very mild surface steroids at a lower dose. Keep it a little longer. So you can add anti-glaucoma medication.
One very important point Dr. Rishi said, which I keep telling it to all my residents and everybody, is that after PRK, we keep them on steroid, and the steroid responder in them is very slow. Unlike, slow means to pick up, because patients have been told that your vision is going to fluctuate for a long time. They don't come back to you when the vision drops. However, in a LASIK patient, because of the flap, there is steroid responders, there's a fluid collection, and suddenly it drops, everybody comes running back to you. And there is one major issue which I feel people have been talking about this patients who develop haze after 1 or 2 months. I believe that is 99% of them are later haze is developed by a steroid responder. What happens is, when you have a steroid responder, which you're not picked up, your aqueous fluid and all those fluid are very rich in creating scarring. He mentioned about TGF, beta, alphas, cytokines, because that's the fluid which comes out because of the pressure. And what happens is, when they are in the stroma, what do those fluid do? They just create an aberrant wound healing. And the scar, that's why you get those honeycomb-like scarring on the epithelium. See, if you look at the honeycomb, this is the earliest sign. After that honeycomb comes the stroma. Exactly same type of honeycombing happens in the stroma. In fact, I was telling my team in the lab that we should create a model to do this. And minute you see a late onset haze, this is a word I was thinking, late onset haze, 99% of the time, there have been 1 or 2 sudden spikes of IOP which mix up. So if you are asking your patients of surface, and what happens is, you keep treating, it keeps coming back, you increase the steroid, and you call him after 3 weeks, his spike will be sometime in between. It's not that it keeps always at 60 or 70. So keeping IOP as one of the major factors of the haze is very, very important. And this is a very nice point Dr. Kumar asked, and I think we all have to keep it. So you have to have a different way of calling them to your clinic just for an IOP check. And this is very important. I think we have one more small case, and after that we move on to the live wire planning. And this is a very interesting part of this meeting. Is we're going to have this software plugged in, and we'll have all experts here, and also we'll have Dr. Thomas here. So he's going to tell us about how we can use live wire, how we can use the software to plan different cases. These are all real cases. And we have the post-op outcome also of these cases. So we'll have a mix of live wire and the post-op outcomes. Just a small case about the reason ocular surface is what Dr. Arun mentioned. The ocular surface, all that dry eye, patient running in the morning, and all this, how it has an impact into the healing. Dr. Ritika is going to speak about this, a small presentation, and then we go to the next session. Dr. Ritika?
Yes, sir. Thank you, everybody. Good evening. And I'll be discussing on how does ocular surface impact healing. So it's a well-established fact that dry eye increases after the post-refractive surgery. A few of the complications of post-refractive surgery dry eye disease is that the patient complains of headache, glare.
Can't hear. Can't.
Hello. Hello.
Go ahead.
Go ahead, Ritika. Go ahead.
Go on, yeah.
Okay. Sorry. So after that, there is a increased high order abrasions. There is an increased chance of ectasia also in these patients. So I'll be discussing two such case scenarios. In the first, the patient is coming to the clinic. She has no complaints of dryness. She is not a contact lens intolerant user. The second case is that difficulty in working in AC environments is seen by the patients, and she is a contact lens intolerant patient. So we see the slit lamp examination, the anterior and the posterior segment both were normal. The tear film breakup time was normal. In the first case, the patient had a normal OSDI. And in the second case, the patient had an abnormally high OSDI. So how do we proceed with this case? Should we blindly go ahead with refractive surgery? So I'll be discussing upon these 4 points, that how the epithelium and nerves are related, how the tear solvent factors are related to the inflammation and pain factors, and how does it impact on the outcomes. So we see 3 sets of patients where we see that the meibomian glands are normal. On deeper evaluation, the confocal reveals normal nerves, and the OSDI is also normal. Regular epithelium is present in all such 3 cases. The next set of patients have a meibomian gland dropout. On the deeper level, the confocal shows increased dendritic cells, which are inflammatory cells. The nerves are also abnormal, and there is an irregular epithelium with a high OSDI score. So what happens if we start to operate on these patients? Our group has done extensive work on correlating the ocular surface with the dendritic cells, along with the molecular markers. And they have seen that the patients with abnormally high number of dendritic cells or abnormal nerves have a lot of inflammatory markers in their tears. So now if we operate on such a patient, what will happen in the first 3 sets of patients, there will be normal outcomes. But in the second set of patients, there will be an abnormal outcome. There will be abnormal inflammatory layers. There will be irregular epithelium. There will be an irregular VBUT score on the OCAS. So to summarize, what do we see? That a high OSDI score is an indicator for an unhealthy ocular surface. It should alert us that there is poor nerve regeneration in the patient, which will lead to poor wound healing and irregular epithelium, which in turn leads to a poor optics, and the patient complains of increased glare and halos post-refractive surgery. And this creates an unhappy patient and a poor quality of life. So I won't be touching upon the treatment profile as it's been discussed earlier, but thank you.
I think you covered up everything. I think this session has gone on wonderfully well. I think we have completely covered all aspects of PRK, starting with the kind of range, the astigmatism, you correct, the what to do pre-op, what to do post-op, and how does ocular surface help with all the cases. I think, and also controlling pain. I think we can't have a more comprehensive discussion on PRK than what we just did now. For the next hour or so, we have a very interesting session where we're going to connect the software. We have a software on the laptop now, and we have some cases. So I request all the panelists and all the people who are working on this to be involved in this. Thomas, you are here. We need your help in this part.
Yeah, I'm here.
Perfect. I think now we are going to plug your software in, and then we'll discuss. So we'll have a small set of cases, and then we'll move on to the discussion of how we can fine tune. So anybody has any questions on the software as we are planning, please ask. You can type it or you can just ask us so that we can completely understand. This is very rare to get Thomas free in this kind of a meeting, so it's best we clear all our doubts. So Pooja, are you ready with the software?
Yes, sir. So we'll start with a case of irregular cornea. Dr. Payal, can you share your presentation? Then I'll go to the live wire.
We start the plan is that we start with the case and then we go to the planning. So
Yes.
that unfortunately the software does not have a place where we can write all that planning part, all the about the case. Payal, quickly on the case, please.
Yes, sir. Is my screen visible?
No, not yet.
Share screen. Just do this share screen.
Yes, sir.
Yeah, Dr. Payal is our fellow in cataract refractive, and yeah, you can start your presentation.
Yes, thank you, sir. Good evening, everyone. I'm Dr. Payal Pandit. Today, I will be discussing about corneal customization prior to cataract surgery in irregular cornea. I'll be starting with a case discussion about a 31-year-old male who came to us with diminution of vision in his left eye since the past 6 months. Patient gave history of Lasik surgery done 3 years back. On slit lamp examination, the patient showed a cataract of nuclear sclerosis grade 2 with posterior subcapsular cataract. We advised the patient for cataract surgery. The patient was keen on spectacle-free vision post-cataract surgery. So we went ahead and did a pentacam for this patient, and we found that he had an astigmatism of 2.2 diopters with a decentered ablation on the axial map. Now, in the treatment of irregular corneas, there basically exist two schools of thought. One school of thought says that it is better to do the cataract surgery first, followed by a surface refractive procedure for the residual refractive error. However, there is a second school of thought which states that regularization of the cornea followed by the stabilization of the keratometric values allows for better IOL power calculation in these patients. In a small study that we did at our institute, we regularized the cornea first, followed by cataract surgery in these patients. We found that the residual refractive error as well as the visual outcome in the postoperative period was better for these patients. This is known as C3, that is corneal customization prior to cataract surgery. So how do we go about this? On the Schwind planning software, a target refraction of 0 was kept and the ablation map showed a maximum ablation of 82.41 microns with a central ablation of 73.67 microns. Now, as has been already discussed, there is a depth minimization option on the Schwind platform which allows us to decide which abrasions can be left untreated. This reduces the amount of maximum ablation, as we can see that after depth minimization, the maximum ablation reduced to 51.71 microns, with the central ablation reducing to 42.97 microns. This is particularly important in patients with irregular corneas, as these corneas are already thin. Now, the pre and post corneal customization difference map showed that there was a significant reduction in the astigmatism in the post corneal customization phase. Even in the EKR maps, the post-corneal customization, there was a change in the EKR 65 mean by almost 2.1 diopters, and the astigmatism also reduced, resulting in a regularization of the cornea. Now, what we did was we went ahead and calculated the IOL power for these patients after 3 consecutive EKR reports were stable, and we used the ASCRS post-refractive surgery calculator. Keeping the target refraction as 0, we use the EKR values from 1 to 4.5 millimeters zones, and we use the central corneal thickness from the pentacam. The biometry was lens star, and these values were incorporated, and we got the IOL power. Now, this IOL power was then used to calculate for the toric IOL using a Technis toric calculator. The postoperatively, the patient on postoperative day 1 improved to 6/8 with nil spectacle correction. So in order to summarize, in irregular corneas, it is better to follow an algorithmic approach. This allows for lesser chances of residual refractive surprises in the postoperative period. So a customized corneal ablation followed by stabilization of EKR over 3 consecutive visits,
followed by an ASCRS post-refractive surgery calculation, and then going ahead for a toric aspheric IOL was beneficial for this case. Thank you.
I think you can stop sharing and we can go to the same case, and Thomas can guide us how we could fine tune it better.
Yeah, thank you. So thank you, Payal. Can you stop sharing the screen, please?
Yes, ma'am.
Yeah, so I am sorry for I think there's a technical glitch. I am not able to play this particular case, but I will put on another case and sir, we can discuss on the same.
Play.
Yeah. So I think all of us are very well versed with how the software looks. I'm just going to import one scan. Yes, so this is a keratoconus patient. A lot of planning is going to be on the similar terms, and we can start on how we plan a keratoconic eye in a Schwind-IPCL software. So
I have I'll take over from here. I
Yes,
have a
sir.
question here, Thomas. There is something called as asymmetric offset. Okay, in this. Pooja, can you just put the cursor on the asymmetric offset? And
Yes.
that's a click button. And can you explain to us what is asymmetric offset and when you think we should? Most of the time, by default, it is always on. So when you by choice, when you take it off.
Okay. When we started with the Amari software, we only had the symmetric offset available. And the symmetric offset has the challenge that if you have an offset, you have to compensate for with a larger optical zone. You have to compensate this shift so that even if you shift this optical zone, that you cover the whole pupil area. So let's say if you have a pupil of 6 millimeter and you make a shift of 0.2 millimeter, you have to add 0.4 millimeter to overlap the whole area of the pupil. And then you need extra tissue to do that. And in order to avoid this, later on the asymmetric offset was introduced into the system, because the asymmetric offset behaves like doing a larger optical zone, but only cuts off the values above the pupil itself. Yeah. And so to say, throws away the other areas which are not contributing through the pupillar opening. And for that reason, it doesn't require that you enlarge your optical zone twice with the offset, which would be required in the symmetric. So it is a historical approach, this symmetric, which nowadays almost everyone and almost every time we are using the asymmetric offset.
Perfect. Let's go move forward now on this case. This is a case of
Yes. Yes, so it is a keratoconus patient of grade 2. When we start planning in the ORKCOM software, this is how the first screen looks like. Epithelium thickness has been looked over. Let's see, the patient's epithelial thickness is 55. Now, one thing what I think Thomas would agree with me is that the radius of pupil offset should be within 0.2 millimeters, because in keratoconic eyes, yes, there is going to be a mild variation, but here you need to be within 0.2 millimeters. Am I right, Thomas?
Typically, we use the radius which you really see on the diagnostic device. If it is more than 0.2 millimeters, then why not entering it? Yeah.
Yes.
For example, if the offset is 0.3, I would enter the 0.3 measured on the device.
So this is 0.27 here. So I go ahead with the same. So we click the PRK button here. We enter the refraction 0, just to see how much ablation is there at the 0.
Why would you choose 0 and not entering the reflection you have maybe measured halfway?
No, we want to know how much does the machine ablate? What is the higher order aberration the machine is ablating? for a particular zone we are treating. And sometimes we get it very beautifully when we are using a PRK model than even though I do a trans PRK, but this kind of an ablation pattern I get very nicely done on a PRK mode.
I agree.
For example, if I put a whole refraction, I will not know how much is the machine ablating for just as a higher order, because this is a completely zero ablation. I mean, there's no refractive error corrected. All we are correcting is only the higher order aberrations.
Dr. Rohit, can I just interrupt you? Dr. Shady's talk, he was mentioning that if you enter 0, sometimes it will ablate more than if you actually enter the refractive error.
The idea here is we are not burning 0. It's just to see that at 0 refraction, how much is it burning? How much difference there is in the center and the maximum ablation?
I get that. Yeah.
Okay.
But then if it is ablating lesser in that means it is compensating in some way.
So what Shady said was, Dr. Rishi, is he said he compared the corneal wavefront, what we are showing, with the ocular wavefront. And he compared both the technologies, and he was trying to compare which of them was actually giving him much less ablation compared to this. So we don't have a Pyramis now with us, so I have no comparison of how much the OW, the ocular wavefront, would treat. In this, we only have the corneal wavefront ablation pattern. That is the whole difference there. And for many people who are using this software, this is something which is very important, is to I always before I go to the manager, I always look at the summary. Yeah, the summary, there it comes there also, the software. In the summary, it's a very interesting feature which I always see, because in the summary, it tells you the amount of coma, trefoil, and spherical aberration, both in terms of microns as well as diopter. It is going to correct, or not correct. It's there and it's going to be corrected. For example, it's looking at it in terms of diopters. There's close to 3.5 diopters of astigmatism related to coma at 64 degrees, and a small amount of trefoil and very minimal amount of spherical aberration. And it also tells you what is a higher order aberration. At one shot, you know that you are treating a very highly irregular, highly aberrated cornea. The amount of your cylinder may be -6, of which I am assuming that a significant amount of that cylinder is coming from the coma itself. So, Thomas, would you like to say anything about this part?
You can further go to the Zernicke list.
Then you can go to the Zernicke list here. Not the manager, the Zernicke list, please.
Yeah. We see it also here. You can, this was, here you see which aberrations are really significant. And we see that there is a lot, and we see the relevance one. But just to have a glance at this, this is more in detail than the aberration summary and that the aberration info. And then if you go to manager, if you close it and go to manager, we have what we recommend to do here is start with the reflection first. And then the question is how much tissue you want to save. Are you happy with the 46 microns which you ablate right now, or you want to further reduce the tissue? And therefore we have a different starting approach. What we typically do is we enter from the beginning on the refraction, even if it is not trustable. We enter, so to say, the most trustable reflection in the patient data. And then we compare what is the amount of tissue we ablate with the higher orders and without the higher orders. So these two values, higher orders all or no higher orders, are important. If this difference is less than 10 microns, we typically go ahead for an aberration free. And then if it is more than 10 microns, we calculate a tolerance factor, which is maybe we can we can do it later on with this case.
I can do it now if you, I can just enter patient.
But Thomas, this case is irregular cornea. We will be, for what you're saying, we will need a regular cornea.
Yeah.
Because this you cannot, there is no way you can do an AF on this. This needs so what we'll do is we'll finish off with this and then we'll go to a normal cornea where you can discuss about the tolerance factor. Is that all right?
That's all right.
So this, because here we had to manager. And when you look at the pyramid, and then you can call, there's something called as minimized depth. Thomas, would you all like to say something about this, what it does actually?
Yeah, minimize and minimize plus. Minimize plus is more aggressive, eliminating or saving more tissue, and either you go for minimize depth or volume. Typically, but not always, typically the depth function is used for myopic and myopic astigmatism, and the volume for hyperop and mixed astigmatism. But you also find cases where you save more tissue if you go to volume, despite that he is myopic patients. So the ideal way would be to click on minimize depth and see the values, the results, and then click on minimize volume and see how much it changes. That would be the most optimum. But I agree, this is time consuming on the other hand.
What's happening now is it's growing live. So when Pooja clicks on it, it's actually trying to optimize. It takes a few minutes to actually do the whole minimize depth. And now you can see that it's a very interesting way. The machine has automatically taken off the one aberrations which it feels that it is not important to be corrected in this treatment planning. The one which is lighter shade or in gray are the ones which are not going to be treated. And you can see that the machine automatically is off the spherical aberration. That is, spherical aberration in this patient is not treated. So basically, to save the amount of tissue, it's only treating what it really needs to be treated as far as the vision is concerned. Am I right, Thomas?
Yes, and furthermore, it treats also the, so to say, green non-significant higher order aberrations which contribute to safe tissue. Because as we see, for example, the 8 on the right, on the right side at the bottom, yeah. So it treats even that. On this, sorry. So it treats all these higher orders who are contributing to safe tissue, even if they are in green. But for sure, it corrects all highlighted red ones and orange ones, because they are indicated to be relevant, as Dr. Shetty was already saying.
And you can also do it yourself in case, you don't need, if you are in a hurry and you can say that I just want to, how you can do it is one in green are the ones which are non-significant. Can you just show the ones in green? Yeah. Green means, yeah, the values, yeah. And the ones in red or ones in little orange are the ones who are significant. So all you can do is manually, you can keep all the ones in red to be treated. And once in green, you can just say that I knock it off completely so that you save tissue. So this is a very important tool. All Schwind users should really use this. This is something which is completely unique. And I don't think any other platform actually gives this flexibility to play around with this. And once you say okay, then you say okay, then you know this is you have treated, and then based on whatever refractive error you want, you can correct it. So do you have any other different way of doing it, Thomas? You want to put the refractive error here and then do that thing, or do all that and then go back and correct it? Does it make a difference?
In principle, we enter the manifest refraction like here from the beginning on.
Okay, yeah. So this is the manifest refraction. So should I go next step?
Yes, please.
Okay.
Yes, we know that this reflection is not really trustable, reliable, but it's the best reflection, the best guess you probably have in that moment in time.
So can I ask one question?
Yeah.
Sorry, sir. Can I just ask? Thomas, in one of your presentations, you talked about the vectorial calculation, and there are 5 parameters that you include in that, including the aberrometer refraction. Now, my question is for a person like me. You mentioned in that slide that instead of an aberrometer refraction, you can still use the autoref. Will using the autoref refraction that be still valid in calculation of the vectorial, the refraction that you have mentioned?
Yeah, it's by our experience, it's better than that. It is better that you use autorefractometer than nothing. Yeah, because right now we would like to check that you have the manifest reflection, and either the autorefractometer or even better the ocular wavefront reflection. And then we have the K reading astigmatism, and then we have the astigmatism from the wavefront at 3 mm and 6 mm. And out from these 5 values, we calculate a starting point. So it's not only relying on a manifest reflection, we also consider other refractions, because that might have an indication and implication as well.
Thomas, we have a question here. See, for example, let's see this. When I went to the summary, this patient has, can you put the, hold on here, just keep it. This patient has a -3 diopter of coma. The patient acceptance is -4. So when I, without even putting -4 on the machine would still treat the coma magnitude of around -3. Right?
Right, yeah.
So that means of the -4, a huge chunk of coma is coming from the coma. Now, how much do you think that I should be treating in this patient, knowing that the patient's coma is close to not minus, I can't know, I don't know the value of it, but it's around close to 3 diopters.
Yeah, I agree that the coma somehow can behave like a cylinder. Mathematically, there are 2 different things. But if you have this coma and you only look on a certain area, it behaves like a cylinder. And this might vary depending on the pupil diameter or an analysis diameter. So it's really hard to say how much of the 3 diopters from the coma are included in the 4 diopters of cylinder of the manifest refraction. So there is no formula what we would recommend or what we would have. So we accept this, that this is a cylinder, what you have measured. We accept that this is a coma, which are measured with the diagnostic device. And then we look on the ablation pattern. Because here above the cone, you probably have 67 microns. Can you click with the mouse at the center of the red ring of the ablation profile? Click. So we see we have here 67 microns, and that would be probably too much to ablate above the cone. Would you agree to that, or
Absolutely.
how do you see it?
Absolutely.
Yeah. So then the next steps brings us to the manager. And if we click on the manager, exactly, we have this constraints again, which we earlier have heard in a previous discussion. So this constraints of 0.88 sphere, 0.673, 0.63 is 1.25 diopters in the spherical equivalent. So this is amount, so to say, where the software now looks for another refraction, for another sphere and another cylinder and another axis, which is contributing to save tissue. So it allows another sphere to be 0.88 diopter plus or minus off from the actual value of minus 0.75. It allows a value of 0.63 diopters off a cylinder value, deviating from the -4 diopters in the cylinder. And if you click on minimize depth, for example, it makes a 5-step calculation. And let's see if it is already enough, so to say. We see already on the preview on the right side, the maximum oscillation is 51. And hold on for a second here. So using this default constraints, we end up with an ablation of 48 microns. So probably this is acceptable for ablating on the cone. If not, it might be that a larger sphere or a larger cylinder in the constraints will allow more tissue saving action. And now you see we have a change refraction, which is now in the preview, minus 0.19 with minus 3.27 at 62. So we're coming closer to that coma approach. And what I want to express it somehow, it automatically balances each other. And if you then say, just for OK, if you click OK, we have not touched the pyramid function. We just have modified the refraction. And now we see, if you click again on the center of the red, we see around 48. So you might decide, yes, this is enough, or no, we would further continue. We can go to manager. Don't do it right now. I just want to mention it. And we can go for the pyramid. So this refraction functionality helps to find a refraction which is far better to save tissue. You can do the same by entering, please click on patient data. You see here now in the manifest refraction, if you start from the beginning on with the minus 0.19, minus 3.27, instead of having the cylinder of -4 and the sphere of minus 0.75, you would have been immediately at that result. But you don't know in advance which sphere, which cylinder, which axis are the most effective to save tissue. And that's why we allow them with these constraints, or within these constraints, if they are activated, to let the software search for a tissue saving sphere and cylindrical value, because in such cases, the idea is to save tissue and to improve the visual acuity and not to be ametropia at the end.
Thomas, one question for you. The flow would be that you would do the refractive constraints first and then the pyramid, or you do the pyramid. Can you, Pooja, just keep going so people will know what's happening? Because they're all very, very important, because if you have a machine like Schwind, if you are not using this, then you're not using the machine to the full. So the whole idea of showing this case is to show that use the machine what is really made for. And this is what I think when I use the word customize yourself, this is how you customize yourself virtually on everything.
Yeah.
So I have started this case again. I have, so I think Thomas, you can, like Thomas and Sir can guide us, because.
So let's go say okay.
Okay,
right?
I've put the refraction if that's okay.
That's okay.
Perfect.
Okay.
Then we go to the manager. That's okay. 6 millimeter zone is what we usually consider in our population because our pupils are smaller. So go to the manager. Then say the minimized depth, right, Thomas?
Yes, I would go a step further before, just for a quick overview. It's
okay, I'll stop. I'll stop. Yeah.
Yeah.
Sorry.
Go cancel, go out, and click on the manager again. And now click on pyramid, just as an information. With all the higher orders, the maximum ablated tissue is 74 microns. And if you click on the higher order bar on the left side of the, yes, click there, say apply. And then we have the comparison between a customized treatment and an aberration-free treatment. So only aberration-free, correcting sphere cylinder, we would end up 65 microns. And having all the higher orders in, we can do it again, apply again. We have 74. So the difference is from micrometer wise, not that much, but the profile looks totally different. So this is always, we check before we start with the refraction. Now we go refraction. Yes, please. And decide for a minimized depth here. It's a myopic patient, so probably minimized depth is the best approach.
So basically, it is trying to find the best refraction which saves the least amount of tissue, right?
Right, right. And you see, now we have, remember, we have done this some minutes ago with a refraction which was plano. We did not enter it. So we ended up with another value. Here, entering this from the beginning on the manifest reflection, We have now the preview minus 0.99 with a cylinder of minus 3.37 at 67 degrees. Because we allow these constraints, this 1.25 diopters in spherical equivalent, to be deviated from the current refraction. If we would tick off all the higher order constraints, it would further go and save tissue. If we remove the constraints by clicking on sphere, cylinder, and axis, this checkbox before.
Thomas, that you've mentioned in your nomogram that if the tolerance factor is more than 3, that's the only time when you should remove the constraints. Am I correct?
Yes. So
otherwise, you don't need to go. You can go with the default constraints in most other situations, right?
Right. Yeah. Yeah. For the sake to demonstrate it, I would encourage to press Def again, because now he's looking for a wider range, so to say, from minus 12 to plus 12 or plus 7. He's looking for refraction, which is just saving tissue. Let's see what he ends up. It's also a matter how trustable your refraction is, which you entered your manifest refraction at the beginning. If it is repeatable, with different pupil diameter, or only a snapshot in that moment in time. I just want to make you aware how you can play with the software and go around.
So basically, every single time when you're doing a customized ablation, maybe 30 to 40 minutes of it, you can actually play with all these constraints, pyramid, look at the coma, what diopters of coma, how much is the axis. That's what I asked him. If the patient is having a 4 diopter cylinder acceptance and 3 diopter on the machine says that it's going to treat the coma, then how much cylinder are you going to use? That I think nobody has an answer. That is one of the reason I don't go for even if the tissue is good 500 microns, I usually go by only 50% of the cylinder, so that I know that other 50% of it roughly is your higher order aberration, which is going to take care of it. And if you are very more enthusiastic in treating the entire cylinder, you will end up with the refraction like plus 1.75 sphere with something else. You will end up in a hyperopic shift, which is terrible for a keratoconic patient, because keratoconus patients are okay with myopia, but they just cannot tolerate your hyperopia because it becomes too intolerable for them. So now we go to the pyramid now.
But first apply.
Pyramid. Then you do your minimized depth, right, Thomas?
Yes, yeah. And you see, we already have 44 microns. And looking on the image, on the preview, we can see that these 44 are above the cone. So that's already a good number to be below this 50 microns.
When should one choose minimize plus over minimize?
Minimize plus is a little bit more aggressive in saving tissue, and minimize is less tissue saving. For minimize plus, it looks only for the red ablation, as we see here from the coma, to save tissue. And now we get this 37 microns.
Minimize volume is when you're treating hyperopias.
Yes, typically, yeah.
Thomas, it's very interesting. The first time without doing the refraction modification, it was treating the SA. Right now, like it was not treating the SA. However, now it's asking us to treat SA. So
yeah, so probably it's borderline, not really significant, and therefore under some circumstances it is involved, and some circumstances it's not involved. If you click on it, it surely should make minor differences.
Thomas, this question is for you. Jerry Tang keeps telling me that don't treat essays in a keratoconus patient, because if you're treating essays, you're going to have a lower vision quality in them. And based on our limited work with adaptive optics, we have realized that essay in at least 60% of my patients if I treat SA on the adaptive optics, the patient vision, the keratoconus patient vision drops. So do you think that in a keratoconus patient where SA is not a contributor, it's not a major factor at all, because the cornea is already a curved aspheric shape one, do you think that we should by default keep SA off like what Jerry Tan says, or you still feel it's debatable?
I'm struggling with what you want to say with the essay, or you talk about the spherical aberration?
Yeah. In keratoconus patient, Jerry Tan says that he does not want to treat SA. Like Pooja just closed that essay. He clicks this off for every patient he treats for keratoconus.
And also 60 and 80, so the higher orders of the spherical aberration?
Yes.
And let's press apply and see how much it changes.
He says it's not about the amount of tissue saved. He says it's just that the quality of vision is better if you don't treat SAs.
Okay. Yeah. You see, we can learn there are plenty of factors. I heard this before, that sometimes the user are not using these spherical aberrations, but that at the moment we include them, as I said before. Not saying this is better or worse. It's just how Schwind is operating at the standard at the moment.
But most important, I want to take home point to all the Schwind users is, I mean, it looks a little scary in the beginning. It did for me, but it's the most wonderful thing you can have as a refractive machine. And again, I'm repeating this third or fourth time. If you're not used it or not doing it, please go back and use it. It's not as scary as it looks here. We are trying to make it look scary because we want to look smart. But when you go back and use it, you know it's nothing smart about this. I mean, there's no right or wrong, but Thomas has given us, we all learned from him. And then you say apply. This is one useful thing that, you can play around with this and okay. And then this is what you finally treat, and you can see that the central ablation here has come down to 26 microns. If you remember, the previous one, even without treating, we were actually at
37, around 37
to 40 microns. Here we are correcting a small amount of cylinder, a small amount of sphere with an axis, and then we are keeping a 6 millimeter zone, and we are only ablating 20. And then what I do in these cases is I go back then and press the transepithelial. Till now it's all in because I like the way, if you look at the transepithelial, you get this. I don't know. I don't like this picture. I like those colors. It gives me a much better. Now you go back again and press the PRK. So Thomas, that's the reason I did the PRK, because I like these colors. I know exactly where the cone is. I know exactly where the thing is.
I agree. Absolutely.
So now you go back to, but most important thing is, please do not press the button, say apply. So go back again to patient data, press the transepithelial, and now say okay. And that's it. I think this is the mode, and this is what you're going to treat.
As we have seen that above the cone that it was 40 something microns, would you increase the optical zone slightly, or would you check for the mesopic or scotopic pupil size, and depending on this pupil size then eventually decide to use a larger optical zone, or will you keep the 6 millimeter?
The answer is, if your patients are like countries like yours, or where you have a larger pupil, then we can increase the pupil size to as big as 6.5 or even higher. But we are very fortunate to have a pupil size of 2.5, 3 millimeters. So we are very fortunate that most of our pupil falls in that, and we are able to manage more with 6 diopters. But like you said, the bigger the zone, the better it is. But wonderful explanation on this, Thomas. Anybody has a question on this? Because after this case, we'll move to the presbyopia one, because this case explained everything. We can have 100 of these cases, but one case has got everything in it to explain. Rishi?
I have a point. I think your point of using the PRK rather than the trans PRK for the planning was fabulous, because I've always struggled, because those colors really confuse you and you really don't know where you're treating. And sometimes it gets completely masked You don't really know where it's ablating more unless you put the cursor individually. So I'm going to do this next time. Superb.
But please do not forget to switch it back, because we had it that someone was forgetting.
I have treated once on a PRK mode only, because all this thing was good, and then you suddenly, okay, now, but most important thing is, what I like about this is the summary mode. Go to the summary again. In the summary, I like many people don't use it because
green button, summary.
I looked the summary and I said, okay, what is the coma I'm treating? 3.3 diopters. What is the, this is the right one, you know. I like the manifest what the refracts. Now you're only treating one, Dr. Rishi. That means the machine must have assumed that, I don't know, the software must have assumed that a huge chunk of it is anyway going to be treated by treating your coma. So that must have, there must be some thinking in that, because now you're treating only one, which may be the patient's actual curvatural based astigmatism, not the higher order aberrations. So this is beautiful, I think. And trefoil is not very high, and spherical aberration is very low. That's high because we added some amount of refractive error, I think, now. And
just one question. Instead of the trans PRK mode, like you said, we'll do only the PRK. What if we manually scrape off the epithelium and then do only the PRK mode?
Because if you have a PRK, Nishant, why would trans PRK? Why would you do anything?
Exactly. So, but the thickness of the epithelium varies from the center to the periphery in an irregular cornea.
Yeah, but you can add that in your, you can really look at what is your average 6 millimeter one, and that's what you're going to add it.
Okay.
So we will show one more thing which we have done. We call it TREC, and this is an accepted paper, and then Nishant will show his experience.
One question. In the patient data, there is an option of post CXL. Now we tried doing the ticking on the post CXL and off post CXL. There is no change in the ablation depth. So what does it actually do? Like, what is the purpose of that?
Okay, the purpose of that is, if you want to ablate 50 microns and your cornea is not cross-linked, it's a natural cornea, then you need a certain amount of pulses to get this 50 microns. But suddenly you have a patient in front of you where you want to ablate these 50 microns, but this patient's cornea is already cross-linked, not a flash cross-link, but fully cross-linked. And then you want to ablate also 50 microns. If you do not activate this cross-link button, you will ablate, or you end up in an ablation which is maybe 12% less, so you end up with 45 microns only. Because if you activate this cross-linking or post-cross-linking, then the software adds automatically about 12% of more pulses, more pulses to compensate for a more rigid, a more harder cornea due to this cross-linking. Whereas the goal is always 50 microns to ablate. 50 microns either on a patient with cross-linked cornea or without cross-linked cornea. That's why the ablation profile is always showing 50 microns and not changing. But be aware, the difference is if you shoot it on a photo paper or PMMA or such material, you will notice a slight difference by about 12%.
Okay, perfect. Thank you.
So as mentioned, like some of the times your ablations can go beyond 40 or 50 microns in a keratoconic eye, and you wouldn't want to do that because it's already a weaker cornea. So our group has devised this technique wherever the ablation goes beyond your 50 microns, or if it's a localized or a very highly decentered cone, we can do a technique called as TREC, which is the trans-epithelial removal of your epithelium over the cone area. So what we do is first in the Schwind-IPCL software, we take the PTK cam mode. PTK is like a phototherapeutic keratectomy, but it's a modified one where you do a PTK over the cone area. So you go to this PTK cam mode, we take the AF mode, it has that. You take the corneal data into consideration. Even though you're doing a PTK here, you need the corneal data because you need your SCC check and a particular place where you want to ablate. So that's why you take your corneal data into consideration, and this is how you import your scan, and this is how the SCC check looks like. So now there are various parameters here. So let's see what should be the zone of your PTK. So I'll go back to this Phoenix software, which is of the Cirrus, and I'll go to the tangential anterior map, where I'm going to take the dimensions of the cone. So we do a right click, we go to the tools, we take the distance tool, and if you see here, this is your localized cone, how it is. We'll just go a bit more outside towards the steep zone, which is around 0.1 or 0.1 millimeters. And we measure from the long axis.
We are not able to view it, Dr. Pooja.
Pooja, it's not visible.
Okay.
Tangential map.
Okay, I'll stop, I think.
If it's there, anyway, I can also talk about it.
Nishant is talking about it. See, what we'll do is let Nishant talk about this. Stop sharing. Okay, you just quickly show, and then Nishant, you can take this, and then she will show it live. So
Sure, sir. So you want me to start now,
yeah,
sir?
Please start.
Sure. So just to continue with Dr. Pooja and what Dr. Rohit said, thank you so much, sir. So gone are those days where we have to do only C3R to stabilize the keratoconus. Yes, this have been proved with lots of papers, but are the patients really happy with only stabilizing the cornea? Because the next question is, how much of visual improvement am I going to get? So without any visual improvement and only stabilizing the cornea is not something which patients nowadays want with the refractive cataract surgeries which have come. So then comes the question of what can we do with the laser, that is the Schwind-IPCL. So it was so easy for me because Dr. Rohit Shetty has done all the papers, and I had to just see the right kind of patients which we had to select. Yes, there were these topo guided CXL, but the amount of ablation which the tissue had to be taken were much more. So just to say about the procedure in simple, I just go directly to the procedure. Yeah, there was a paper by Dr. Rohit Shetty and Dr. Pooja where they had told about the topo based removal of corneal epithelium for keratoconus. In short, they call it the trick. So this is a small video which they've done, which shows that I will be showing in detail. So there is an offset which is taken. They measure the cone horizontally and vertically. We measure it in the SEC check, that is the static cyclotorsion control, which is an amazing thing where the pupil center is always there. So with the pupil center, we can actually hit how much ever we want in the periphery with the offset. Then it is transferred to the amarus and the epithelium. So as I said, according to the base of the epithelium mapping, you can change it central and peripheral however you want. And I'll just show a detailed discussion on how the long axis and short axis is also done. This is just a small video to show that the amount of thinning which is present on the corneal surface is exactly how the ablation is going to happen with the Schwind-IPCL. So I'll just go to the case directly. Yeah, so the best thing is it's all other lasers will actually have to be straight while hitting in the pupil area. But Schwind is something where you can actually be in the center and hit in the periphery. So that is the advantage. You need not move your machine to the periphery to hit the periphery. So this is a small live video which I've taken. All you have to do is you can see that the focus is exactly in the center, but you can see that the ablation happens inferiorly if it is visible over here. Just that the amount of ablation which is there is around 20 to 30 microns, which I chose for this patient, which I will show you the pre-op and post-op pictures as well. And then we start the riboflavin. So my experience in this keratoconus with the trick. So this is, one second, I'm sorry. Yeah, so this is one patient who was a 25-year-old. So she had a constant eye rubbing and she had actually a sudden loss of vision. You can see that the vision is around 3/60. She had not had this problem earlier because her other eye vision was 6/6. So in her, this is the RGP trial where you can see with -5 cylinder with a base curve of 6.5, she was able to read around 618 only with an RGP. So as Dr. Pooja was starting to say, we take the tangential anterior of the map. So this is enlarged. We see what the K value is. And then you can see that the thickness is around 468. I keep a value above 450. So we measure it. After doing a right click, we measure both the axis, and the axis is then transferred to the Schwind-IPCL platform. So you have the long axis and you have the short axis. This is the ablation depth, which I am actually planning for this patient, was just around 20 microns. So I took the trans PRK mode, and the SEC is also definitely checked. So when it comes to the online platform, the Schwind-IPCL, you can see how perfectly it actually ablates only the area of the cone. We all know that while ablating, it actually flattens the surface. So this is how my laser is going to hit, which I showed you the video. And I'm just going to show you, this is the preoperative and postoperative. As you can see that the symmetrical index front shows around 9.34 preoperatively, and postoperatively within a month's time, you can see that how drastically it has come down to around 3.23. So I will definitely say that it actually works. It regularizes the cornea. Just make sure that the patient selection should be precise, and you will actually find out that the patient, I do not overpromise them by saying that your vision is going to be completely corrected, but definitely the amount of cylinder will be reduced, and their acceptance of either an RGP or a row scale lenses will be much better than it was than it is with only a C3R. Yes, Dr. Pooja, I think you can continue. Thank you so much.
Very nicely. I think you explained the planning about Trek in very like a nice detail. Dr. Rohit had to leave because he had another meeting to attend, and he's sorry about it. So does anyone have any questions about Trek or something? Because what we have seen is this is a beautiful technique, and the results, visual outcomes, your topo guided PRK with cross-linking and Trek are almost similar. So
I have a question. Everyone is talking of Trek.
Yes,
My
sir.
question here is, are we trying to say Intax is out? And we
Intax
don't
is not
suggest
out. I have a, so that's what, like the case I had shown and Sneha had shown, sorry, Dr. Nishant had shown, they're like very small, early, like, you know, not your very advanced cases, not your very early cases. In fact, what we do, sir, in your advanced cases where you would like to do Intax, we do a one-step procedure. Okay, I'll just, and we do a one-step procedure. We just do the Intax. We ask the patient to wait for a month. After 1 month, we see how the patient is doing. And if you allow me, I'll just quickly show one patient of Intax followed by Trek. So we do Intax, we wait for some time, and then we see how the results are. And after 1 month, we do Trek. So it's not Intax is out. See, if you see the map here, we have done an Intax ring. Like, you know, you can see the Intax ring very beautifully. We have not done a cross-linking here. But if you see, the cone has localized it, and it's a very small, tiny cone. So now what we do is we just ablate this cone over here with a Trek procedure, and we do a cross-linking. So we are not saying Intax is out.
Definitely. And yes, sir.
So my thought was, why would you do this after to get even Intax to stabilize takes X amount of time?
So we have done a couple of patients. We've been doing this Intax followed by Trek procedure for more than 3 years now. So we see 1 month is the maximum time you require. We have done sequential scans at every week, and we see there's not much of change in your cone location or size or shape at 1 month. And ideally, you shouldn't be allowing your, like, you know, you can't keep your keratoconus patient without cross-linking for more than that much time. So
I think Trek has a role where you don't want to do Intax, and it is an early cone where your thickness allows you to do use some amount of stromal ablation along with the CXL. So I think the indications are pretty different for Trek, and if you want to do it with Intax and Trek. So Trek is only for the initial cones which are decentered, so make it little, you know, regularize the cornea and gives them a better this thing, contact lens, and either contact lens fitting or spectacle corrected vision.
Absolutely correct. So the thing is, Trek we do when we don't have enough stroma to do your topo guided PRK. That is your first indication. So, or if your ablation goes above 50 microns, you would rather do a TREC, because your stromal ablation is only 20 microns in your TREC procedure. So that is one indication. If you're thinner cornea, like your cutoff for topo-guided PRKs would be minimum 450 microns. But if you have 420 microns, would you not justify your patient without doing a laser? So that's when, you know, even if it's 420 microns, we can do a TREC procedure. And the third thing would be in your advanced or highly decentered cone, what Dr. Kumar sir said, we would first do an intax. We would probably shift the cone a bit up, or, you know, we'll make the cone smaller, and then we'll again do a TREC procedure on that cone and then do a cross-linking. So TREC is one procedure which, you know, it's like a modified Creton's protocol. But Creton's protocol, you had a very big challenge that, you know, you could only do a centered PTK. Even if it was 70 microns, it was only centered PTK. No, however, Schwind platform, you can decenter it. And Hakim and the Schwind team, Thomas and all helped us in how you can, you know, you can localize your cone area, and, you know, you can just do the PTK on that cone area.
Like even in TREC, there is a particular amount you can decenter. So the way you said, if it is too decenter, that is where your intax is going to play the role in shifting it slightly towards center, and then maybe apply your TREC.
100%, 100%. So anyone has any other questions on TREC? Because we have a very important two small discussions remaining. One is the presbyopia planning, which all of us need. And I would like Dr. Kumar sir, Dr. Rishi sir, Mr. Thomas, all of them to give their inputs. And the next would be one very small talk on predictive modeling by our team led by Dr. Abhijit. So, sir, can we move to the presbyopia planning? Okay. So I'm again we will be doing a live planning only. There is no talk here. So, and we'll just discuss the practical aspects of the presbyopia planning. This is how your presbyopia planning station is on your Schwind Amaris software. So you have multiple treatment options here. One is your if you see the Presby type, first the model is biaspheric, and then there are various types of micromonovision, hybrid, and monocular, and Presby reversal. So Kumar sir and Thomas, would you please enlighten us on this, that what are the differences in each of this procedure? Why are they different?
Yeah, the monocular approach is the latest approach. And in principle, what's happening here is one eye is corrected for the far distance with no extra amount of spherical aberration. And the other eye is targeting with a certain amount of aberrations for the near and a little bit micromonovision also for the near. But remember, the far eye is like aberration free. If you click on hybrid, the far eye is in addition to the correction for the far distance, it receives a small amount of spherical aberration, less than on the eye for the near, but a certain amount for that. And the micromonovision is even more compromising, because both eyes then got a certain amount of spherical aberrations, not symmetrically. Still, the one for the near gets a higher amount of micromonovision, a higher amount of spherical aberrations. But in principle, the distance eye receives for the micromonovision the highest approach of spherical aberrations, and for monocular, it's just a plain aberration-free treatment. So that is in basic the principal difference between these three.
So just to summarize, like in the hybrid, you correct one eye fully for distance, but you just create a small bump, or you give such a spherical aberration that it is comfort, like it doesn't lose the depth of focus for near, the distance dominant eye.
Yeah, yeah.
Whereas in micromonovision, the depth of focus is in such a way that it compromises a bit for distance, even for your distance dominant eye. Is that the difference?
Yeah, yeah. So the near eye is in all three approaches, micromonovision, hybrid, and monocular, the same. The difference is only in the far eye. Yeah. And for, again, monocular is aberration-free, everything perfect for the far. The hybrid is adding a little bit spherical aberration, and the micromonovision is even adding spherical aberration more higher.
So if I have to choose one ideal treatment, I think it would be hybrid, so that the patient has good vision with the distance dominant eye for distance, good vision with the near dominant eye for the near, and he has good depth of focus to manage for intermediate as well.
Yeah, nowadays most doctors even choose hybrid or monocular, one of these two choices.
Kumar sir, do you have any preference in each, like do you have to add anything here or?
I thought it was dependent on the refractive error, whether you're treating hyperopia or myopia also.
That was my next question. So now, yeah, so okay, if you have opened up that question, so what would be your treatment of choice if you're treating a hyperopia patient? And what would be your treatment of choice if you're treating a myopic patient?
It's not so easy that you can say the hybrids, the hyperops will get the hybrid and the monocular is for the myopes. That's not the situation. The reality is very colorful and very mixed. So I know people or surgeons who really prefer monocular over hybrid and vice versa. And I see doctors who mix up both. Yeah. And at Schwind, we do not have a clear statement to use hybrid only for hyperops or myopes or something. We offer both opportunities and both has their value. So I cannot say hyperops for this or for that. That's not possible. Either hybrid or monocular.
If you can just make a small comment. I mean, I personally, I look at the demand, how demanding the patient is. If the patient is very demanding, a little type A personality, and I would go for the monocular treatment so that his distance is not compromised at all. In one of the eyes is perfect, and the other eyes, you have that intermediate. Yeah? And if they are, a pretty, not that demanding patient, then I would go for hybrid.
Okay, that's a very good point, sir. That actually, it's very useful. So I think next question what we have is, so okay, for example, this patient has the distance dominant eye right eye, which I've already entered. I've already got the corneal data. So the left eye, which is the near dominant eye, it chooses the target as minus 0.89. Mm-hmm. What data or why has Schwind kept this value as minus 0.89 for the near dominant eye as the target? And is there like even if, okay, let's enter refraction as +2 with minus 0.75, 0 degrees. Yeah, so even if I enter refraction here, so the laser is going to burn this much for the distance dominant eye. The near dominant, I cannot change the target. Can you explain us why is that, Thomas, and what makes us do this?
Yeah, for the classical monovision, we have about 1.5 diopters difference between the two eyes, and people accept this, but it's also bothersome to have 1.5 diopter difference between one eye and the other's eye. It offers some disadvantages, as you are more familiar than I am. But the micro monovision with half of this, indeed for this target is minus 0.89, is offering a very good compromise, so that almost everyone is accepting a difference between both eyes of 0.89, or so to say 3/4 of a diopter. And that's why the 1.5 was too much at the beginning when we early started. So we say, okay, let's go for the micro monovision, and that's how we ended up in 3/4 of a diopter, or minus 0.89.
Okay, so now next question is the micro monovision. As we said, like, it changes your spherical aberration in such a way that it doesn't, so it just changes the spherical aberration. There is nothing to do with your target with any of these modes, right?
Right.
Okay, so next let's, so, okay, before moving forward, just last one question on this page, the role of Presby reversal, if you could tell us.
Yeah. For the in the most cases, when the patient is not happy with the presbyopic treatment, it is either that he's not well enough for the near, or he's not happy with the far vision. If he's not happy with the near, you can maybe repeat this Presbymax treatment, adding again a little bit more spherical aberration with the Presbymax addition, or it's just that the focus, the overall focus can be shifted by a little bit myopization or myopic treatment of this eye. If the far distance is a problem, maybe we have to look if we have to shift his vision a little bit to the far with a hyperopic treatment. So the reversal is only for the ones who really not happy with the multifocality and with the monocular vision, where they, even with the glasses, adding extra for the near, extra for the far, who complain about headache or problems. So really for the patients who are not happy with the Presbymax. And this is in a very rare situation, at least by our experience. But in these circumstances, Presbymax reversal is offering the opportunity to reverse the Presbymax higher order aberrations in one treatment. So you need to know the original treatment parameters, you need to know the original optical zone, and then it can be inverted.
And I think here whatever you enter is also the initial parameters and not the current ones.
Exactly, yeah.
Yes, that's fine, okay. So what would be your next approach when we go to the treatment page? The zone and everything, yes, it would be a larger zone because you're doing a hyperopic treatment as well as presbyopic treatment, so a zone of 6.5. Would you advise us to change anything here on the aberration page or the manager page?
In the manager, you have activated probably all the higher order aberrations.
Yes.
Yeah. It might work, but it adds some extra risks because if there are some significant higher order aberrations which impair the visual acuity, then of course this votes for customized treatments. But as we already do a customized treatments manipulating the spherical aberration with the Presbymax approach, this combination of a customized treatments in conjunction with the Presbymax is not really advisable. Yeah. So therefore, I would suggest to switch off all the higher order aberrations. With the, if you go to the left, you can click on high O, yeah, HO, and say apply, and then they should be all deactivated. It makes now not a significant difference, but we see anyhow that the coma 3 + 1 is indicated as red. So this was only red, but as it looks like it was minor. Maybe it was just around the 0.5 diopters. Yeah. So our recommendation is not to use this wavefront, neither corneal nor ocular, if you go ahead for the aberration free. So keep it like off and say okay.
But what about the spherical aberration then? Because the whole point here is you need to modulate your spherical aberrations. And here if you, okay.
Yeah. So if you activate the manager, if you activate the higher order aberrations, and the patient would have some spherical aberrations, yeah, it might be that these spherical aberrations either add up to the Presbymax spherical aberrations or neutralizes the spherical aberration from the Presbymax. And then that's why in such situation, the patient outcome is unpredictable. That's the software allows it, I agree, but it's not advisable unless you are very expert, but Schwind typically do not advise this.
Okay. Kumar sir, Naren sir, or any other panelist, you have to add something to this, please? Or else we can move to the next topic.
That internationally, what are your results as far as plano patients with presbyopia are concerned? In my experience, myopic patients are not very happy because they tend to compare the vision with the nearsightedness that they are myopic with. Their hyperopics are normally anyway very happy. My question to you was, what is your retreatment rate which is published? Is there a high amount of retreatment? And another thing I've found is some patients really take time to adapt to this kind of treatment. So even if I do a presbyopic treatment, they're not immediately very happy like your Lasik patients. They take sometimes 2 to 3 to 4 weeks. And then they're happy, but they settle down after some time. So it takes them time. So is it something that is going wrong, or this is how it is accepted and this is how patients behave?
No, that's what we also experience and notice. We have the the wound healing we have, and in addition to this wound healing, we also have the neuronal adaptation. And this neuronal adaptation might take several weeks or months before it really is accepted, before you get used to this. So it might be that you take 3 months, 6 months before the patient is really happy with it. And in this time, he needs to be prepared that he maybe struggles and has some doubts. But we encourage you to make him aware from the beginning on that it's not best next week. It will take some months to get used to it.
Does a contact lens trial in any way help in micromonovision, or it doesn't help to tell the patient to get an idea of how it's going to be?
Yeah, mostly these contact lens trials to get some. Okay, we have to separate. A monovision test is advisable to see what is the patient accepting. You can start with 1.5 diopter difference, and then you reduce it to see if with 0.89, so 3/4 of a diopter is okay. This is something which is really, I would like to encourage you to do and to see, to get the feedback from the patient. But what is almost stopped is to use a multifocal contact lens, a soft or hard contact lens, to simulate this visual approach. Because even if you take this for this patient for the whole day, the time is too short to get adapted with his neuronal brain function. And that's why many do not use this anymore.
We do a blood tolerance test for all of these patients, and we give them it's not going to be too accurate, but yes, we do give them that this would be your power after surgery, and make them wear it for some time, sit in the reception and see how it feels. So that is one thing what we do for all our patients. And it's not just for 15-20 minutes, we give them a good time. So that is what we do. Anyone would like to add anything to this? Otherwise, we can move to our next talk, which would be the final talk for the session. Okay, great. So the final talk for the session would be by two of our colleagues, Dr. Abhijit Sinha Roy and Matthew Francis. So whenever it comes to refractive surgery, there's a lot of always a fear that what would be the post-operative outcome, and what will my patient land up into. So they both have been working for around 7 hours to build this model where they can predict the post-operative biomechanics and the outcome of the patients. And now they have built into a software, an artificial intelligence based software, which they'll just be giving us an overview on that, how it works and how can it be useful in our practice. Matthew,
hello.
Over to you. Yeah.
Good evening, everyone. So on the onset, thank you for having us here and letting us present. So we'd like to present our software called AccuCMX. This is a one-of-a-kind predictive software which can be used in clinic to calculate or to be exact, predict your post-op biomechanics after refractive surgery, even before the first cut is made. So we have a lot of indices out there which can be used to calculate your post-op pre-op biomechanics like CBI, TBI, SSI, BAD-D, etc. But all of these parameters are only, all these parameters can only tell you what your pre-op status is, what is the patient doing currently, but none of them can tell you what's going to happen once the surgery is done, whether the patient would go to an abnormal biomechanics or even end up with something like an ectasia. So why do we need this? So this is a patient, 26-year-old female who came for refractive surgery, and she ended up getting a smart surgery was done. She had all the right acceptable pre-op parameters, all in green, and then she came back with post-mile ectasia. And as you can see, the correction is also not too high. So how do we counter this? So what we propose is to have a predictive simulation, which is based on finite element modeling, which is going to be patient-specific and surgery-specific at the same time. So we take the corvus and pentacam information for the patient and develop a model. And using the model, we are going to predict what's going to be your biomechanics after surgery using a surgery-specific model. By surgery-specific model, what we mean is, so our interweave collagen fibers, which give the strength to the cornea, we can actually emulate what is going to happen during surgery in those cornea in this virtual model, which is going to be built using your pre-op corvus and pentacam data. So in a PRK surgery, you are typically doing the surgery at the zone 1, as is shown in the center figure. And in LASIK and SMILE surgery, you would be typically targeting zone 2 of your cornea. And these regions have different collagen fibers with different strength and interweave structures, resulting in a different biomechanical output after surgery. Plus, in the region where you have the flap or the cap, it's observed post-surgery that the cornea, the Bowman's layer kind of crimps, indicating the collagen fibers crimping after surgery. Taking into account all these effects that we see post-surgery, we can virtually incorporate all this into the model to predict what is going to be your post-op biomechanics. So all this, how the model is done with a test with 36 patients was done and was published in IOVS. And then we moved on to verifying this data set using much larger number of patients. So in this, we are presenting a results what we found for a set of 200 patients, where we got an interclass correlation coefficient of 0.95 or 95% agreement with what you ended up with in vivo case. So the prediction had an excellent agreement with what the patient ended up with after surgery. So how does this translate into the clinic? So a patient gets his basic pre-op workup done, and then using the predictive model, we can actually predict what is going to be his biomechanics, and then compare this biomechanics to whether it's going to be in the normal range or if it's going to go beyond the normal range and end up having problems. So this predictive tool gives the surgeon the capability of having n number of virtual surgeries in the clinic before the actual surgery is done. And next, I'm going to demonstrate how the software works, and I can show you how simple it is to actually do a simulation in the clinic. So the software is the first tool that can actually do a predictive modeling, and it has the capacity of predicting your post-op biomechanics. It's surgery specific, and it can give you an idea how your cornea is going to end up after surgery. So this is all the team that has worked on with the development of the software. Now I would like to show you all how the software looks and how it works. So basically, when you open up the software, this is the window that shows up. The window has all the information of a patient which has been simulated before. You have all the pertinent information about the patients here. And this particular software is developed as a modular software. So right now we have the refractive surgery simulation module added. We'll be adding and developing the software with more finite element based modeling techniques and artificial intelligence based technique as and when we move on. So right now we have the refractive surgery simulations, and you can see a lot of simulation has been done. So I'll go to the refractive surgery simulation window here. So as I said, we only require the pre-op corvus and pentacam information. So you can add the corvus and the pentacam information like this. And then once you give all this information in, you can start simulating a surgery by giving in what are your flap cap thickness, flap cap diameters, your optical zones, the spirocylindrical correction you're planning, and even in the epithelial thickness. So here, as the day progresses, all of you have heard how important the epithelial thickness is and how well it plays a role in your post-refractive outcomes and things like that. Biomechanically also, there are a lot of importance to this. So we have understood that, and we have added an added feature of having a customized epithelial profile that can be added to the simulation. So right now it can read the MS39 epithelial map and actually do the simulation based on this non-uniform patient-specific epithelium. So the software gives you a lot of customizability and a lot of ways by which you can actually get the right predictions for your patient. And once this finite element part calculates a prediction, the prediction is further adjusted using an artificial intelligence model based on more than 200 patients. So this particular database is growing every day. We are adding more cases into it to give you the best prediction possible. So I'm just going to show you how a simple simulation can be performed. So the first step is to add your pre-op information. So we're going to just click on the select Pentacam HR CSV and then just go in and select a particular information. So we're just going to select a patient elevation data, and then we are going to select a Corvus measurement for this particular patient. So once you select both the information, you can see all the pertinent information about the patient has been automatically read by the software and has kept all the information here. And then once you have the particular patient details entered, you can start giving in the surgical parameters. So I have selected smile here for the first run. So first I'll give the flap cap thickness, the cap thickness as 110. I'll use a flap cap diameter of 7.3. I'll use an optical zone of 6.0. So let the correction be -3 and -1 for this patient at 30 degrees. And then I'm going to select a uniform epithelial thickness of 53 microns. So once you have given these details, you can click on Add to Process Queue. So this particular software is built around a philosophy of not having an operator watch over the whole simulation. This has to work independent of the staff. It has to work independent of the clinical outflow. So once you add this process onto the queue, the software takes over and it does the rest by itself. And once it's done, it exports a result into the results recall section, and you can view the results after once everything is done. So you can add n number of runs to the queue and get the results at the end of the day or the right next day. So all the patients you would like to be simulated can be added into the queue, and every results can be viewed at the end of the day. So if you're selecting like something like a PRK surgery, again, you won't have the flap cap details there. Instead, you will directly give the optical zone, your spirocylindrical correction, and your thickness, uniform thickness if you are going for uniform thickness. If not, you can click on the customized thickness and select the CSV file export, which is directly exported by your MS39 software here, and you can use that for assimilation. So once everything is done, all your results comes back to your results section, and you can select one of your results and just hit export, and all your results will be exported. I'll show how the results are exported and basically what outputs you get out of the software. So right here I have a report for a patient who was was simulated to have a smile surgery with a correction of 5.7 diopters per, -1 diopters cylinder at 30 degrees with a flap cap, cap thickness of 110, diameter of 7.3, and an optic zone of 6.0. So the report actually has two sets of information. First is comparing what the pre-op and the post-op values are with respect to the population. So as you can see, this yellow is the distribution of all of the data, the data that is stored inside the patient for the normative database. So, and then the green is the distribution for the post-op stiffness, corneal stiffness. And then the software gives you how your patient compares to this normal population in these two black lines, the pre-op and the predicted post-op. It also gives you the change from the pre-op to post-op. So this change is very relevant because suppose a software tells you somebody is after this so-and-so correction using so-and-so surgery has a change predicted of, let's say, 20 Newton per meter. And in the post-op, he's showing up to be 30 or 40, then you know for sure the patient is going out of this normal range. And all the predictions come at the confidence interval. So you can know what is your normal range for this patient in the post-op once the surgery is done. And then the patient can be followed up accordingly. Before surgery itself, you will know what's the range the patient is supposed to end up, considering everything, the whole healing process in the entire biomechanics has gone according to what was the plan, then what is the normative range the patient is supposed to end up. If there are deviations, that's when you have to start worrying about that particular patient. So the report gives you what was the pre-op corneal stiffness is, what is the predicted post-op stiffness with the range, and what is the change in the biomechanics the patient is going to end up after the refractive surgery. So we have reports for Lasik and PRK surgery. In all the cases, every result is shown with respect to a population data for a better understanding of how the patient shows up after refractive surgery. Over to you, Dr. Pooja.
Thank you, Matthew. Thank you so much. So basically, what I think the speaker, also the delegates, speakers, and attendees would like to know is, if you have this software, you don't need to do any mechanical data or anything. You just need your pentacam and corvis. You don't need to feed in. It's automatically incorporated backhand. And it runs their simulations, your finite element modeling, which also incorporates a lot of laser ablation profile and everything into consideration. Yeah. And after that, it gives you a prediction that what will be the outcome and whether it's safe to do a surgery or not. Yes. And as it is artificial intelligence based platform, it is much more stronger than just having 2 or 3 patients. That's what your software will do, right?
Yes. So it's a combination of having a predictive model and an artificial intelligence in the same thing. And it's a very sophisticated finite element model, and none of the complexities are shown up. It's as simple as filling 7 columns and selecting 2 buttons. And the entire simulation happens for inside the clinic. It will work on any computer, and it's made in such a way that it will work in the clinic without having a very dedicated operator or an elaborate setup to do this.
And you don't need to be by the computer. You just enter the data, you can do your OPD work, you can go do your surgeries, come back, and that will be ready. So what would be the minimum time your report can be generated? Because that's most important for the clinicians.
Yeah, so a typical case with if the minimum system requirements are met will finish in 1.5 hours.
So while we are doing other tests, it will tell us which surgery to do. Perfect. So, and it can be used for any laser platforms. It is just not for your Schwind.
It's customized for basic spirocylindrical correction. There will be slight variations from machine to machine on the profiles. Unfortunately, the exact ablation profile from machine to machine is actually a trade secret for the companies. But the simulation has the AI inbuilt to take care of some of those unknowns and some of the unknowns of surgeries.
Yeah, because if the ectasia has to happen, it will happen irrespective it's Schwind, Alcon, or your Visumax Smile. So basically, if you have your refraction, if you have your pentacam corvis in today's date, you can have your report. Okay. Yes. Thank you very much, Matthew. Thank you for I should not say we are waiting, but I think a lot of them would be waiting for the software to be
there. I think, Matthew, that's the next thing. Everyone's going to be asking when it's going to be available to the clinicians. So what is the timeline we're looking at?
I'm happy to say that first installation is happening. And so it's more, I would say it's very closer. Very soon, all of you can have the software in your clinics, and
no more futuristic thing. It's there with us very soon in our clinics. That's great.
Help you with your surgical planning and your post-op assessments. It's very soon. It's now. The time's now.
Thank you. Thank you so much, Matthew. Anyone has any questions regarding this? I know we are running a bit late, and we have kept you stuck to your chairs, and thank you for thanks a lot for waiting and being a part of this webinar. If anyone has these questions, we would be happy to have, or else if not now, you can email us, one of us, or you can text us, or you can WhatsApp us, and we would be happy to answer all the questions on whatever is discussed today or regarding the software or anything. And Matthew, can you stop sharing the screen, please? Okay.
So if there are no further,
we would like to
questions.
Yeah. So I would like to thank Thomas, who's here, Kumar sir, Naren sir, all of them, like other Dr. Shedi Awad, and most of the eminent faculties who have been part with us today, for all their contributions, their discussions, and their tips and tricks on how we can utilize this machine the best, and we can have the treatment better and customize. Basically, customization was today's highlight. So I think Dr. Rishi sir, Dr. Kumar sir, Nishant, Natasha, Sharon ma'am, Dr. Naren sir, all of them are here. Quick final word, and we would end this webinar for today.
Yeah, any take-home points from everyone? Dr. Kumar, Dr. Sir, any take-home points for the audience?
The take-home point will be that after 2-3 months, you should have one more webinar.
Sir, I think people will start. I know Schwind is like your Schwind and IPCL are such topics that you cannot cover it in a day. So, and there is so much left, I think, still to cover. But I think we have to let this session end today. Otherwise, people will not come for our next.
No, this is quite
Thank you so much, Thomas. Thank you so much for coming and being there for all the sessions and for giving us a lot of tips. I would be very frank that we learned a lot regarding the TCAT as well, and from other PowerPoints of laser. So thank you so much.
I think we really had a great session. Thank you, Thomas. There were, I mean, so many attendees. We've had more than 150 plus people, you know, international from different parts, Japan, Sri Lanka, so many places, 800 plus participants who've been there through the evening. So it's been really wonderful, you know, so much of learning about different things, small points, which definitely will improve our, both our clinical judgment in choosing cases and how we manage these patients going forward. Thank you very much. Thank you so much for your time. Anyone else would like to add something?
Yeah, thank you very much for arranging this. It was a lot of background work, I'm sure about this, and a lot of work to arrange all this agenda and bring the speakers together. Thank you also from our side, from Schwind's side, from my side. It was very interesting, and you made a very excellent work, all of you. Thank you.
Thank you. Like Dr. Kumar said, I think we'll need one more webinar soon just to reinforce what we have learned today, and that we don't forget and start applying and come back with our results. Thank you very much, everyone, for staying up till the end. I think we have had a good marathon run, starting with the imaging to ending with imaging and the future modalities which are going to be in the clinic pretty soon. I would personally like to thank Thomas for making it so simple and making it so encouraging. A special thanks to Dr. Rohit. He has been absolutely brilliant and amazing, and he's been very, very active all throughout. I don't think he's taken a food break as well.
No, he's still in another meeting.
Yeah, it's incredible. The stamina that man has is just absolutely incredible. It's very, very inspiring. A personal thanks to Care Group for arranging this and bringing such amazing technology to our doorsteps, right into our houses. It's just absolutely brilliant, the efforts that you guys are taking to making sure that customization is being made available to everyone. So thank you, Care Group. Thank you, Vipin. And I've been texting Hakeem over this, and we have been having constant messaging through what else can be done, how can we implement this into the clinic. So it's just absolutely amazing. Congratulations, Care Group, for this wonderful, wonderful session.
I would personally again like to, we from NN Narayan Netralaya would like to thank again Mr. Vipin Duggal, Sanjay, and the Care Group. for arranging this, for being a great support, and bringing all of us together once again.
Yeah, there's Mr. Vipin.
Yes.
Thank you so much, everyone. That Rohit, it is only you and only you who can have 6.5, 7 hour session and still have 700 people participating. Thank you, the entire team of Narayan Nitralaya. We love you all. Thank you so much. Thank you all the participants. Thank you our users for trusting us. Thank you, Thomas. Thank you, Dr. Bianchi, for getting up at 4:30 in the morning. Thank you, Pavel. Thank you, everyone. Thanks a lot. Thank you. Bye-bye.
Nishant, we forgot you, but thank you for joining us and for all the contributions. Thank you, Nishant.
No, not forgotten. Thanks, Nishant. Thanks. Very well presented. Very well presented. Chalo, shall we call it a day?
I think.
Bye-bye. Bye-bye. Thank you so much.
Thank you so much.
Bye-bye.
Thank you.
Thank you. Goodbye.
Thank you.